Mainly. No, no, no. For others, whoever wants to print. You're keeping yours. Do ಬಯೋಮೆಡಿಕಲ್ದು ಬಯೋಮೆಡಿಕಲ್ ಲಿಂಕ್ ಬೇಕು ಮೊಬೈಲಲ್ಲಿ ಕೊಡೋಣ.
ಅಲ್ಲಿ ಕೊಡಿ. ನಮ್ಮವ್ರಿಗೆ ಅಲ್ಲಿ ಅಲ್ಲಿ ಕಂಟ್ರೋಲ್. ಅಲ್ಲ ಮೊದಲೇ ಪ್ರೆಸೆಂಟೇಷನ್ ಓಪನ್ ಮಾಡಿ ಇಲ್ಲಿ ಪ್ರೆಸೆಂಟೇಷನ್ ಮಾತ್ರ ಓಪನ್ ಮಾಡ್ತಾರೆ. ಸ್ಪೀಕರ್ ಯಾರಿರ್ತಾರೋ ಅದು ಪ್ರೆಸೆಂಟೇಷನ್ ಓಪನ್ ಮಾಡ್ತೀನಿ. CV ಎಲ್ಲ ಅಲ್ಲಿಂದ
ಅಲ್ಲಿಂದ ಇಲ್ಲಿಗೆ ಬರೋದು. ಸರಿ ಸರಿ. ಅವರಿಗೆ ಇದು ಫಾರ್ವರ್ಡ್ ಇದು ಬ್ಯಾಕ್.
ರೆಡ್ ಪಾಯಿಂಟ್
ಇಲ್ಲೇ
check one, test, check 1 2 test, check hello. Check, check, check 1 2 1.
Because
Yes.
we memorize your people,
Yes.
otherwise you can't. Because it's important talk, initial talks and all. Maybe 10 minutes we wait, 5 minutes.
Yes,
Huh?
10 minutes.
You can just send Nagali, no? This round people out.
Fine. No? Yes. Start. Good morning, everyone. On behalf of Department of Neurology, NIMANS, it gives me immense pleasure to welcome our distinguished guests, delegates, and all the participants to Advanced Stroke Care CME Essentials of Stroke Care. Stroke remains one of the leading causes of death and long term disability worldwide. Timely diagnosis, evidence based treatment, multidisciplinary care are essential for improving patient outcome. Today's CME has been designed to provide practical updates on acute stroke evaluation, imaging, intervention, CVT, and secondary prevention. We thank all our speakers and all the participants for joining us here today. Let's begin our scientific program. The first session is on hyperacute evaluation and imaging protocols. Our first session focuses on early recognition of stroke and role of imaging in guiding acute treatment. Our first speaker is Dr. Raghunandan Nadik sir, who will speak on clinical diagnosis of stroke. He is a professor and head in Department of Neurology, St. John's, with interest in acute stroke management, thrombosis, and neuroimmunology. We welcome you, sir, for the talk.
So good morning, everyone. At the outset, I thank Dr. C. Jitesh and Department of Neurology for hosting this. I know in the morning first talk, people have yet to join in. I think there are residents here. So it is a basic, very basic talk for the senior people. But my job is to know this is not like a traditional neurology where assessment of an acute stroke. So where you take detailed history, you make a hypothesis, and you have a differential diagnosis, you discuss and then plan management. So acute stroke has, when we were undergraduates, postgraduates, MD, it has totally changed. So it is a teamwork and everything has to happen simultaneously, parallelly. So that's what we are going to discuss. And I'm going to give you a few basic concepts, how we evaluate and manage an acute stroke. So what are the objectives of my talk is rapidly identify the signs and symptoms of stroke. And some basic knowledge, I think all neurologists or even MD medicine should know efficiently perform a neurological examination, not the classical like how you do higher mental function, cranial nerves. So there is something called as NIHS, all should know and then get certified and interpret neuroimaging to differentiate between ischemic and hemorrhagic stroke and determine the patient eligibility for acute reperfusion therapy. I think this is the main goal of my talk. As we all know, the WHO has defined stroke, a clinical syndrome consisting of a rapidly developing clinical signs of focal or global disturbance of cerebral, brainstem, spinal cord, and or retinal function lasting more than 24 hours or leading to death with no apparent cause other than vascular origin. Some people may die suddenly, like in SAH. They may not be there for 24 hours. It still be considered as a acute stroke. So any neurological deficit due to a vascular cause which persists for more than 24 hours or at least 24 hours, we can call it to be a stroke. So when you see a stroke patient, so these are the questions one should ask and then has to answer. Does this patient have a stroke when they come with a neurological symptom? And if you think it is a stroke, what type of stroke it is? Is it a ischemic or a hemorrhagic stroke? This is what we are going to answer and then do evaluation. If it is an ischemic stroke, what is the underlying mechanism? So that is called mechanism of stroke. So like MI is only, you'll have an thrombus and then they have a heart attack. But stroke is not like that. Even if it is ischemia, there are various mechanisms and the management differs. And next question, if it is an ischemic stroke, is there a significant penumbra? So that is the more, so we have to save neurons. And that is what we plan imaging and all. And is there any evidence of large vessel occlusion? Okay, this are, then the last is what is the reperfusion strategy can be employed. So this, I think, as a strokeologist or any physician, if these ask questions and then look, I think we may reach the answer. So always this has to be done in the first few hours. Now, before going to that, so just for refreshing, commonest stroke is ischemic stroke. and hemorrhage is about 22, 25, 30 maximum, but majority is ischemic stroke. So this is an old, there's one, I think you can remember as so nearly in ischemic stroke, majority are more atherosclerotic, lacunar, cardioembolic, cryptogenic. I'll come to the classification. So this is based on a TOAST classification. This is the mechanism of stroke. So TOAST is stands for Trial of ORG 10172 in acute stroke. This is way back in 90s, late 90s they had done. So this is what large artery atherosclerosis. Atherosclerosis or thrombosis there, which can have. Second thing is cardioembolism. Third is small vessel disease. That's what we call as a lacunar stroke. And other determined etiology, like you have patients with Apla syndrome or you have a hyperhomocystinemia, so vasculitis. So that is the other known cause. And undetermined etiology. Sometimes you can have patients with atrial fibrillation who comes also has diabetes, hypertension, has small vessel disease. So undetermined etiology. So they can have two mechanisms. So always at the end of the day, when your patient comes with stroke, you maybe have to classify patients, at least before discharging, you should be able to classify the stroke and it should be mentioned because the secondary prevention is entirely depend on this management, this classification. So now coming to the ischemia, as I mentioned, so ischemia can be further divided into a thrombosis, embolism, and decreased systemic perfusion. Okay. So thrombotic stroke usually happens stepwise with periods of improvement. So like what we earlier used to call stroke in evolution. Okay, so somebody comes slurring of speech, after some time they notice some hand weakness, they progress for few minutes to an hour. Usually it is a thrombotic. Embolic strokes is sudden in onset with maximal deficit at the beginning and it can improve. And usually it happens when they are doing activity, when they are with coughing, sneezing. You should be able to ask when, how it started. And the mechanism is the thrombosis can have an unstable block, thrombus formation, and you can have artery to artery embolism. Or usually if it is in the same territory, then you call it as an artery to artery, but usually cardioembolic will be in different territory. But it's not a single rule. If it is a large thrombus from the heart, it can occlude one of the main vessels. And next thing is the embolic source can be anywhere, right from the atria to ventricle to the arch of aorta. So embolism potential and the different types of embolism can happen. You can have a infective endocarditis, a mural. So those things are not common, but these are the different types of embolism one can get it. And this is the another common thing what we see in elderly people who have a carotid artery stenosis, asymptomatic. They develop systemic infection, sepsis, or if they have any dehydration, they come with strokes in the watershed zones or patchy infarcts, or somebody has got a hypotension prolonged. So hypoperfusion. Okay, so this is another mechanism, especially in the patients with cardiac failure after an MI, they can have a low output and they can develop this type of stroke. So this is a different mechanism. Here, your anticoagulation, antiplatelets may not help immediately to reduce. So you have to improve the perfusion and look at their vessels, how they are. So that is why answering these questions is very, very important when we are evaluating an acute stroke. This is continual. So always you should remember time is brain. I think time is money, from that is where we have come. And then time was the muscle. And then we should remember time is brain because the core, whatever time, I think within 3 minutes, nobody can reperfuse. So the brain neurons will stop dying if there is no oxygen for 5 minutes. But nature has given a lot of reserve and collaterals. So for a given functions, we have millions of neurons working. So if you can save neurons, definitely the patient's function will improve. So as this is the core concept, one should know. So whenever there is an occlusion of a blood vessel, okay, so there will be a core. Okay, the core is going to die. So surrounding that area, that is called a penumbra or an umbrella, where there is a perfusion defect. Patient, if you don't allow that, that is going to die. That the core is going to get enlarged. And there is a region of reduced blood supply and then the healthy tissue. So our main role, see, whatever the neurodeficits you get is because of both penumbra and core. So whenever the blood circulation, normally we get up to 55 ml per kg per 100 gram of tissue is the brain. Whenever it comes below 30, you start getting some TIA symptoms. If it goes below 8, then that tissue is going to die. There is a gap of 8 to 30 where the neurons have not died, but they are at risk. That is the main role of a neurologist or whoever is treating stroke, to identify that so that we can save. If you leave, I will come to that, the core is going to enlarge. Okay. So what one should know is every minute lost. This is all done in uh, primates and all. It's not a human data, but it's all done in the animal models, and it is found that nearly 2 million neurons are going to die each minute. Suppose you have 3 minutes, you have come within 3 hours is the cutoff. If the patient comes you don't at 1 hour, it doesn't mean that you have time till 3 hours. Okay. So always remember every 3 minutes is delayed. One of the each 100 treated patients will have it. So this is, I think, if you can remember, if one stroke will increase their mental age by almost 3.5 years. Okay. And time is very important. So whenever a stroke patient comes, you are in the emergency room or in the OPD, it so happens in the OPD patients, we are sitting, they'll make card and wait. When they come inside, we'll ask, they have symptoms. When it started, morning. So I always tell the patients, if you have chest pain, you go to the hospital, you go to the emergency. Why don't you go for any dizzy feeling, weakness? Why do you think? So this is the common, I think we have to educate, and we have to educate our people who register there, because they would have told what problem they will register. So I think that is where I have many patients like this in the OPD waiting from morning 12 o'clock. They would have come and registered at 9 o'clock. We see them at 12. They will ask 7 o'clock, we started symptoms. So the time is lost. So the most important thing is door to physician should be less than 10 minutes. Okay, and door to stroke team is less than 15 minutes. Door to CT initiation is 25 minutes. Door to CT interpretation is 45 minutes. Door to drug is 60 minutes. And now we have the door to needle puncture is less than 90 minutes. So if you are planning for a thrombectomy, and door to stroke unit admission is less than 3 hours. So these are all quality indicators. One have to try to achieve this. And it is found that if you do this, the outcome of the stroke patients are good. So this is all that if you are busy, there should be a red pathway in the emergency room, like patient who has come with an acute stroke, there should get activated so that somebody takes care of it. Coming to the case, we'll have a case and then we'll go how we did it. So this is a 50-year-old gentleman. This is during the COVID, brought to the emergency at 12:15 p.m. with difficulty in speaking and right upper limb and lower limb weakness. We'll see how to manage these patients. Okay. So by the history, it looks like probably a neurological deficit. It's an acute onset. We'll see. So the important thing, this is the American Heart Association. There are 7 Ds in stroke. Okay. So first is detection, rapid recognition of stroke symptoms. So if you don't recognize, in our country, people don't recognize. We have done a study where we found that patient didn't recognize, family didn't recognize, even the first physician. Many times the patients go with a giddiness and some imbalance. They think it is your BP is high. They'll give some vitamin and they'll reduce the BP and send. So detection of the stroke is very, very important. And dispatch. So many patients, what they do when they get symptoms, they go to a clinic, they wait for the doctor, they go to the scan room and they reach us. So that is the other thing. And third is delivery. So going to a proper hospital, what we call as a stroke ready hospital. So patients have to go to a hospital where they have patient's physician is there, at least an imaging facility is there. And door, appropriate triage, as I mentioned. So in our country, first 4 happens when the patient enters into the ER. So that's where we should not delay. So in the Western world, you have a stroke ambulance, even they are doing CT and thrombolysis, even in the ambulance. That I don't think we have reached that, but at least door, when the patient comes to the emergency room, we should not get delayed. And then comes the data. That is where rapid triage, evaluation, and management with the ED and decision. So most important is decision, basically selecting the patient for any therapy, and you have to choose the drug, whether a drug or an intervention, and disposition. Okay. If this is a good link, if there are 7 links, if any link is weak, the patient is not going to improve. So all should remember our thing starts from the door. So that is our role. I think we should be very, I think there are many hospitals in somewhere in Pune or they have ambulances, they have awareness. So awareness is more important in the cities or this one. So if you have a stroke symptom, please come to a stroke ready hospital. It is better to tell your family members to know which hospital. Even you are working in Nimans, if they are in Elanka, there is no point coming to if they have a stroke symptoms to Nimans. So they can find out a hospital nearby so that they can be managed. So detection, how do you recognize strokes? So anything is sudden numbness, weakness, sudden confusion, trouble seeing in both eyes, sudden trouble walking, dizziness, sudden severe headache with no known cause. Anything acute or sudden. So there is an adage, I think all of you know, that is to be remembered as earlier it was just fast. Now it is more of be fast. Balance, any imbalance, eye blurring or a double vision, face deviation, and an arm drift, speech slurred, and always you should know when it started. Time, last seen normal or time, T stands for time. Same thing, sudden, anything is sudden, one should be considered. This could be a symptom of stroke. When you have the symptom of stroke, so the evaluation starts. Evaluation, as I told you earlier, so it is parallel. You are examining, taking history, examining, and also doing decision on investigations. Okay. So first thing is any in medicine is ABC. Airway, breathing, circulation has to be looked into that. See that patients are stable. And if anything is there, you provide oxygen, stabilize the patient. And always remember to activate code stroke. So many of the corporate hospital, you can have a WhatsApp in this one. There could be a code stroke like a code blue, code red, everything is there. Code blue is for any arrest. So they activates in a code stroke, you will have a neurology resident and radiology, PG as well as a technician, pharmacist, lab, nursing, social worker, ICU, and interventionist. All are activated simultaneously that there is a patient with stroke who may require intervention. Okay. So always remember to activate. In a busy emergency, many of this stuff happen in parallel. So one should have a code stroke. So it's a teamwork. So as I mentioned, it's a teamwork. One should all work together. So what is the immediate evaluation by an emergency physician? Check blood pressure, pulse, respiration, oxygen, check blood glucose. That's the most important thing. So because many times something called as a stroke recrudescence. If somebody has got a whole stroke, so when they have hypoglycemia or hyperglycemia, they can have a recurrence like a appearance like a stroke. Okay. Always remember when you are putting a line, please take samples at least for CBC, PT, INR, TROP-I and get an ECG. Okay, so don't wait for PT-INR report and all if there are no significant comorbidities, but at least you're doing. And order an investigation, urgent CT brain, and always remember you should have a vascular imaging. CT brain with angio is easy to get. Some of the places where MRI can be done, if the gantries are free, I think in Nimans it may be tough. In our hospital, sometimes we can do the MRI angio if it is not busy. So MRI but always remember to order an angiogram and definitely inform the radiologist and neurology team on call. Here, most of you are neurologists in the Nimans, that will not come into picture, but many hospitals that needs to be done. So what are the data we have to collect? So first, a focused history, symptoms with emphasis on the time of onset. When the ways a patient was last seen normal. Suppose if the patient has seen you at 9 o'clock and you would have gone out and then you come and see that patient is not able to speak, not able to move, you come at 12 o'clock. It would have happened at even 11:55, we don't know. But last seen normal will be 9 a.m. Similarly, if somebody has slept and woke up at 6 o'clock and they start noticing symptoms, last seen normal will be 9 p.m. or when they went to bed. But if there is a clear history, so that needs to be taken. And because the time is very important because for the decision making and planning the imaging for any reperfusion strategy. So that needs to be taken. And stroke history. So you'll be taking history to know what could be the mechanism. So always get headache. Is it a maximal onset? Was there any chest pain? Many times it so happens we have patients who has come with stroke, but ECG is showing an MI. Okay. So many times MI could be silent or they could have had a recent MI. So that could be a cardioembolic stroke. Okay, there are certain contraindication at some point. Somebody has got a MI last week, and then you come with acute stroke, thrombolysis may be harmful in them. So that those are all exceptions, but always remember MI can come present with stroke. And always medical histories are very important. We are looking here for any contraindications for giving the drug thrombolysis, prior hemorrhage, recent stroke, any head trauma, a recent MI, and surgical history, any recent surgeries, any bleeding manifestation, GI, or a hematuria, and all those things. And then in the present era, you should know about their anticoagulant therapy. Antiplatelets are okay. If the patients are on any newer anticoagulation, vitamin K antagonistic, until unless you ask, patients won't tell us. So at least we should have a chart to have look whether any of these things are there. And next is basically you have to know focused history for to know whether is there any, we can explain bedside. If somebody has got an atrial fibrillation, that could be and explain the mechanism. Okay, so always look into that. And in the physical examination, so it should be strategic rather than an exhaustive. As I mentioned, you do a higher mental function, MMSE, all those things is not required. Okay. So our main role is to know what is the deficit. So there is a standardized practice. What you have, we can learn to do is NIHS scale, National Institute of Health stroke scale. All of us to learn, it takes 5 to 7 minutes. Initially, it may take 10, 15 minutes. If you're well versed with it, within 5 minutes, now apps are there. You can open your mobile and ask the questions and do. And before NIHS assessment, should quickly assess patient mental status and protection of the airway. So the important thing is, this is going on repeating, the pulse is also very important, and checking the BP is also very important, and look all the peripheral pulses are well felt or not. And physical examination, this is a table from the Davidson book, neatly explains what as a physician you have to look, auscultate. Many times neurologists have stopped using stethoscope. And I can give you an example. When the patient had an hemorrhagic stroke, okay, down the line 24 hours, 48 hours are happened. And we were thinking everything was normal. What is the cause? So echo showed a mitral stenosis, okay. So she was a 50-year-old. So we rarely bother to auscultate. Then we go and auscultate, it is there. So it is we should be first physicians, look at the patient as a whole. So the important thing, at least you can put a stat, see whether they have any, because sometimes management changes. One should always know this. What is the importance of doing NIHS scale? It's a, see, you say power is 1/5, somebody will say 2/5. If you ask, call your consultant and say, I have a patient, right hemiplegia, upper limb 3/5, lower limb 4/5, and mild facial weakness, does not have much meaning for the person who reads. So if you have done an NIHS score, so you can tell, I have a patient, stroke, onset at 5 a.m. with a NIHS of 12. That carries a good meaning, and then you also add the CT, which I'll be coming. So NIHS is very important, and you have 11 parameters what we are going to look, and score is maximum is 42. So level of consciousness, visual field, facial palsy. Actually, this NIHS was initially made for the trial, NINDS trial. It basically looks at MCA territory. So MCA territory, and that's why extinction and all come. So large vessel occlusion. So this many times what happens, it was told that if your NHS score is more than 10 or more than 5, it's a large vessel and there's a cortical lesion. But that may not be true. You may have a small lateral medullary syndrome. Lateral medullary, your NIHS will come high. Okay. So this NIHS basically came for anterior circulation in the trial so that they could use it. But now we can use across all. So what is the importance? Based on the NIHS, we can classify stroke as mild, moderate, severe, and very severe. So the very severe, the earlier is a contraindication for any intervention, thrombolysis, thrombectomy. Now, even mild, some people means there are studies showing that antiplatelets may be beneficial, but if you have a significant, like a, if you have, like somebody has got speaking difficulty, hand weak, somebody has just comes with only wrist drop of the right hand, and then mild speaking difficulty, if you do NIHS score, it will come to 2. But the significant deficit will be there. So you have to take a decision, minor stroke, what is most significant for that patient. So anything above 5, up to 24, you can plan the intervention or whatever thrombolysis we can plan. So the important thing of NIHS is it's you have to monitor. So many times we have to do at admission. So see if you have done any intervention, check 6 hours, 12 hours, 24 hours, at the end of third day, at the end of 7th day, at least at the end of 3 months. So this will have a important thing. And if somebody's NIHS is worsening, that means the stroke is progressing. Suppose you are thrombolized, and if NIHS, anything worsening more than 4 is an indication to repeat imaging and take a decision. Okay. So if the patient is improving, their NIHS will improve. So NIHS is very, very important. And there are, I think, sir also has given, so all of you can get trained. It's a free online so that you can get certified yourself. I think that we are not asking as a residents. I think all of us should get it certified and put it there that we have NIHS. Similarly, as a neurologist, we should know some skills apart from the stroke. And we should also know about how to do UPDRS, how to do EDSS for MS. I think those are all important things one should get ourselves trained and look into that. So next comes what imaging we should order. So you have examined the patient, you have done the basic workup, and you have done the NIHS score, and NIHS score has come, and imaging. So there are 4 P's which you have to see in images. So one is parenchyma, okay, pipe, then other thing is pump also, that is the heart. So all things for information. The important thing is plain CT, and if you are doing an MRI, there should be a sequence for GRE. And always have CT or CTA or MRA. And many times it so happens patients do the imaging, angio will not be done, the patient will walk in with the scan. And angio also is done, only it will be done from the intracranial. So we should have angio right from the arch of aorta to the circle of Willis. If the patient is delayed, I think next talks are there. We are talking on the perfusion and all, which is not required if the patient has come to you within 6 hours from the onset of neurological deficits. Okay. So this is all advanced imaging is not required. What is required is CT with CT angio. So that's the important thing one should do. And so CT is the most available and easy. What is the advantage of CT is it is 100% sensitive and specific to detect bleed. Okay, so the absolute contraindication for intravenous thrombolysis is bleed in the brain. So which definitely CT can give you. So always remember you do a, and one more remember, stroke is a clinical diagnosis. You do a CT scan not to prove that this patient has got stroke. You do a CT scan to rule out that he does not have hemorrhagic stroke. So stroke is a clinical diagnosis. Even posterior circulation stroke, up to 3 days MRI may not pick up diffusion restriction. So it's a clinical, so neurology is clinical diagnosis. Many of the diseases clinical diagnosis. Stroke, remember it is a clinical diagnosis, and you do the investigation to corroborate you that there are no major abnormality. So CT brain, a positive scan is unnecessary. That is what. So a CT scan should not show big stroke. Okay, it's unnecessary for diagnosing acute ischemic stroke. When a typical stroke syndrome presents along with a normal CT, one should suspect that this is a probably ischemic stroke, but not a hemorrhagic stroke. So there are subtle signs of early signs of ischemia. So what are those things? So insular ribbon, when you have, this is all described in a large vessel occlusion, like an proximal M1 is occluded or a distal ICA, you can develop insular ribbon, loss of gray-white differentiation, okay, and then blurring of internal capsule, and then mild sulcal effacement, okay. So at least it may take 3 hours to develop. See, this is, I think, the third, I think Dr. Shritijesh is talking on collateral. So everything is defined how good your collaterals, the imaging findings also, okay. So each human brain, each circulation is different. All of us sitting, all of us don't have the same type of circulation. Okay. So the imaging differs based on your perfusion. And also look at the places where you can see some dense sign, right? Hyperdense MCSA, which shows there is a thrombus. Or you can have a dot sign, Sylvian dot sign, or a basilar artery. So this will indirectly, so why this is important is recognizing these patients may not respond to your IV thrombolysis alone. Okay, if you don't have a facility, you have to think, I've seen this scan, I'll give thrombolysis and see it's not the correct way. So you should have an idea that, oh, this is a large vessel, there is a thrombus. This patient may not, you may have to plan a IVT. So what our scan should not have this. So no bleed should be there. Okay. And this is one of the bleed subdural. They usually present many times with the left-sided weakness of an acute onset. Okay. So this is usually, you can see acute on chronic. What could be the mechanism of this bleed? Anyone? This has got STH and this is an ICH. A patient with an atrial fibrillation comes with a stroke, so like symptoms, and this is the imaging. So this is, if you see, there is a fluid level here and it is not so hyperdense like this. So it is usually an anticoagulation related bleeding. You get a fluid level and the density of the blood will not be very dark. So the main important CT findings are this, I think already which I described. And these are the few other things where you can see a Sylvian dot sign here, which is showing distal M2 or M2 occlusion. And then this also, many times it so happens, patients, we have seen patients who comes with, emergency will tell that this patient is having seizures, they intubate also. And it so happened in pediatrics also it has happened. So they will be actually posturing, okay, top of basilar, they will be posturing, they think it is a altered sensorium and they are repeatedly doing this and they will be intubate, they will give lorazepam, levetiracetam and all, and they do a plain CT. Plain CT will not show. Okay. So, but if you closely look, there is a thrombosis in the basilar artery. So always better if somebody has come with an unconscious state, posturing and all, plain CT may not pick up. It is better to do a angio also to see that there is no top of basilar or a brainstem stroke, because this potentially treatable. We have lost patients because after admitted to the ICU after 48 hours, they call us, why this patient is still seizing, please come and have it. It's actually not a seizure. Okay, it's a decerebrate posturing what they are developing. Okay, so one should be very, look all these things when you get a scan, and this is not bleed. Okay, what is this? If you see this, patient is in the thrombolytic period. What is this? So what structure comes? That is pineal gland calcification. So one should not get confused, and it is as hyperdense as the bone. So one should know that it is not bleed. And the next thing what you have to learn to do is something called as an aspect score. Okay, as a neurologist, I'm introducing NIHS, you should know, and you should know aspects. So aspects, this is for the anterior circulation aspects. You have 10 score. If there is a hypodensity, you actually minus 0. If there is no hypodensity, you calculate 1. Okay, so the score is 10. If somebody's CT scan is 10, that means it is good. There is not much of infarct has happened, or the core is not very big. And similarly, aspects. So anybody right now, what is the importance of it? Somebody who has got an aspect of more than 6 or more than 7 is an ideal thing for all procedures, thrombolysis, thrombectomy. So now you have aspects, like anything up to 5, even up to 3 they are doing. But as of now, we should know anything above 6. So what may be the duration also is up to 19 hours, you can intervene. Okay, so that is the important thing. So all should know how to do the aspects and CT, and this also is the training. If you go to the Calgary, this one, you can get this aspect and you can learn how to do that. And similarly, you have aspects for posterior circulation also. So you have aspects of 10. So PCA territory, occipital lobe, thalamus, and you have pons, midbrain, and the cerebellum. Once you have done the aspect, so decline, so the important thing is, and it is better to look at the aspects in the source images. Okay, source images, and you can reduce the window to 40-40. Sometimes it will be very difficult, 70-30 if you do. One should look at the source images, and then you should look at other thing is the CTA. When you do the CT angiogram, you can look for the aspects there, and which I ever told. And the vascular imaging you should do from the arch of the aorta to the circle of Willis. So that is the important thing. So if you can recognize here, there is an M1 occlusion. So many times if they don't do an angio, it will be very, very difficult to get. So the next question you will ask is, how is the perfusion? I think this will be coming, I'm not going in detail. always you should ask a question. Next question is, you have done the angio, also look at the what is the collaterals. Somebody has got a good collaterals, the outcome will be good. Poor collaterals, the outcome. So you can prognosticate the patient and counsel the family. Whatever the intervention you are doing, collaterals are very, very important. That is like somebody is falling and holding a straw. The straw may not hold them for a long time. You may be able to pull them back. So that is how we can imagine. So if there are good collaterals, you have time, you can intervene. Okay, but if somebody has got a poor collaterals, this will progress. So this is what is depicted. So if you have a good collaterals, there will be slow progression of the core, and this is the penumbra. If the collaterals are able to manage the penumbra, if the time passes, the core will start increasing. If you can intervene at it, you can save. But if somebody has got that is called as a rapid progressors and slow progressors, I think definitely sir is going to speak on this. So the collaterals also is important in knowing the outcome. So when you are a physician there looking at it, you should ask all these questions: NIHS, aspects, probable collateral. So for that collaterals, you should do multiphasic CT. So usually they should do 3 sequences they have to do, 3 times they have to do. You have to tell your radiology colleagues to get it done. And this is the very, very important, which I have already discussed. And then I think this is going to be discussed. You can know the clot burden if there is an M1 occlusion. There are scores to know how much is the clot burden so that we can know how they have an outcome. What is the importance of knowing the clot M1 occlusion is because they don't respond much to the IVT. It is found that more than 30% of the people does not respond to IVT. So if you have a MRI is also very helpful. Definitely MRI will show diffusion restriction. Earlier we thought this diffusion restriction is a core. It is not true. We have seen that the diffusion can also reverse many times. So earlier I have still remember many in the earlier period, if you had seen this much, I would not have thrombolized. I have not thrombolized. Now retrospectively, I regret I should have done that. Because over a period, we have learned that diffusion, and if there is a diffusion flare mismatch, definitely you can do that. And always remember to have this sequence, gradient sequence, because if you look here, it looks like an acute infarct, but if you closely look, there is blooming. So this is a bleed where absolute contraindications for thrombolysis as well as thrombectomy. Okay, so one should look that disadvantage. If you just see these images, you think it's an acute ischemic stroke, but usually in an hemorrhage, it will be not like a wedge shape and it would have crossed the territory. So one should look into that bed gradient is very, very important. So MRI, you should look at all sequences to diagnose an acute stroke. CT, you'll just see if there is no bleed and look at the aspects. And then this comes, there is another classification based on the Oxford classification. You have total anterior, partial anterior, lacunar syndrome. This is how you can classify. This is not required in the emergency room to diagnose, but at least you should know total anterior circulation, left hemisphere, you will have aphasia, dense hemiplegia, hemianopia. So you can syndrome. Somebody who's fully conscious has got a dense hemiplegia, mild slurring of speech, and don't know hemianopia, no any of the visual extinction and all. So even though it is a dense hemiplegia, it will tell you it could be a lacunar infarct in the internal capsule. Okay, so this will help us in classifying the various stroke. This is more in the ward later, but not in the acute emergency. What are the differential diagnosis? You think seizure, syncope, sometimes migraine with aura. We have patients with aura migraine coming like a hemiplegic migraine. Okay. So where it has helped us is diffusion is not showing anything. And see, you should remember anything ischemia which is going beyond 30 minutes, diffusion usually will show the restriction. Suppose if diffusion is normal after 30 minutes with a dense hemiplegia, you are not able to detect, it's very, very alive. Anytime functional patients also can have, demyelination can also come. So how to differentiate? Symptom onset in stroke is sudden and non-stroke is slow, rapidly reaches maximum severity, and there is more of negative phenomenon in the, like patients with seizures and all, they have positive. Hemispheric pattern may be non-specific, and loss of consciousness is uncommon. If you have a brainstem or a whichever involves the reticular system, you can have unconsciousness. Otherwise, traditionally a right MCA infarct or a left MCA, they will not have altered sensorium. If they are in altered sensorium, that tells you that it's a massive infarct. There is a large inclusion and there is a raised ICP. That's why the patient is becoming drowsy. So next, coming to that, you have assessed, you have done the imaging. What is the goals of management? Aimed at identifying the cause, minimizing the volume of brain that is irreversibly damaged, which I was discussing, and preventing complication. And main role for a physician is reducing the disability and handicap that we can improve with the rehabilitation. And the fourth one is reducing the risk of recurrent stroke or other vascular incident. So what we have available is rational for thrombolysis. As I mentioned, if you see that at the onset of the stroke, this is the core penumbra. As the time passes, if there is no reperfusion, the core is going to become big. If you reperfuse it, okay, it is found that why that 4.5 hours came. They have done studies in the animal, where especially primates, clamping the MCA. At the 4.5 hours, core and penumbra is almost same. So that is how that 4.5 hours came, but that may not be true. If somebody has got a good collaterals, even thrombolysis can go up to 9 hours now with a advanced imaging and look at is there a diffusion or is there a perfusion mismatch. I think in the next call you are going to hear about that. So that is a very important thing. And rapid clot lysis can perfuse the brain and save the neurons. And the only complications we were all worried in the beginning of it is what is the bleed. If NINDS showed that there is a 6% risk of bleed if somebody has got IV thrombolysis. But in the real practice, it is less than 3%. So if we have done hundreds of thrombolysis, I can count in my fingers how many patients really bled. So thrombolysis is relatively safe, but you should choose the patient and you should go through all indications and contraindications. And up to 4.5 hours now, earlier 3 hours, 4.5 hours now, up to 4.5 hours. If there is a measurable neurological deficit, there is no bleed, no contraindication, and your blood pressure is managed, definitely you can thrombolyze, and most of the time you don't come into any complication. So next decision is you have decided you have to give drugs. There are earlier days there are only one, now we have two drugs. Okay, inclusion, I think we all know this. So anybody above 18 years, but now in pediatric also it is approved. You can thrombolyze. Anybody, if this is the initial NINDS, less than 3 hours, then up to 3 to 4.5 hours, there are other contraindication. But so what is the absolute exclusion is if somebody is blood in the brain and platelet counts are low, or there are many of these and platelets are low, then if patient is INR is 1.7 and heparin if they have received, if they are anticoagulation less than 24 hours, hypoglycemia, okay, and if the infarct size is more than 1/3, but now that also is going out, but we should all look into that. You have to have a selective, and then pressure is the most important thing. What is the main factor with the patient bleed is if you have not managed their blood pressure. So blood pressure has to be managed before you thrombolysis. And this was the other recast trial and all, they excluded above 80 years if they are diabetic and if they have a significant small vessel disease, micro bleeds. But now you don't have to look for all those things. And pregnancy is a relative exclusion criteria. Seizure at onset was initially, but now it is a relative exclusion. Major surgery, trauma, within previous 14 days, if you can manage the bleeding, we can still give that. Recent GI bleed, recent MI, within 3 months is a relative contraindication. So AHA brought a scientific statement. So even in minor stroke, many of the contraindications have gone. One can go through this article. And this is the latest guidelines. Within 3 hours, both the drugs can be given. So earlier Indian were given only for first 3 hours tenecteplase. Now tenecteplase up to 4.5 hours one can give. So all these things we should know. This I think will be available in the. So the next question you will ask is if a patient you have an LVO. So what is if you just give IV thrombolytics, it may not respond. So nearly 30% carotid proximal middle cerebral R, distal ICA, basilar may not open. So next, what to do? For that, we should consider them for thrombectomy. Somebody has come in 3 hours and you have LVO, so you have planned thrombolysis, but you should also you should keep the gantry ready and what you call as give the drug. Now it is bolus, tenecteplase, you can shift the patient. Intravenous thrombolysis fails to reperfuse. Mechanical thrombectomy up to 6 hours you can do without any advanced imaging. Okay, so if patient has come at 5th hour, okay, that is a contraindication as of now for thrombolysis. You can push directly for the thrombectomy. Anybody who is coming within 4.5 hours, even though they have an LVO, you have to thrombolize and then plan thrombectomy. So in the Western world, they are directly tracking. I don't think in our country it is still possible. So drip and ship. Okay, so in the emergency room, you thrombolize and you shift to the cath lab. Many times it is found, we have also seen either the clot has migrated distally or it has totally opened up. Especially with tenecteplase, we have this experience. Okay, so mechanical thrombectomy is a class 1, level 1. So if you don't offer to a patient, we are legally or medically liable. Okay, all doctors should know. If you don't have the facility, that is a different thing. You have to explain and you have to shift. So mechanical thrombectomy is an absolute indication if you have an LVO and there are no other contraindication. And if say NIHS is more than 5 and then you have an aspect of more than 6, then you don't have a job not to just give thrombolysis and keep in your hospital. So you have to give a prescription and that there is available, you have to shift them. Now coming back to the case, I think with this discussion, so what to do now? So what all information you want? How do we manage this now? So we just discussed all the story, how to evaluate. So what you want to know? So he has come at 12:15. Okay, with difficulty speaking, right. So how to go about it? What information you want? Huh? So you ask me, I will give you the information. You are in the emergency room. This is the history. He has come. So next, what do you want to look? So his sugar we'll check. BP we will check. Question what we have. Be fast. If you do a be fast, he has got weakness is there. There is speech. So definitely it is a stroke. So next is what? Okay. So when time of onset, okay. The first is you want to know what time. He came to you at 12:15. So when was the onset? Okay, that is one. Next, what will you do next? You check the blood pressure. I'll give you the value. Next slide, it is there. Then check the sugar. And he does not have a surgery. He's a known diabetic, hypertension, no other habits. He didn't have any MI or anything. Next, what will you do? You do the neurology assessment by NIHS score. So you should do a NIHS score. So then what will you do? So NIHS is, I think, 15 here. So what will you do next? So you order an imaging. So you can send the blood samples for CBC, PTINR, but don't wait for it. And suppose is creatinine mandatory to do a CT angio in this patient? So no. Okay, remember neurons over nephrons. Okay, you can transplant kidney, but you can't transplant the brain. Okay, so don't wait for the creatinine. So because many times this what we are using may not cause much significance. So don't wait. Okay. So you have done the imaging and we have done an MRI with this. And so this is the information. So you have symptoms at 11 a.m. So the patient has come to you within 1 hour, 15 minutes. BP is 200 by 110. NIHS was 18. And so if you look, what do you see here? So if you see here, CT is not showing much. You are showing diffusion, whole of the left hemisphere is, and it is not very dark. Okay. And if you see flare, there is a mismatch. So flare is not showing any changes. And if you see the whole of the left ICI and M1 is not seen. Okay. So now what do you do? This is a real patient. So he is in the emergency. By this time, all it is done. Now say it is 1 a.m., 1 p.m. 12:15 patient has come. You have all this information by 1 p.m. Next, what is your action? So as a physician, what will we do? So BP is high, so we'll admit to ICU, large MCA infarct. So he is a candidate for reperfusion. So there is no doubt about it. We have to think what reperfusion strategy. Before doing the reperfusion strategy, what we should do? So reduce the blood pressure. Okay. So we have to bring down the blood pressure to systolic less than 185. diastolic less than 110. Okay, so that's one of the indications. So many times it so happens patients with accelerated hypertension with a lacunar infarcts and all will come. Many times we have failed to bring down the blood pressure by giving repeated labetalol. Okay, we have abandoned thrombolysis because of we are not able to get down the blood pressure. Okay, so you have to bring down the blood pressure. So then what will you do? What is the treatment strategy here? Reperfusion strategy. Thrombolysis or thrombectomy or both. So you have to plan both. Okay. So this is a candidate who is within 3 hours or within 2 hours he has come. Aspects is good. There is a large vessel occlusion and there is no doubt. Okay. So you have to plan what drug. So tenecteplase, altiplase, both can be given. So we have to decide on that. So summary, acute infarct with a large vessel occlusion. So reperfusion, we started tenecteplase. Tenecteplase dose which was approved in our country is 0.2, but many Western world, we are also started using 0.25. This is the case which happened in 2021. And mechanical thrombectomy was done. Okay. And patient was admitted in ICU and monitored. So when they do it, it doesn't mean that tomorrow they will become normal and walk out. Okay. So that's what the patient expects. So you should counsel them the outcome, whatever the IVT or the thrombectomy, it is at the end of 3 months, how is the outcome to a patient who has not undergone. So for that, what you should do is something other score included is MRS. So Rankin score, all neurology residents should know about MRS. When they get admitted to the ward, you should mention NIHS, aspects, third is MRS, premorbid MRS. If somebody's MRS is already 5, even if they come in thrombolytic period, thrombectomy, it is not going to be of beneficial. Okay. So our idea is MD has got an MRS of 0 to 1 or up to 2. And what is the MRS at admission? So those things to be documented. And see this patient we did, and then after CT demonstrated next day, no significant hemorrhage, but there is a large infarct with little mass effect. Aspirin statin started, and he was found to be COVID positive, and he was in the ICU. Then slowly, by discharge, almost after 2 weeks, his power has improved to 1/5 speech. He was monosyllable, he was able to speak, and dual antiplatelets was given. And down the line, after he has clinically significantly improved, he still comes for walk-up, he is able to walk, he is able to speak. But if you have done the angio once again, we did, it shows ICA is still occluded. Okay, this was done. This is basically an artery to artery embolism from the left carotid artery. And since there was a good cross flow, nothing has been done for this. And main thing is modification of his diabetes and hypertension. So this is a flow chart. One should know. Okay, anybody who comes with symptom less than 4.5 hours, treat with IV TPA if eligible. Results of CTA, then LVO. Less than 6 hours, there is no doubt open. 6 to 24 hours, you have dawn diffuse, which we are going to talk about, I think, later. So always think in your brain, can I open the vessel, either by the drug or by the mechanical thrombectomy? So in conclusion, as I was telling, stroke evaluation is time sensitive. It doesn't mean that patient has come 1 hour back, you are still 2 hours, I will have coffee break and come and see. It is not like that. And you may have to push trolley to the scan room. So you cannot order, it happens, aid is not there, nobody is there. So time sensitive. And recognize stroke symptoms and activate stroke code. That is, it's a team. As I was told, 7 days, everybody has to be on the floor. And severity by NHS. And remember imaging of the brain from the brain as well as from the vessels from the arch to the circle of Willis. Rule out bleed. Look for large vessel occlusion. And always strategize reperfusion therapy. Either it could be an IVT or mechanical or both. I thank Dr. Sharath for sharing few of his slides. Thank you. Any questions or? So DAPT was, that's a prevention of the stroke. That is, patient has got carotid large vessel disease. When you have a large vessel atherosclerotic disease, the current guidelines up to 3 months you can give dual antiplatelets. If it is a lacunar infarct or this one, if there is no large vessel or a ICAD, you can give for 21 days dual antiplatelets. So current guidelines are that. So many of our patients, I think from the ages we are giving dual antiplatelets, but now there are some guidelines up to 3 months you can give dual antiplatelets. This patient had atherosclerosis of the carotids.
Thank you.
Thank you.
Thank you, sir, for that excellent overview and reminding us again how accurate clinical diagnosis remains the cornerstone of stroke management. Our next topic is CT and MRI protocols in acute stroke. Dr. Rimpi Joseph ma'am will speak on perfusion imaging on acute stroke. Rimpi ma'am, who is working in EMS Memorial Hospital. She's a pioneer established in hyperacute stroke response pathways in northern Kerala and is a medical advocate for pre-hospital care and stroke management.
Respected senior colleagues and dear friends, a very good morning to all of you. I initially at the outset, let me thank the organizing committee for inviting me here to present on an important topic, which is perfusion imaging in acute stroke. So first a brief introduction. So we all know that the goals of acute stroke imaging are to exclude hemorrhage and stroke mimics, which is most vital before we go for any reperfusion treatment, identify the presence of large vessel occlusion, quantify the core, delineate the extent of salvageable tissue, which is the penumbra, and which then forms the crux in every case selection, which is individualized in stroke. From the time we were in medical school, we were taught that time is brain, time is money. Now we have refined the concept and there has been a paradigm shift. There is no denying the fact that time is brain, but more important is it is a tissue which is brain. So we are more worried about the tissue window, the collateral window, or the collateral clock as described in this paper. So the collateral clock, once it starts ticking, the outcomes also matter. Once the collateral clock, the times are bad, then the outcomes also become proportionately bad. As my previous speaker, Raghu sir, correctly mentioned, there are 5 P's of acute stroke imaging. Imaging of the parenchyma by means of a non-contrast CT or a non-contrast MR, the normal MRI. The pipe imaging, which is the imaging of the vessels by using a CT angio, MR angio, or a direct DSA. Perfusion imaging, which is the topic of today's presentation. The penumbra, which is assessed by a combination of these. Then we have the 3 C's, which is the core, imaging of the core, the clot, and the collaterals. We hear a lot about mismatches in stroke, and an approach to a good perfusion imaging actually begins with examining and taking a proper history of the patient. So that's a quick examination in 5 minutes of the NIHS. The first mismatch at the ED room is looking for a clinical radiological mismatch. which means if the patient has got a bad NIHs and he has got good aspects, which is not matching, which means that if the aspects is like 8 or 9 and he has got a bad NIHs, a high NIHs, it means that the patient has got a large penumbra. So this is the first indication that we are dealing with the patient who has a large penumbra. We need to be really fast to treat this patient. So then we have the core penumbra mismatch, which we identify on the perfusion, the core collateral mismatch. We have diffusion perfusion mismatch, the DWI flare mismatch, which you all are aware of in wake-up strokes. So this is a basic figure. Consider that this is the artery and the artery is blocked. So the artery when blocked, the part of the brain which is supplied by the artery, the worst affected is the core, which has been irreversibly and irretrievably damaged, and it's at a point of no return. But the target of reperfusion therapy is actually this area, which is the penumbra, which is the area which is surrounding the infarct, or it is called as a peri-infarct area, which can progress to a core or which can progress to normalcy, depending on the effectiveness of our treatment. So, and then there is a border zone between the core and the penumbra. This is the area which is most likely to progress to become a core at the earliest. And this is the area which is at the highest risk. There is another border zone, which is the external border zone of the penumbra and the benign oligemia. And then beyond this is the area of the normal brain. So the brain can be classified into a normally perfused brain, which is somewhere here, and a hypoperfused brain. The most severely hypoperfused part, which has been irretrievably damaged, that's the core. The hypoperfused part, which is functionally impaired but still intact, that is the penumbra. And then the hypoperfused brain, which has got no clinical significance, that is the benign oligemia. This is a picture which all of us know from Astrup et al. Paper. And here we see that we have on the left-hand side the cerebral blood flow. And this is the normal range of the cerebral blood flow. As we all know, the cerebral blood flow, or the CBF, is higher in the gray matter. It's about 50 to 60 ml per 100 gram brain tissue per minute. And the blood flow is half of that in the white matter. So the normal, say, CBF in the white matter will be about 30 to 40. Now, this is all, this graph is regarding the gray matter. So when the blood flow becomes between 30 to 50, that is the threshold for oligemia, and then below 20, so somewhere between 20 and 10, that is the threshold for penumbra, and below 10 is where there is release of potassium and neuronal cell death, and that becomes the core. Just to highlight that penumbra essentially refers to tissue which lies within the thresholds of functional impairment. So it's a functionally impaired tissue, but morphologically intact. That is the target of reperfusion therapy. While core is a tissue in which the blood flow has fallen below the critical threshold of 10 ml per 100 gram brain tissue per minute. It has completed infarction, it is refractory to perfusion, and therefore non-salvageable. Now we talk in the coming few slides, we will be talking about the perfusion parameters. The three important parameters are the time to transit, the cerebral blood flow, and the cerebral blood volume. And this is just a figure to show how we identify the core. The most reliable marker of core on a perfusion imaging is the relative RCBF, that is a relative CBF less than 30%. If you convert it to volume, it is a CB volume, that is the cerebral blood volume less than 40%. The penumbra is most accurately identified by the TTP, which is more than 145% of the normal appearing hemisphere. So this I've already described. Now, we also need to know what is clinically relevant, what is meant by luxury perfusion. So luxury perfusion is important in the context of a patient who has already had a stroke. Consider a patient who comes with an acute infarct, and then your repeat CT or your CT perfusion shows that the blood flow has pseudo-normalized, or even the blood flow has become higher than when compared to the other hemisphere. And that is because of a reperfusion, which has happened either spontaneously or iatrogenically, or due to a hyperperfusion. And the primary mechanism of luxury perfusion is dysfunctional autoregulation. And because this revascularization can occur due to endothelial injury or blood-brain barrier injury, this may appear as an enhancement, a contrast enhancement like appearance on the CT brain. Although luxury perfusion has been typically described more than 72 hours after the onset, but it can also be seen within the first 24 hours. If you see luxury perfusion in a patient coming in the lytic window, that is in the thrombolysis window, it's better not to lyse the patient because they are prone for hemorrhagic transformation because of the breach already existing or created breach of the blood-brain barrier. So perfusion imaging in stroke can be done in two ways, either via CT or via MR. Both are equally good. Some centers prefer CT perfusion over MR perfusion. The most important part of any perfusion imaging is to interpret it. The major differences between CT and MR perfusion for the students, CT perfusion involves radiation, but the radiation is much lesser than a normal single-run CT. The SNR is lower in CT perfusion while higher in MRP, and that is why the resolution is much more in an MRP. CTP gives an indirect estimation of the ischemic core when compared to MR perfusion, so because of the simple reason that we also have a clear-cut DWI in the MR imaging, so that gives a direct visualization of the infarct core. Iodine contrast used in CT perfusion and its related complications, gadolinium retention and its related rare complications of NSF, nephrogenic systemic fibrosis in MRP, less contraindications for CT perfusion compared to MR perfusion, and less readily available is MR perfusion. In our center, we use the MR perfusion. Now, whatever whether it's CT perfusion or it's MR perfusion, the concept remains the same. We are basically imaging the perfusion or doing an angiography, either a CT or an MR angiography of the cerebral microcirculation, not of the macrocirculation. So it's basically a functional or physiological imaging technique which changes over time. And its main role is to identify the extent of the irreversibly infarcted brain tissue, which is the core, versus the potentially salvageable penumbra. CT perfusion in its most simple form consists of three basic steps. The first is data acquisition, then post-processing, and the third and most vital step where all clinicians are involved, and that is the interpretation and using this for our clinical practice. So the first step is we inject iodinated contrast as a single bolus. It's about 30 to 50 ml. In our center, we use about 50 ml as contrast bolus, which is injected either manually or through a power injector. And this passage of this contrast bolus, the first pass through the cerebral circulation, is imaged via sequential CT or MR scanning. And the length of the first pass definitely depends on the cardiac output. In a low cardiac output, it will take a long duration. Similarly, in case of a hypovolemic state. So this is how the sequence of scans are done. So the three steps on the right side, the data acquisition, the post-processing, and then the results interpretation. So post-processing can be done by the maximum slope method or more commonly used deconvolution technique. So we have a 50 ml contrast, 5 which is injected at a very high rate of 5 ml per second, followed by a 25 ml saline push. And ensure that before any patient is sent to the imaging, he or she has a good 18 gauge cannula, because there's a lot of time in our daily practice. We see a lot of time is wasted with the cannula not available when the patient has reached the CT or MR room. This picture is also important. When we do the perfusion imaging, we start the scanner button and the power injector button simultaneously. Here we inject, and the starting of the scan is after a delay. So there are two terms which are used interchangeably, but not so much so the same. They are the TTP and the Tmax. So the TTP is measured from the time of injection until the peak of contrast enhancement, while the Tmax is measured from the start of the scan and not from the time of start of injection. And once the scan is done, the various the CT perfusion parametric maps are then obtained. So the radiation exposure as compared to a CT is less for a CT perfusion. And then the post-processing softwares depend on the various vendors, whatever the vendor is. The most important part of a perfusion imaging after doing it properly is the interpretation. Measures of CT perfusion. These are the commonly used measures: cerebral blood volume, cerebral blood flow, mean transit time, time to peak, Tmax, time to decay, and the delay time. So what is coming to each of them? What is cerebral blood volume? Cerebral blood volume refers to the total volume of blood which is flowing in a given volume of the brain. So normal cerebral blood volume is about 4 ml per 100 gram. And in an infarcted tissue, it's usually less than 2 ml per 100 gram. Cerebral blood flow, on the other hand, refers to the volume of blood which is flowing through a given region of brain per unit time. So it's a measure of the rate of the blood flow. And normally in gray matter, it's about 50 to 60 ml per 100 gram brain tissue per minute. Then the next important parameter is the mean transit time, which is the average time which is taken for the contrast to flow through a brain region. And the time to peak, which I showed before, it's a time from the start of injection until the maximum peak of contrast in enhancement when compared to Tmax, which is the time from the start of the scan until the maximum intensity of contrast arrives at each voxel. Time to decay, and then there is a delay time. So here in this graph, if you see this from the time of injection until the peak of enhancement, that is the time to peak. But from here, time from the start of the scan right until here, that will be the Tmax. This area under the curve is MTT, and this rate, this maximum gradient curve, that is the cerebral blood flow. Then we have the time to decay of the contrast, and this time is this average time for the contrast to pass through the given brain tissue. That's the mean transit time. This whole area under the curve is the cerebral blood volume. So as we see the TTP, so this is a normal case. This is the TTP of a normal brain and of an infarcted brain where the TTP is so grossly prolonged. And you can see the CBV, which is higher here, and the CBV, which is quite low here, similar to the CBF also. This is again a little important concept, and that is there are certain confounding factors while interpreting a CT perfusion. So consider this as a normally flowing and fully patent vessel. So when the vessel is patent, the brain is perfused normally. You get a normal CBF, a normal CBV, and a normal MTT. Now consider that this vessel is getting occluded. When the vessel is getting occluded or with increasing stenosis, the cerebral perfusion pressure is reduced. In the initial phases, it is called as a compensated phase, the green one. The autoregulation maintains the perfusion. How? And that is by maintaining the cerebral blood volume at normal or slightly increased levels. Of course, when there is a stenosis, there is more time taken for the contrast to pass through the given tissue. Therefore, the TTP or the MTT is increased. After a certain stage, the decompensation starts, and that is the initial phase, which is called as a benign oligemia state. With increasing stenosis, the cerebral blood flow falls, but not to a greater extent. The blood volume is still maintained, and of course, the mean transit time in this hypoperfused area is increased. Further on, the blood flow falls much more. That is, it becomes 30 to 50%. That is, the relative cerebral blood flow compared to the normal side becomes 30 to 50%. It is a penumbrate tissue. The cerebral blood volume also begins to fall, and the mean transit time further rises. And then the extreme extent is the core, where the cerebral blood flow falls below 30%. Of the other side, the cerebral blood volume falls below 40%, the relative cerebral blood volume, and the mean transit time or the time to peak is grossly increased. So just remember this, make a mental roadmap of this picture, because this will be useful for interpretation. So that's just I've put it in a tabular form, the interpretation of CT perfusion abnormalities. Now, coming to the patterns of CT perfusion. So, of course, a normal brain will have a normal intracranial perfusion. There will be symmetricity of all CT perfusion parameters. Although I have described 6 parameters, for the clinical practice, only 3 parameters are sufficient: the TTP, the CBF, cerebral blood flow, and the cerebral blood volume. Now, we know that the cerebral blood volume and flow are higher in gray matter than the white matter. Now, we look in CT perfusion images for the matches and the mismatches. We are more bothered about the mismatches. So, CT perfusion mismatch can be favorable or it can be unfavorable. A favorable mismatch is when the core is small and the penumbra is massive or huge. An unfavorable mismatch is on the other side. It's the core is very large and the penumbra is small. And intermediate is when both are of moderate size, and then you use your clinical judgment making along with other radiological investigations to make a fruitful decision. Then we have a malignant perfusion when the core is large and the penumbra is also large, and that is the red signal that don't go ahead for any reperfusion treatment there. Then there is the lacunar stroke. So lacunar strokes, again before the lacunar, the Malignant infarctions are those where the DWI lesion volume is more than 145 ml. In malignant mismatch, despite the significant penumbra, the large DWI is there, and these areas are likely to have very poor collateral supply, and they are likely to land up in more complications if reperfusion is attempted, and therefore it's better to avoid malignant mismatch cases. Role of CT perfusion in lacunar strokes. So lacunar strokes by definition are small, the smallest of the strokes. And here there is the sensitivity for detection of lacunar infarcts by CT perfusion is low. However, CT perfusion can predict the neurological deterioration happening in certain patients with lacunar infarctions, for example, in capsular warning syndrome, and that is by detection of an increased TTP and a reduced CBF. Now coming to the reperfusion pattern, I've already mentioned about this. This is what is known as a luxury perfusion. So it is a pseudo-normalization of all perfusion parameters due to a successful reperfusion or due to a natural reperfusion or due to an endothelial injury. So this is non-nutritional since the cerebral tissue is already infarcted. We have reperfused, or the nature has brought forth blood flow into an already dead tissue. So it's of no use, it's non-nutritional, and it appears as an enhancement on the CT. Reperfusion pattern should be recognized, and as I mentioned before, such patients should not be given thrombolytic therapy. So now just coming to the interpretation of images. So we look for the matches and mismatches. So here is a patient with this is the CT, and then we see first we look at the TTP or the MTT. We see that the TTP is grossly prolonged in this area, which means it's a hypoperfusion. We then move on to the CBF, which is reduced, and the CBV reduced, all corresponding. So it's a match, and therefore, which means that there is no mismatch in this. And now coming to the another case, just to identify the pattern, that is to show the large. So here we see the TTP is grossly prolonged in a large area on the right side, and we see that the CBV is grossly reduced only in a small area, and compared to, there is a mismatch between the CBF, CBV, and also between the TTP and the CBF. So this, if it is a large vessel occlusion, it is a good candidate for endovascular treatment. Similarly, here on the aspects, the early ischemic changes seen over here on the TTP. So when one thing to note is that the TTP progressively prolongs when the ischemia, degree of ischemia increases, but when the tissue becomes totally dead, then it is shown as black in color. So the TTP may not be visible at all. So this is a completely dead tissue. Here is a hyperperfused tissue, and here is a perfusion is still relatively, it is much, much better compared to these areas. And finally, when the patient had the infarct, he had the infarct to the demarcated areas only. This is the mismatch where you should be careful if you have a large core. So this whole thing, green, you have the penumbra, and if you have a large core. So if you have a large core and small penumbra, these are not good candidates for reperfusion therapies. Now coming to few cases, a 65-year-old male, out of window stroke, cardioembolic stroke. He had an M2 inferior division occlusion on the CT angio. So let us just read the perfusion images. We see that the MTT is grossly prolonged here in the territory of the inferior division of the MCA. We see next go to the CBF. We see that the CBF is grossly reduced, but the CBV, which is reduced in this area, is the area which is going to be the infarct. So there, here, this patient, it was this M2 inferior division occlusion, which was then conservatively managed. So there is no mismatch between the TTP and the CBF. And the patient finally turned out to have the infarct like this. This is a 75-year-old male patient with a wake-up stroke, and there you can see the hyperdense clot in the distal M1, and the patient had a right hemiplegia, lower aspects, which is developing, and see the MTT, which is grossly prolonged in the entire MCA territory, go to the CBF, and the CBF is also, there is hardly any penumbra, very minimal penumbra, so this is a large core, so it's again, this is a red signal for not going for a reperfusion treatment. Patient was managed conservatively, developed the infarct in the demarcated areas of the perfusion, and went back with an MRS of 4. Another case, 65-year-old patient with a right hemiparesis, distal M2 occlusion, and then see the MTT, the distal M2 occlusion, this area, and these are two different cuts which are taken. And you see the perfusion, the TTP is grossly prolonged there. Immediately go to the CBF, and you see that there is a mismatch over here. This is the demarcated area which is going to develop the infarct fully, the one which is very dark blue in color. And similarly here you can see that there is a mismatch over here, and this patient was treated with lysis, and immediately post lysis there was clinical improvement, so treatment stopped with that, and patient had an infarct here in this demarcated area. Coming to another patient, 40-year-old patient with a right hemiplegia with a severe mitral stenosis, a hyperdense MCA sign indicating a large vessel occlusion. This hyperdense MCA, however, was secondary to a CC occlusion from here. So the MTT is prolonged over here, and you see that the CBV is only the CBV abnormality is confined to a smaller area when compared to the larger CBF abnormality. When you see these shades, if you also see, we mentioned about oligemia. So if you see that oligemia is also a hyperperfused area. Oligemia is the area where the blood volume is preserved, and this is the area which is going to become the core. So that is how the patient had the MRI. Another patient, 38-year-old patient who presented with acute left hemiplegia, disorientation. He came as a wake-up stroke, but he was a young stroke patient, and he did not have a DWI flare mismatch. But after the MRI, there was deterioration. He became progressively drowsy. These were his DWI images here. So definitely there was a clinico-radiological mismatch. This score did not explain his higher NIHSS. So this score was already demarcated, but his NIHSS was much worse. So we knew that there was a big penumbra. We went for an angiogram. The MR angio is showing the M1 occlusion there, mid M1 occlusion. The neck vessels appearing fairly normal. Went for a perfusion. The perfusion is showing a large area of perfusion abnormality, and the TTP is grossly prolonged. The CBF, which is, there is a good mismatch between the TTP and the CBF. And similarly, CBV is also reduced only in very small areas. Went ahead with the DSA. And the DSA, you can see, even though the PCOM is not visualized, you can see good leptomeningeal collaterals coming and filling the MCA territory. And then, so this is our protocol in SNF. In an occlusion, we go for one vertebral artery, the opposite carotid, and then we go to the symptomatic side. So we went to the opposite carotid, and we saw that the collaterals are filling in the later phase, filling, and reaching up to here. Now, at this point, two decisions were to be taken, whether to go for an endovascular or whether to leave alone. The nature has provided such excellent collaterals. Now, even before I could decide, the patient improved on table. The patient who had an NIHS of 22, suddenly this patient had a grade 0 power of the left side. He started, power became about grade 3 in the upper limb and lower limb about grade 4. He started talking, his gaze preference improved. So then I decided that when nature has taken care, why to perform the endovascular, left it as such, and a patient was managed conservatively. Of course, not lice, because no DW flare mismatch was not there. And the patient made a good recovery, walked back home, and went back to his driving profession normally with MRS of 0. Another patient, 69-year-old patient, diabetic hypertensive dyslipidemia with past history of multiple right hemispheric origin TIAs, which were unattended to. Presented in a 7-hour window period with acute left hemiplegia, gaze preference to right, and low GCS. We go to the MR images, we know very clearly that such small infarcts cannot present with such a high NIHSS. So then we know that there is a clinico-radiological mismatch. Here we are dealing with a possible LVO with a large penumbra. Imaging, we go to the angiogram. We see the neck angiogram, the carotid is visualized still here, and then the ICA is appearing. It's not seen, maybe a faint ICA filling here. And then from the opposite side, we see the ACA filling. So it's probably a tandem occlusion, a T occlusion here, and a probable carotid stenosis or whatever. So we go ahead with the MR perfusion before taking the decision for endovascular. And MR perfusion, the TTP is grossly prolonged in this area. We go to the CBF. The CBF is markedly reduced in this area, but the other areas it's relatively okay. And the CBV is also markedly reduced only in the area which was infarcted. The others was relatively preserved. So it was a small core and large penumbra. Patient would deteriorate even further. So this was an ideal candidate for mechanical thrombectomy. And the baseline images showed a bifurcation complex, critical, dirty looking lesion there, and a near occlusion of the carotid. Why near occlusion? Because on the run from the CCA, the ECA is filling fast, but the ICA is making a delayed antegrade filling and then stopping somewhere here, like what we described, what we thought that it was a T occlusion with tandem turned out to be the same. Then the opposite side, there we see that the collaterals are not great enough, and patient underwent the angioplasty followed by a distal thrombectomy and then followed by stenting, proximal stenting, which is the approach which we follow at SNF. And patient came with an MRS of 5, went back with an MRS of 4, and then over next 3 to 6 months became MRS 3, and now is about MRS 2 after 1 year. Another patient, 55-year-old. So it looks like a similar case. 55-year-old patient, acute motor aphasia and right hemiparesis. In the extended stroke window, there was a diffusion perfusion match. Means our diffusion core, though I have not put the pictures, the diffusion core was exactly corresponding. So this is a match. So this is the first alarm. And then we see on the angio, MR angio, we see that again here the carotid is completely occluded. ICA from its origin is occluded. And here again it's not filling. And this probably again a T occlusion, but there is a PCOM which is seen. There's a limited angio images which we have. But we see that this whole area, this whole side is hyperperfused with flow, which is cerebral blood flow, which is reduced only in this area which was DWI demarcated on the MRI. So this means for clear that this patient had a chronic occlusion which was well compensated. He was managed conservatively and made a good recovery. Another patient, 79-year-old male patient, diabetic hypertensive, very active patient, newly detected paroxysmal atrial fibrillation with fast ventricular rate, not on anticoagulation, presented with acute global aphasia, right dense hemiplegia in the 5-hour window period. There was a diffusion flare mismatch. As my previous speaker mentioned, that there is no beyond in the 6 hours, but at SNF we do it in cases where we need to have a more clear case selection and more of a tunneled case selection. So in patients who have a large infarct like this, large core like this, so we went ahead and then we saw that the TTP is prolonged in this whole area. This area is irretrievably, which is gone. The TTP is not measurable here. That is completely gone, but the area and it was a 5-hour window. So the CBV, you see the different shades are seen there. So there is a moderate mismatch, and there was a left M1 stem occlusion on the MRA. When we went ahead with the DSA, we found that there is an M1 occlusion beyond the origin of the takeoff of the anterior temporal artery. The M1 is occluded there. And then mechanical was done with 2 passes of combined treatment, and relatively good reperfusion was obtained. What did we achieve with this? Patient on the post-imaging had the infarct which was there in the DWI initially, but we avoided a decompression, and with gradual physiotherapy, patient became MRS 3 at 3 months. Now, is everything good in CT perfusion? No. CT perfusion, there are certain pitfalls and one should be aware of it. Both cerebral blood volume and blood flow are calculated using a deconvolution technique. So these can be affected by any condition in which there is a delay in the passage of the contrast bolus from the arterial to the venous end. That is, if there is an extracranial arterial stenosis or a CCF or a congestive cardiac failure or an atrial fibrillation. Therefore, CT perfusion should never be interpreted in isolation. The first step is clinical. Then you have the CT, plain CT or an MRI, then the vascular imaging, and then only the perfusion. Now, another thing is that all CT perfusion parameters are assessed by comparing with the normally appearing hemisphere. Now, consider a situation where the normally appearing hemisphere itself is abnormal. For example, if you perform a CT perfusion in a patient for evaluation of a left M1 occlusion, he will have a distorted CT perfusion map in the presence of an asymptomatic right extracranial carotid stenosis, which is causing a contrast delay. So, therefore, all images should be interpreted in the clinical context. And finally, I'll just like to end with two things. These are the ghost infarct core on CT perfusion. It was put forward in 2017, and there are clear indications of performing CT perfusion or MR perfusion after 7 hours. And this happens when the perfusion imaging is performed very early in the hyperacute stage within 3 hours. And what is ghost infarct is a large infarct which appears, or a size of the infarct is much more on the initial CT perfusion, and the final infarct says the day later on CT or MRI is much smaller. So that is the CT perfusion wrongly estimated or overestimated the core. And the reason given is that the CBV abnormality, which indicates the core, it just indicates absence of contrast arrival to that area. It does not mean that actual histological change or cell death or anything of that sort has happened, which as is reflected on the DWI. Therefore, it just means that it's the most severely hypoperfused area. It is likely to infarct at the earliest. So if we move ahead in a time-dependent fashion and go ahead with an early and complete recanalization, the ghost core may likely disappear. So therefore, in the early windows, interpret CT perfusion with caution and don't overdo the CT perfusions in the hyperacute early windows, unless indicated like in our case. The other extreme of that is the perfusion scotoma. Perfusion scotoma is an underestimation of the CT core in the delayed time window in patients with acute. That is more than 6 hour time window, which is the recommended window where CT perfusion is indicated. We find a small core infarct on CT perfusion, but the aspects is low. So if you take all the imaging studies together, we usually will not go into a wrong interpretation. When we know that the aspects is low, we know that the core has to be large, especially after 6 hours. But when we find a core which is small, it is a perfusion scotoma. This is present independent of the vendor used for application, about 20 to 30% cases. And this is due to early reperfusion from partial recanalization as well as luxury perfusion. So we should not go ahead with the good CT perfusion with a large, that is with a low aspects or a large core on the plain CT or the MR imaging and go ahead with endovascular, we may land up in trouble. So we should be aware of all the pitfalls also. And with these, I'd like to end my talk, and I give my sincere gratitude to Professor Shakir Hussain sir, who has been our mentor and guiding light and guided us through this difficult journey of neuroendovascular treatment. Thank you, sir. Thank you, Dr. Sridhar, sir. Yeah, no. Yeah.
All the images which he showed is MR perfusion. In fact, if you do have a CT perfusion, and if you do a CT angio, I think we do in BMH, CT angio and followed by CT perfusion, that gives a very good delineation of the arteries and the correlation between leptomeningeal collaterals and perfusion. That gives actually an insight to the way we can interpret based on CT, leptomeningeal collateral itself. So you want to comment, sir? Because, yeah. So basically this actually, if you use MR perfusion, it won't really clearly give an understanding. You can have a mental map within leptomeningeal collaterals and this what you call perfusion abnormalities. So that actually, if you do an MR perfusion, you don't really get. Is more, while on the contrary, if you are doing CT perfusion and along with you do a CT angiography, you can just based on CT angiography, we can interpret data. So that initially you need to have a practice of that. After some time, you as an ECG pattern, you get a mental picture how a leptomeningeal collaterals correlate with the perfusion score. I think Dr. Shakir will come.
This is a very important point, and I think this is often a question or the debate or the confusion in the mind of the people. In fact, who are even practicing primarily the stroke medicine, I would call it. whether interventional or non-interventional, because it's the major difference in the qualitative outcome or the beneficial aspect of the treatment of revascularization remains in the case selection. That's the most important thing. So if you have a right case selection, your outcome is going to be good. Because sometimes withholding a hand, like Dr. MP showed some of the examples, you are ready with your catheters and your devices in your hand. But if you are not judgmental and you are only mechanistic, you will go ahead and open the artery because the artery is blocked still. But when you apply your rationale of, the thinking that what my procedural uh, recanalization, which will be pictorially very beautiful, would necessarily or 100% translate into a good outcome. Because the natural history is going like in the patient when you are performing a angiogram itself and patient from 0 become to the power of 3. It's a very remarkable, the difference in the outcome. That means the collaterals are very robust and they are maturing to supply or reduce the penumbra or the oligemia very fast. So what we are, end of the day, we are concerned is the clinical recovery, not the pictorial, the recanalization. That's a very important and fundamental point everyone has to keep in mind. Because what is happening in the present world of mechanical thrombectomy, people will show you a nice picture that vessel occluded, vessel open. Now, these two things are only temporary gratifications, actually. And we should not indulge into these things. We should be critical in analysis. Still, the literature is not talking about the mechanistic world of West, particularly, I would call it, is not talking about another phenomena which we deal with is a secondary stroke while you're performing a procedure, right? You recanalize the M1, but now you occluded one of the opercular branch, which is more disastrous, more problematic than the M1 occlusion. Because M1 occlusion, and there is a one dictum which I have synthesized, and it's just yet not published. And I think this concept we have to publish and the point of view is that the more proximal is the occlusion, better it is. More distal is occlusion, it is a problem. Both for the neurological deficit reversibility, whether you use IV thrombolysis or mechanical thrombolysis, it would not reverse. Why it is so? I think Siddhitesh is going to talk about, the collateral circulation, that more distal you go, the collateral circulation, if it is there, it is there. If it is not, it is rapidly falling into a core. So if you, and that's where those who are interested, you can read a recently published article that we have written on medium vessel occlusion, which is becoming very popular. And every conference, there are plenty of, the lectures. It is well understood. It has no role, in my view. More distal you go in your recanalization, poor is the result outcome. And this has already been demonstrated in IV thrombolytic studies. So read this article published in Indian Academy of Neurology as a viewpoint. I think 2 or 3 months back, we have published it. Well, apart from this, the most important confusing point is that what modality, as Dr. Siddhitesh said, that CT angiography gives you a very good perspective on everything. That's no doubt about it. Because it is a contrast-based, what you call perfusion that you are seeing. So if you do a multi-stage angiographic, multiphasic angiographic imaging, you can actually substitute with the perfusion study. You don't need to do the perfusion study. But I do not recommend in the beginning, as we said always in our forum of teaching, that first you adapt yourself to the very good understanding on CT perfusion. Don't run to the Western guidelines. They are right. They're perfect, actually. But they're applied to their environment. Because they have learned through, and their whole system has learned through the analysis of the CT perfusion and then going to the multiphasic CT angiographic examination. Now, if I apply the same parameter here, I would be very sure that not more than 10% of the people sitting in any audience will be able to understand it, actually, because you have not understood CT perfusion adequately. First, understand CT perfusion. The moment you understand CT perfusion, that means cerebral blood flow. It's a simple thing. It's not a complicated matter. So once you learn that, then what Shishite said is very, very important. And it is already been published by the Toronto group. Mayank has published a nice paper on it, that multiphasic CT can replace the actually, or you can substitute with the perfusion instead. Don't waste time or contrast, which you give additional contrast in these cases. So that is a very important point, but don't leave your practice at the moment of learning CT perfusion. That's one thing. Now, when we go with the CT perfusion study, what we miss is a problem in an atypical stroke. What we mean by the atypical stroke, any stroke which is happening with an unknown window period, or a wake-up stroke, or no history available. The patient is brought to your casualty by some people, or by the police department, or by somebody, the social service workers. We do not know the history, so we do not know the window period. So there are atypical group of patients. Secondly, you are not sure whether it is a stroke, especially what happens in a basilar stroke. You know, the patient is unconscious. You're not able to understand it. So in those situations, you have to go to the MR protocol. And that is a front line. Now, when you go to the MR protocol, you have to depend on MR imaging, on vascular imaging, just to document if there is a LVO. That's it. But if you have to understand the perfusion, which can be in a CT perfusion, can be substituted by the multiphasic angiographic examination. You don't have equivalent in the MR angiographic imaging so far. So that is something which you must clearly understand. Once you understand this difference, then you are very clear in your judgment in clinical sense that which direction I have to decide and go. So what we do in our acute phase of revascularization, I don't bother whether it is a large vessel occlusion or a small vessel occlusion, or whether I do it with the IV lysis or with the thrombectomy. That's not the question. The decision will remain same in both the approaches. Now we are more objective in IV thrombolysis. If there is no large vessel occlusion, if there is no medium vessel occlusion, will you go for thrombolysis? How many of you will go for thrombolysis? Okay. How many will not go for thrombolysis? There's nobody. And how many? So the rest are unclear. So there is about 10% population still says that we'll go for the thrombolysis. But in my view, it is a futile thrombolysis. Simple reason. It's a perforator stroke. It's a lacunar stroke. And you recanalize or you don't recanalize, and you don't recanalize the perforators with IV thrombolysis. So it's a useless exercise to give the IV thrombolysis. In our environment, it is useless also from the economic point of view, where you have to conserve the cost of the treatment. So these are some of the things which are still unclear in the guideline or literature. But as a practitioner, as a knowledge and the clarity of the mechanism and the effectiveness of a therapy or the indication of a therapy is very clear, where we should do it. So then why we should not apply to our people actually, which is a different population to be applied for. So this is a very important thing, and more such exercises that you do again and again, which we have synthesized in our SNF protocol. Dr. Rimpi was mentioning our SNF protocol. What exactly the SNF protocol means is a continuity of the same pattern of approach repetitively in a very objective manner, not in a subjective way, that because I decide not to do and I decide to do. However, on the other side, what we are confronting today is another new knowledge base, or I would not say knowledge base. It's a statistical knowledge base which is coming into the fora, is a large core thrombectomy, which I surprised that it's a very stupid way to do the things. And the answer to this is, again, I can do a scientific answer is that when we did IMS3 trial and IMS2 trial before, and at that time we were not even agreeing to do the recanalization, even in a strongly indicated case of M1 or a large vessel occlusion, which failed. Then how can we justify that in a large core and you do a thrombectomy now? These are two paradoxical scientific statements in a period of about 1.5 decades. I'm seeing in my own practice, the same group of people, same research group, were objecting to do any intra-arterial thrombolysis even. Now they say do thrombolysis or thrombectomy in every case. Yes, usually it's something else there. And what is there, I want to make an introduction to this terminology because this is the reality of the world. And that is a industrial dominance. We are not a scientist only by ourselves. Every research people, there are many research people here in this institute, the National Institute. They have to depend on a grant. Now, usually the government grants are reducing down. NIH grants are grossly reduced down. So globally, the major grants were coming from American and European environment. But those grants are reduced to very, very low. So the grants are now coming from the private sector, the industry. So when the industry is investing into the research, they have a bias and pathway to guide and decide in some or other way, using the statistical tools to make you agreeable to the publications which are there, right? So be judgmental, be scientific and objective. So that is something which I think I would like to make a comment. We can discuss more and more on these points. Dr. Siddesh will talk about collateral circulation.
Thank you for speaking on concepts of perfusion imaging. Speaker is Dr. Shilta sir, stroke.
So I'll be discussing on collaterals and imaging protocols in stroke. So this is kind of a, there are certain medical officers and all I called. So it is a kind of a toned down version. Now, how many people are outside the NIMHANS? Come from outside NIMHANS? Okay. So essentially, I just toned down the vocabulary. You may not understand everything, but like medical officers and physicians may not understand everything, but I think they need to have a mental map of the vocabulary at least. So this is a very short, simple presentation. So why do some patients survive arterial occlusion for hours while others infarct within minutes? Well, this is the essential question. And the answer is that brain is a highly collateralized organ, highly metabolically active, about 20% of the cardiac output, and is quite precious. And so nature has provided channels for the brain to sustain injury, especially vascular injury. And this is anatomical circle of Willis connected by the communicating arteries. And the communicating arteries essentially have a robust mechanism. It supplies from one side to opposite side. And generally, you won't, in fact, if the actual incidence of stroke, actual incidence of what you call arterial occlusion, we may never know, because what is evident is when the collaterals fail. So the actual incidence of arterial occlusion may be much, much higher than the clinical stroke. So you have the collaterals or the major vessels connected by leptomeningeal arteries. This is MCA, ACA, MCA, PCA, MCA, and then also the external carotid communicate with the internal carotid. And so these are very robust mechanisms. And this is another cartoon. So now you have a primary Willisian collaterals and the secondary collaterals, which are leptomeningeal collaterals combined, connecting MCA, PCA, PCA, MCA, ACA, and all. So this provide a very robust autoregulation mechanism. And if you look at the CT angio, the leptomeningeal collaterals can be really visualized, and that actually give a very good mental map what happens to your patient. Now, in this first panel, you have this cutoff, MCA, middle cerebral artery cutoff, but you have a very robust collateral. In fact, you can't differentiate between the right and left. So while the second panel, there is a cutoff, but some hypodensity. The collaterals are not. See, the hypodensity, it means that collaterals you can see, but it is somewhat reduced. And here, it is completely, it is hypodense. Now, the lower one, the third panel will perform better, poorly. You have to revascularize within 15 minutes. Otherwise, it won't work. While this patient will sustain ischemia for quite a long time, the first panel. So collaterals, especially leptomeningeal collaterals, underline the biological difference between patients who have rapid onset, large infarct versus smaller infarcts. And that differentiate between fast progressors versus slow progressors. So the true incidence of arterial occlusion we may never know, because many of the occlusion remain clinically silent because collateral circulation compensates. Clinical strokes happen when collateral circulations fail. So we can determine the outcome of stroke based on the CT angiography imaging of patient acquired along with the initial CT scan. It gives better estimate of the extent of infarction than plain CT, and almost similar to the estimate of MR imaging. I will show that. Now, outcome of acute stroke treatment is based on the extent of damage before the treatment is initiated. And we know it is called as infarct load. So we call it as a code. And then common parlance, the infarct load is determined by what is known as aspect score. Our neurology residents know that. For the benefit of other people, just want to explain it. It's a semi-quantitative measure of infarct volume measured on the MCA territory. You have 10 points. So you have this caudate nucleus, internal capsule, lentiform nucleus, insula, M1, M2, M3 at the level of capsule, basal capsule, and then one cut above, M4, M5, M6, anterior MCA, middle MCA, and posterior MCA. So this is the MCA territory, and this is the ACA territory. So we are mapping the MCA territory, and the most common cause of stroke is MCA obvious. So that's the reason this aspect was developed on MCA. So aspect score has 10 points. So full score is 10, means normal looking brain, and you minus areas where there are early ischemic changes. What do you know call as EIC? If you have 2 areas showing EIC, aspect is 8. Anything above 7 or above is good. Less infarct. That's the original study. Now we have the concept of 6 coming up. And in fact, we had done a study in NIMHANS. So actually the outcome determines upon how rapidly you recanalize. So when we looked at the study data from NIMHANS, we found that only 8 and above really give a good outcome. 7 is neutral, and 6 you don't get good outcome at all. So essentially, these are all dynamic phenomena. It's not 6 is not a kind of a hard cutoff. 6 actually, I think that it's mainly developed because they want to include more patients for mechanical thrombectomy. 6 patients generally don't work. Actually, you need to have very good workflow, very good recanalization to get a good outcome with 6. So that we'll discuss later. But I do consider 7 or above is good. So now the early ischemic change is very tricky. It is very subtle, easy to miss, especially for beginners. So what are early ischemic changes? Loss of gray white representation, obscuration of lentiform nucleus, swelling causing loss of normal cell C, which is called cortical sulcal effacement, and subtle hypodensity on the brain parenchyma, which is known as hypoattenuation. Now, human eye is able to differentiate only 20 to 30 shades of gray. And there is a lot of inter-observed variability. People guess things. So there is a huge inter-observed variability to detect early ischemic changes, and especially for beginners. So, but on the contrary, the leptomeningeal collaterals won't give that kind of error. Here, the inter-observed variability between this and this are very less. So my PDF student Anush has done a very good study. So we've looked at the inter-observable variability between NCCT and CTA aspect. So it is very low. So in NCCT is 0.83, while CTA, if you use CTA, leptomeningeal collaterals is about 0.91. So in this panel, if you look at it, this is the leptomeningeal collaterals absent here. And in the subsequent MR, if you do, exactly that area you get infarct. And the perfusion defect also is in the same area. While if you look at the plain CT, you can't differentiate. It's very difficult to differentiate. But there's a lot of inter-observable. People generally guess. So in my practice, I don't rely on plain CT at all. I always look at the leptomeningeal collaterals. So we have to, I advocate very strongly to use CT angio aspects. This actually reflects the cerebral bed for oligolim and predicts infarct core. This is as sensitive as diffusion weighted imaging. And we had done that study. So this is a case of middle cerebral artery with poor collaterals. You have a cutoff here. See, there's no leptomeningeal collateral at all. While here, there is a cutoff. It's all perfused. So the tissue has been sustained. Now, the caveats for CT scanner interpretation is that you need to get a good quality CT angio. You can't get a good quality CTU if the slice length is less than 64. Best is between 128 and 320. I think we have 128. Slice means the number of detectors in the CT detector. So you have in 64 slice, you have 4 detector rows, and that rotates around, and the body moves in Z direction here. So that many of the government hospitals, they don't have a good quality CT scan. So this, we had done a survey and all. So most of the government hospitals, they provide less than the very poor quality. They can't acquire CT angio. But CT angio, without acquiring CT angio, you can't do stroke work. This is an essential sine qua non. So this is one important thing. People need to understand that you need to have a good quality CT, and the good quality CT is about more than CT, and you need to acquire CT angio. Without that, you can't do, because in the initial hyperacute state, what is your interest is the arteries. It is not the parenchyma will look normal. We want to differentiate, but you need to have, you're interested to look at the arteries. So this is the study done by Anush. So we compare the CT angio and NCCT. CT angio aspect was NCCT aspect. So CT angio aspect is about comparing with the 24-hour MRI flare aspect in a patient who had rapid recognition within 1 hour period. So CT angio almost mapped to the final 24-hour MR flare aspect. So essentially, collaterals sustain the tissue with perfusion until the proximal occlusion is removed. So the dictum is that it is the collaterals which are the reason why we are able to treat patients. So with this context, let me revisit the imaging protocol. So in our center, we have this acute stroke green channel. So we triage the patient within 10 minutes and do a CT. The bleed is there, we withhold a protocol, we'll abort the protocol, or the CT infarct is more less than 5, we'll stop the protocol. And then if on the contrary, the CT aspect is more than 5, we do a CT angio, the stroke protocol. And if you have a favorable CT aspect, we go ahead with the bridging or the direct thrombectomy based on the how many hours is the onset. So essentially, we have a clinical diagnosis of acute stroke, and then onset to presentation is less than 6 hours. You do plain CT to exclude bleed. Now, if no bleed, CT angiography is done in the same setting within 5 minutes. All our data shows that it's less than 10 minutes. I think within 5 minutes, you can acquire a CT angio. And if it's more than 6 hours after the onset of, or you have the onset is not clear, you do an MR protocol, brain stroke protocol. In places like Zurich and even BMH, we do CT perfusion is done before CT angio. Okay, CT angio is first acquired and then CT perfusion is done in all patients. And this is a very important exercise because this helps the beginners to get a map between CT perfusion and CT terminal collaterals and all. So this will give a so now I rely only on CT angiography. I don't want any perfusion studies. So, but that can be acquired. If you do combine CT perfusion with CT angiography, it will be really good. But I think we can work with CT angiography itself. On posterior circulation stroke or unknown onset stroke, you need to have a mandatory MRI because these areas we can't image properly with CT angio. So the posterior circulation stroke protocol is diffusion, flare, SWI, and MRI. And in unknown onset, you have to do MR perfusion as well. So another important thing is DWI positive and flare negative. It is not actually a mismatch. It's basically negative or positive. So what happened is that mismatch concept came from CT perfusion and MR perfusion. Here, the actual concept is DWI positive, flare negative. So you have a DWI sequence which show signal positive and flare is negative in the same region. And that is generally predictive of symptom onset within 4.5 to 6 hours before the imaging. So here you have a case, you have a DWI positive, flare is negative. And this is a very good, actually you can counter check your judgment using this as well. For the acute management, you can just counter check 2 different parameters that give a confidence in your analysis. So the other extended window protocols all came on this basis. There are 2 major trials, Diffuse 3 and Dawn. Diffuse 3 use MR-based protocol, and while Dawn used the clinico-radiological mismatch. So essentially, you have a large vessel occlusion patients, proximal M1 or distal ICA, with low infarct core, less than 70 mm. Now, less than 70 mm approximates to aspect more than 7. One aspect is about approximately 30 infarct core. And perfusion, and this excludes the issue, we should exclude the basal ganglia. Basal ganglia behave differently. This is essentially the MCA territory. And perfusion defect should be double the diffusion defect. This is actual ratio is 1.8 in diffuse 3 trial, and the clinical imaging mismatch in the DAWN trial. So here you have an infarct out here, the diffusion restriction here, and the perfusion is roughly 1.8 or more than 2. So there's a diffusion. And here you have a patient who NIHs of 20, but the CT scan is looking almost normal. This is a clinical radiological mismatch. The point is that the mechanism that undercut all these protocols is the collaterals that sustain the perfusion in the event of an arterial occlusion. And this understanding greatly simplify and, in fact, demystify our approach to the management of hyperacute stroke. So it helps us to make deviation from the clinical trial drive cutoff. We had thrombolyzed many patients with 6 hours, 5 hours based on IV thrombolysis based on the left atrial collateral alone. And this can also predict the outcome of a given patient, improve clinical outcome of a patient. Also, your confidence, actually the clinician's confidence in to prognosticate what is going to happen to the patient. But that actually you have to understand, correlate the clinical outcome with your radiological judgment. That gives a real confidence, and you can make decisions at any with absolute confidence. So you can make deviations from the clinical trial cutoffs. That's an important point, everyone. So as a clinicians, we have to make judgment, and that should not be completely based on the guidelines. So that this kind of understanding, biological understanding, and actually radiology is biology, of course. So will help you to. So essentially collaterals are important. It's very important to understand collaterals and how the dynamics of collaterals, infarcts, and the outcome. So as during the neurology residency, you have to learn to look at collaterals. Thank you. Any questions here?
Thank you, sir. Of collateral circulation. Now we will break for tea shortly in 15 minutes.
Oh, yes. Yes.
Welcome back, everyone. Let's begin our second session. Our second session is Extended Windows, Intervention and Complication, which discusses patient selection beyond conventional treatment windows and advances in endovascular therapy. Our first speaker is Dr. Preetham Raja sir, who will speak on stroke in extended or unknown time windows. He's associate professor in NHANS with a special interest in hyperacute stroke management workflows and stroke therapeutics. We welcome you, sir.
Good morning, everyone. First, I'd like to thank Dr. Srijitesh sir for inviting me for this talk. So today I'll be speaking on stroke in extended and unknown time window. So from morning, we know that what is stroke? It is a neurological deficit attributed to an acute focal injury of the CNS by a vascular cause. We know brief about what is core, what is penumbra. So our target is to save the penumbra so that the infarct tissue should not grow further, and we have to intervene as early as possible. So we already we know that time is brain. So the each minute lost, there will be loss of almost 2 million neuron, and there will be accelerated aging of 3.1 week. So as the time passes, we can see the penumbra size will reduce and the core infarct will increase. And once the core will increase, the chances of disability will be more and the mortality will be high. So what is the current standard for IVT? As of now, we know that we can thrombolize patient within 4.5 hours if they comes and patient has low aspect. High more than 6 aspect, we can easily thrombolize. Lower aspect, we have to see whether we can thrombolize or not. But whether is this 4.5-hour window is still an absolute cutoff for the IV thrombolysis? I don't, maybe how many of you think that 4.5 hour is an absolute cutoff? We can't go beyond. So I think only one person can think, is thinking that it is an absolute cutoff. But it may not be, because there are evidences which support that we can give thrombolysis beyond 4.5 hours. So now earlier what our thinking was, time is brain. From there, now it has changed to tissue is brain. So we can see there is an example of 3 patients who has 8 hours of stroke onset. We can see their difference in the core as well as the penumbra area. The third candidate, which is having a large penumbra, that patient is a good candidate for thrombolysis even after 4.5 hours or something. So now we have to see whether we can save the tissue, and while saving the tissue, we should not harm the patient. So it should be like if a patient chances of hemorrhage is high, then also we should contain ourselves so that we should not go for an aggressive treatment. And what factor will decide whether we should go ahead for thrombolysis and or not? The core volume, the penumbra, the collaterals, and the aspect scoring. So now we need to find out what and all evidences we have for IVT beyond the 4.5 hour. So these are the trials from 2008 to 24. There are various trials which has been done on various time period for IVT, from FTHET trial to Wake Up trial, Extend, Trace 3, Timeless, and those trials and twist trials all are there. So in Wake Up trial, what they try to find out that whether based on if a patient comes within wake up period, whether based on diffusion and flare mismatch, whether we can identify any patient which like if a patient has diffusion flare mismatch, that suggests that the patient the stroke might be within 4.5 hours. So in that case, if like diffusion flare mismatch is there, we can still go ahead for thrombolysis. And they found that the better functional independence means the adjusted odds ratio was 1.61. So 1.6 higher odds is there for a better functional independence if we give alteplase in a wake up stroke if there is a diffusion flare mismatch. So you can see this is the patient 1 and this is the patient 2. Which one would you like to intervene? This is the patient one. The right half is means your diffusion scan. The other side is flare scan. And in this one, this is the right half is the flare and the other side is diffusion. Which, how many of you think that patient one we should intervene? Nobody. There is clear-cut diffusion flare mismatch. I think if once diffusion flare mismatch is there, we should consider thrombolysis. Okay. And the other patient, if you see, the flare is also same signal changes and the diffusion is also same. So in this condition, ideally we should not intervene. And any of the infarct size is almost more than 1/3 of the MCA territory. Then the another trial, which was like extend trial, what they have done is they have selected like patient ischemic core is less than 70 ml and the presence of salvageable penumbra should be there on perfusion imaging. So what they have done, they have taken the perfusion imaging and the core volume, I think from you might have understood now, when CBF, the cerebral blood flow is less than 30%, it is 30% of the normal, it is a core volume. So if core volume is less than 70 ml, means core is less, but the salvageable tissue are there. So in that condition, still we can go ahead with thrombolysis up to 9 hours. And what we found in this study was that the chances of higher functional outcome will be 1.44 times odds of like if a patient we manage with medical treatment. So still in till 9 hours, we can do in a selected patient if we have ischemic core of less than 70 ml and salvageable penumbra is there. So in this one, I think you can see this is cerebral blood volume, which is flow is less, and the Tmax or TTP, which is you can see that there is significant difference is there. But the infarct size now, apart from that, we need to see whether clinically also how is the patient. If it is NIHS is very low, then there is no point in giving means. But according to criteria, you can see there is a difference between the core area and the penumbra area. So still there are salvageable tissue, so we can go ahead with thrombolysis. Then this is a twist trial. Twist trial, what they have found, they thought that maybe like based on non-CT only we can do the thrombolysis or not. If we can select based on non-CT, if infarct size is less, and based on that whether we can do means thrombolysis or not. In this study, they have not found any significant difference in the functional outcome. Means within 4.5 hour, and that like a patient comes within 4.5 hour of wake up. If you do thrombolysis or medical management, they have not found any significant outcome. And like mortality also, there was no significant difference after 3 months. So this is the meta-analysis which consider all the patients which underwent thrombolysis within 4.5 hour to 9 hour, including all the wake-up stroke, based on the perfusion imaging. And they found that in each category, if you see the age category, the NIHS category, that various category, in that all favor the we should give alteplase in patient. And if perfusion mismatch is there, the odds is further high. It is 2.06. If they will not consider perfusion mismatch, then odds is 1.686. But if perfusion mismatch is there, then the odds is 2.06. So this favor the use of alteplase till 9 hours of stroke onset. Then this is same data. They are showing there are significant difference in the outcome was there if you intervene after in comparison to the medical treatment. So what about patient beyond 9 hours? Till 9 hours, okay, fine. We have evidence that we can thrombolyze, okay, in selected patient. But beyond 9 hours, whether we can thrombolyze or not. So this is a study which include patient from 4.5 hour to 24 hour based on the perfusion imaging selection. And in this timeless trial, they try to see, but they did not find any, they did not find the improvement in MRS score after 90 days or functional independence, means better functional independence in patient with tenecteplase. But problem with this study was that almost 70% of the patient in each group, they received thrombectomy too. So once they receive thrombectomy, this will means equalize the effect of whatever thrombolysis we already have given. So there is another study. Another study was there which include tenecteplase for ischemic stroke in patient 4.5 hour to 24 hour without thrombectomy. Those patients who is like very far place from endovascular area, or who chances of endovascular intervention is less, those patients they have included, and in that condition they found that there are chances of improved outcome is there even till 24 hour of stroke onset. So these are the overall trial which has been done beyond 4.5 hour of normal window, and till 9 hour still we have evidence, but for 24 hour we need a further research, and whether we can still select some selected patient or not, we are not sure. So what guidelines says? The European guideline, which was published in 2021, recommend thrombolysis with alteplase for patient presenting within 4.5 to 9 hours of onset, or whose time of stroke onset is unknown, who meets the imaging criteria of extent trial. That was less than 70 ml core area, and the salvageable tissue should be there. Then the next, this is the AHA guideline, which also suggests that if advanced imaging parameter that suggests salvageable brain tissue is there, we can go ahead with thrombolysis, and patient may have better outcome. Then endovascular. Again, same question will come. How many of you feel that thrombectomy can be performed beyond 6 hours? And how many of you feel that we can do thrombectomy beyond 24 hours? First is beyond 6 hours, how many of you feel? So almost all of them, because these trials are there from last 8 to 9 years. So how many of think beyond 24 hours? I think nobody. So let's see what evidences says. So earlier we have, I think in 2018 and all, we have Dawn and diffuse trials based on, we have to select tissue based on different criteria. So what in Dawn they have used, there is clinical and imaging mismatch. If a patient has infarct area, which is seen in a CT aspect or an MRI, it is less, but the NIH score is high, means suggests that the still there are that other area of the brain which is involved, and chances is that if we intervene now, the improvement, those area of the brain can be saved. So in Dawn trial, they have used clinical and imaging mismatch. Then diffuse trial, they used the perfusion mismatch, which is the same, like core volume should be less than 70, mismatch ratio between core and penumbra should be more than 1.8. And both of them, the functional independence was very high, and it was seen that number needed to treat was 2.8 for Dawn trial, and number needed to treat for a diffuse trial was 3.6. So this is the same means area. We have to see the first patient. We can see there is a cerebral blood volume less than means. So we need to see whether the mismatch is there or not there. So the cerebral blood means the core area is 0, and the penumbra is 1.104. So it mismatch ratio is there. So we can do it means endovascular. The other case we can see the means core ratio is core area is 58, and the perfusion is 108 ml. So there is a mismatch ratio is almost around 2 means sorry 1.3. So it will be maybe if it is less than 1.3, we can means we have to think whether we can go ahead or not, because it is risky. Those cases are risky, but it may not follow the guideline. So then this is the meta-analysis which is done means for a stroke means like endovascular intervention beyond 6 hours. And in this also we found that if a patient underwent what you call mechanical thrombectomy, the ratio of odds of means 2.78% chances are there, more odds are there to get a better functional outcome. So these are the various criteria they have used, like they have chosen that aspect should be more than 5 to 6 in various trial, and their NIH score also they have selected based on, and the timing of means like window they have selected in various different trial from 6 to 24 hours. And overall they found that in treatment group, the 90-day MRS is more in comparison to the control group. You can see the control group is here, the MRS till 2 will be here, and the treatment group, the MRS is means more number of patients have MRS 2. So this suggests that still means we can intervene beyond 6 hours and in selected cases. So the same outcome they are doing. And they have studied in different age parameter and male and gender and NIHS, different NIHS scoring and all favor the chances of good function outcome if you intervene beyond 6 hours. Now, whether thrombectomy can be performed with beyond 24 hours, now we have to see what evidences are saying. So this is the meta-analysis which is done, which includes 6 trials, which had patient beyond 24 hours. And you can see the forest plot, still it is crossing the midline. Still it is crossing the midline. So the MRS score functional outcome 0 to 2 is not means statistically significant higher in patient who intervene or manage on medical treatment. The ICH ratio was also same. The mortality was also almost same. So we cannot conclude based on that, based on this meta-analysis, whether still we can go ahead beyond 24 hours or not. So these are the various other meta-analysis which is done, and they have compared in all meta-analysis. The result will be result are same only. So now they have tried to see whether based on aspect scoring, whether we can do ahead, we can go ahead with this thing, like means we can do the thrombectomy or not, or we can intervene the patient or not. So in that also they have found that means in aspect scoring, the functional outcome, there is no difference between the 0. If you see the second row, the functional outcome 0 to 3 MRS, there is no difference between the 0 to 6 hour and 6 to 24 hour. So this suggests that aspect also we can use as a criteria, but still we need a further study. As of now, we should use only perfusion scanning to confirm perfusion scan to confirm that whether we should go ahead for this thing or clinical mismatch. I feel that clinical mismatch is easier than to do perfusion scanning. The clinical mismatch with the core area means either aspect or the DWI core area. If it is mismatch is there, then we can go ahead for endovascular intervention. So now next is that what about posterior circulation stroke? So this is the attention trial which try to intervene the patient with posterior circulation stroke within 12 hours of stroke onset. And they found that the odds of getting better outcome was 2.06. So still, if a patient come within 12 hours, or this is the next study which they have done for 24 hours, and in that also they found that means we can still get a better outcome if we select some specific patient means for endovascular intervention. So so that is. Then what guidelines says? So guidelines say, if you see the first this paragraph, the aspect, if it is 6 to 10, then the means the evidence is A group, A level of evidence is A, and the recommendation is 1. 1 is high recommendation. So if an aspect is 6 to 10, we can do thrombectomy within 6 to 24 hours. If aspect is means in selected patient, whatever criteria they have given, like MRS should be less than 0 pre-MRS, and aspect should be more than 6, and the NIHS should be more than 6. Then if you see in a lower aspect, whether we can do head guideline says that still if a lower aspect like 3 to 5 is there, we can do it. But we need to select some specific patient, and we need to see which area of the brain is infarcted. If basal ganglia infarct is there, the chances of hemorrhage will be high. That it may not be written in the guideline. But once you experience all those things, you will get to know if this area, basal ganglia area infarct, the chances of hemorrhage will be high. So this aspect, low aspect, we should be a little careful. However, the means evidence-wise, it is means level 1 and a group of evidence is there. So still we can go ahead with low aspect means we can do the thrombectomy. And in thrombectomy with aspect, I think this is 0 to 6 hours. Okay, so now then what is there for posterior circulation stroke? Posterior circulation also if MRS is 0 to pre-MRS is 0 to 1, NIHS score is more than 10, and the posterior circulation aspect is more than 6, then still we have a recommendation 1 which is means highly recommended with a level of evidence A, means there are RCT and all, so we can still go ahead with like endovascular intervention in posterior circulation stroke if a patient has NIH score of more than 10. But if NIH score is less than 10, 6 to 9, then still there are randomized trial, but the recommendation is 2B, which is low recommendation. So we need to see based on clinician, we can, if you want to do it, you have to see what will be the benefit and all. Then the similar in pediatric case, if a patient is 6-year-old and with acute neurological symptom with large vessel occlusion, 6 to 24-hour onset, the EVT can be effective to improve functional outcome. But the recommendation level is 2A, which is moderate recommendation, and it is based on the non-randomized trial. And if a pediatric patient age between 28 to 6 year, 28 days to 6 year, mean neonatal period to 6 year, the presented with large vessel occlusion and potentially salvageable tissue, then the level means recommendation is 2B. It is low weekly recommended. So overall, the take-home message is that tissue viability means we should focus on tissue, whether we can salvage some means how much percentage of tissue. Based on that, we should decide. We can do the advanced imaging and in selected patient. Still means we can, if based on advanced imaging, we can still go ahead for mechanical thrombectomy till 24-hour. Evidence suggests that thrombectomy beyond 24 may benefit carefully if we select the patient carefully, but further randomized trial is needed. The rapid identification of salvageable brain tissue remain the key to improve the functional outcome after stroke. Thank you.
Posterior circulation aspect, that's not at all validated. And that will never validate because you can't really map it properly. The collaterals cannot be mapped to it. On the contrary, if you use aspect, instead of plain aspect, you try to use CT angio aspect. And that will completely change your understanding of stroke. So that give a try. After this workshop, you just give a try. So that will, you will have a huge understanding on the biology of how stroke is happening. And you can just go beyond the guidelines recommendations.
Thank you, sir, for such wonderful review and emphasis on careful patient selection and extended window. Our next speaker is Dr. Anand, sir, who will present on mechanical thrombectomy, how it is done. He is from BMH, Calicut, with areas of specialization in intracranial aneurysmal diagnostics and acute stroke thrombolytics. Welcome, sir.
Morning all. First of all, I thank Professor Sridhar sir and Professor Shaki sir for giving me this opportunity. So we talk on mechanical thrombectomy, how we do it in SNF.
This one. Copy. Copy. Where is it? Final PPT. It's not copy. This one is this. Did this you control? Yeah. Oh, you can apply this one. But like how to. So what? Which one is that? Actually, I know. This one is not. But no, it's not working. Copy actually. I was copied actually. You want to copy once more? This is your drawing. This is a drawing, right? Hmm? Okay. Okay. Huh? 2%. Copy. Let's copy. Copy. Let's copy. Yeah. Once more I will check. Save coming PPT. Replace file. No, why you done again? It will take time.
Last time I copied it, they didn't copy.
No, no, you cancel this one and eject this one, otherwise the file will not be properly.
Okay.
Cancel, one. Cancel this one. Where is the folder? There is it. Oh,
Reading.
not really. Take one.
So, topic today given to me is mechanical thrombectomy, how we treat sniff. So we go through some practical examples, case examples. So the revascularization strategies in mechanical thrombectomy involves suction thrombectomy, a combined suction plus stent retriever approach, and intraarterial drug therapy. Drug therapy can be used in the form of an antiplatelet or a fibrinolytic. And suction is the most non-traumatic, atraumatic way of retrieving the clot, as it causes less trauma to the endothelium as compared to the stent retriever thrombectomy. Usually it is the first mode of, that's what we employ first, because it's an atraumatic way. This is the first method we employ for retrieving a clot. If it is not successful, then we go ahead with a combined approach. And the challenges are usually in suction, the major challenges encountered are very hard, well-organized clot. It's very difficult to retrieve. A white platelet-rich clot is also difficult to retrieve, especially thrombus associated with malignancy-associated thrombus, which is very sticky and it's adherent to the wall. That's very difficult to retrieve. Clots more than 4 millimeter, they have a tendency to fragment and distally embolize, especially in post-IV lysis. And when there is unfavorable anatomy is also another challenge posed in the case of thrombectomy. So this is the schema for a thrombectomy. This is a guide catheter. You place the guide catheter in the high cervical area, and through which you take an intermediate catheter in and pass a micro catheter and a wire with the help of a wire and cross the clot. And then we engage this intermediate catheter into the clot. We engulf the clot and then we suck it out using a suction machine. And this is the stent retriever approach, the combined approach. Here you have an intermediate catheter. You can see the intermediate catheter placed in the proximal M1. And here the stent is deployed across the thrombus through a microcatheter. And then this is the microcatheter. And then the stent, then the thrombus is retrieved into the intermediate catheter along with the suction. And then in addition, we give some suction also here in the thrombus. So whatever thrombus is remaining will be sucked out into the intermediate catheter. This is the fluoroscopic image, which you can see the stent retriever here. The markers of the stent retriever are well visualized, and this is the intermediate catheter for suction. And the guide catheter, which is placed in the high cervical, it can be a plain normal guide catheter like AXS Infinity, or it can be a balloon guide catheter. And this balloon guide catheter is useful in the sense that it prevents the antegrade flow, and it causes antegrade flow arrest and prevents thromboembolism, especially in fragmentation in large clots. So that's particularly useful. The intermediate catheter, which delivers suction, has a very complex morphology. It has a coil architecture which helps in its navigation, and it has a braid architecture which helps it the pushability and support in tortuous anatomy. It's made of nitinol, an alloy. These are the intermediate catheters, various intermediate catheters which are available for suction thrombectomy. There is a Vecta, a React catheter, Red catheter, Sophia catheters, and even large bore catheters are now available of 088 in the diameter, which are used for suction. So when do we consider suction thrombectomy in our pre-procedural plan? First, we make a plan. Every case So every case we make a prior plan before going in for the procedure. So we study the whole, we do the analysis in the stroke imaging. And here you can see, we even measure the clot length, especially in the gradient echo. And if there is a short length clot, then we go ahead with suction. If it is a long length clot, there is high chance of fragmentation. We go in with a combined approach initially. And in ICAD, the strategy is different. See, this is an ICAD. You can see the tapered end, and the ICAD, the strategy is different. We go in with the suction first because it's a ruptured plaque. If you go with the stent retriever, and we are going to mangle the plaque and cause more damage to the vessel. So suction will be our first mode. Then in tandem occlusions, we do suction after a balloon angioplasty. There's a tandem occlusion. The whole IC is occluded. So we do suction in the whole length of the IC after the angioplasty and after after proximal angioplasty. So suction is useful in retrieving the whole clot burden in the whole of IC. So before going for any thrombectomy, as we discussed in the morning sessions, we have to do a pre-stroke stroke imaging analysis, and the case selection is the most important thing for getting a very good outcome. So this is the aspects which has been discussed already: the caudate, internal capsule, lentiform, and this is the M1, M2, M3, and M4 ganglionic level, and the supraganglionic level, the cortical. So one case example, here 61-year-old lady presented with in-hospital stroke. She collapsed in the ICU where her daughter was admitted. She had left hemiplegia with 2/5 upper limb power and lower limb power with gaze deviation to the right side. NIHS was 11 and acute stroke pathway was activated. Here you can see a dense MCA sign. This indicates that there is a large vessel occlusion and a thrombus sitting there in the MCA. So vascular imaging is mandatory in this case. As we did the CT angio, and you can see the cutoff here. Then we go ahead with the DSA. Went ahead with the DSA, then this is the occlusion to assess the collaterals. Here the DSA, we use DSA also to assess the dynamic collaterals. Sorry. You can see the whole MCA is getting collateralized from the ACA. You can see the completeness of the circulation. So that means the parenchyma is well preserved because of this. And we have an ideal candidate for a thrombectomy to get a very good outcome. So we selected this case for thrombectomy. This is the proximal guide catheter placed in the cervical ICA. The intermediate catheter, which is brought into the clot. You can see the occlusion level was here, and the intermediate catheter is just engulfing the clot. And here is the clot retrieved, and here is the final circulation, which was restored. The whole MCA antegrade flow you can see. And this patient is clinically improved the next day. So another case, 65-year-old male, coronary artery disease, type 2 diabetes, left hemiparesis with dysarthria, NIHS 9, lysis given. And this was a CT. We can see the cortical areas are well preserved. M1 shows an acute cutoff. And CT angio was done to assess the collateral. You can see the whole right hemisphere is getting well collateralized in the multiphasic CT angio. And the DSA showed occlusion at the MCA M1. There's a thrombus with mild antegrade flow also is there. So there's a soft thrombus. We planned for suction thrombectomy, and this is the intermediate catheter. This is the guide catheter here, and the suction is given in the proximal to. We engaged the proximal to this clot and gave the suction, and this was the result. The thrombus gone and full circulation restored. So in acute basilar occlusion, the suction thrombectomy is useful even in acute basilar occlusion. We prefer to go first with suction thrombectomy even in basilar occlusions. So this is the dense MCA sign. So when you see in CT such a sign, and the patient is drowsy, comatose, with posterior circulation symptoms, then suspected basilar occlusion. CT angio shows good collaterals in the form of PCOM. And the DSA showed occlusion at the occlusion at the basilar level, mid-basilar occlusion. You can see the whole basilar is getting reconstituted from proximally from the PCOM. That's how the whole parenchyma was preserved, but there was a hemipontine infarct. But this pattern of infarct, which you saw earlier, was a perforator infarct, not a large vessel, not a hemodynamic infarct. But still, we went ahead here because the patient in IHS was large and she was drowsy, and there was some hemodynamic impairment. So that's why we went ahead with the procedure. And here post-suction thrombectomy, the vessel is fully revascularized. 5 months follow-up, MRS 1. Now patient is on anticoagulation because she had atrial fibrillation. Now, will you do, as we discussed earlier, low aspects mechanical thrombectomy at SNF? We don't do, we don't take up for thrombectomy with the aspects of less than 6. So usually we take up only large vessel occlusions with good aspects for revascularization. We consider for revascularization. Otherwise, it will be a futile exercise. So this is a 73-year-old man, acute left hemiplegia, NIHS 13, grade 1 power in the left upper limb, 2 power in the left lower limb. Onset to imaging time was 3 hours. Don't know whether it will work. Yeah. So he has paucity of movements on the left side, moving right side upper limb, and lower limb also he's hardly 2/5. Yeah. So the CT was showing reasonably good aspects, around 7. These are chronic infarcts. He had past history of stroke, cardiac source, and the CT angio shows no collaterals. So this is a person who is bound to have a worsening in the coming hours, especially because he might be a rapid progressor. So because we got everything done within 3 hours of window, we thought that we'll go ahead with the revascularization. So this is the diffusion. You can see the large diffusion area. So, and he's going to be a rapid progressor. So we went ahead. Flare is still preserved. So there was a diffusion flare mismatch. See the thrombus burden here, large thrombus. Then we went ahead with the suction. There's a guide catheter here. We pass the intermediate catheter into this proximal clot and engage the clot and give the suction. Yeah, you can see the intermediate clot and catheter engaged into the clot. And then we apply here. We went ahead with the combined approach, stent retriever plus suction, because the clot burden was large. We don't want it to fragment and get distally embolized. Here we restored the circulation. The full vessel is revascularized. Now this is the post CT. There's mild edema here. Post procedure, patient clinically improved. Recanalization time was 1 hour. Post-op day 1. He started improving. The left lower limb started improving, becoming grade 3. Now, upper limb, there was some improvement. This is at day 7. Upper limb was not that much improved as lower limb, but because already there was small core already in the motor cortex. So whether we go ahead with whether we should do thrombectomy in large vessel occlusion with poor aspects. Lot of literature has come up. Rescue Japan study, they have taken up aspects 3 to 5, and they found a reasonable outcome. So, and this is another trial, tension trial. They also took up a large vessel occlusion with aspects 3 to 5. They also found the efficacy was better in the AVT group. But you see here, mortality rate, the mortality rate was very high, 35%, and 65% had severe death and disability. So how would we convince the patient family for undergoing such a procedure with 30% mortality and 70% morbidity? That's a question, open. These are all the large vessel occlusion trials. And see the margin of safety, a margin of efficacy which has been found in the EVT group in large vessel occlusion with poor aspects. Here, the reduction of the Atlas meta-analysis, the systematic review and meta-analysis, they could find a marginal reduction in the MRS score from 5 to 4, and mortality marginal benefit from 37% in the best medically managed group to 31% in the EVT group. So there was only marginal improvement in patients selected for with poor aspects. So that's why we in SNF our protocol is not to take up aspects less than 7. So in revascularization in ICAD related occlusions, we the major strategies for ICAD related occlusions, revascularization strategy is intra-arterial drug therapy. So we use GB2B3A, tirofiban, fibrinolytic therapy, and intracranial angioplasty and stenting. Here, you can, this is a 58-year-old gentleman with right hemiparesis, aphasia, and gaze deviation to the left. You can see the large penumbra and a reasonably very small core. Here, aspects is around 8. Small infarcts in the corona radiator here, in the lentiform and the posterior limb of the, just extending the posterior limb of internal capsule. We went ahead with the first pass reopening, revealed the real nature of the underlying occlusion. So the nature of the occlusion has to be taken into consideration before planning any mechanical thrombectomy. So only after the first, many a times, only after the first pass, you will come to know about the nature of the occlusion. But sometimes CT angio also gives a very good a real situation, and the pattern of infarct also gives a good idea, and the history of the vascular risk factor history also gives a good idea regarding the nature of the occlusion. If it is ICAD, ruptured plaque, here you can see the area of ruptured plaque, the occluded segment. As soon as the first pass we could open up the artery, but again it got reoccluded, and then we applied intraarterial tirofiban was administered, the vessel reopened, and we continued the infusion of intraarterial tirofiban for 24 hours, and this was a post-CT angio taken after 24 to 36 hours. You can see the vessel is still patent after the revascularization. At discharge, patient was started moving the right lower limb, power improved in the right lower limb. Another case of ICAD, revascularization, a 48-year-old lady with AF drug default. This is not ICAD revascularization. This is a revascularization of a refractory clot, which failed to revascularize even after 2 passes. So 48-year-old lady with atrial fibrillation, right hemiplegia with aphasia, NIH is 16. Onset to imaging time was 6 hours. Aspects was favorable, 8. We took up the patient for revascularization. Then this was the left ICA. You can see after 2 passes, the ICA was still occluded. So our artery got reoccluded. Then we applied intraarterial tirofiban. We went with the microcatheter distal to this occlusion, and in a sequential manner, this is the SNF protocol, as Professor Shakir sir had mentored us. We apply the intraarterial drugs all throughout the length of the thrombus, and here the refractory clot is opened up. So many a times, even in cardiac, the cardiac clots will get reorganized in the LV, and it will be very difficult to retrieve such a clot, which is well organized. So we intraarterial drug therapy, either in the form of tenecteplase or tirofiban, will come to rescue in such a case. Even after getting even after 2 passes, if you are not able to revascularize, then we go with such intraarterial drug therapy. So this is another case example of a 61-year-old gentleman with left hemiparesis, dysarthria, hemi-neglect on the left side, NIHS is 12, onset to imaging time 5 hours 30 minutes. You can see the cortical areas are relatively preserved in CT, and perfusion imaging showed large MTT penumbra, TTP and MTT is prolonged, and CBV is relatively preserved. You can see the demarcation of the CBV is coming up, but it is not fully established. That means the CBF flow reduction is already there, and that demarcation started coming up. In such cases also, we take up, even if it is borderline, we have to take up for thrombectomy, revascularization in such cases. Here you can see the occluded artery. The coronal MIP showed a filling defect here, and good collaterals. Collaterals are seen on the right hemisphere in multiphasic CT angio. And we did a injection in the vertebral artery, showed minor posterior angular territories, a little bit filled from leptomeningeal collaterals. And we could open up. This was the DSA image, which showed a ruptured plaque here. This was the one which was getting reoccluded. After the first suction, we could open up the partially and establish the antegrade flow, but there is a plaque here. It got reoccluded again. And this is the stenosed M1 segment. We did a balloon. Then we thought of doing a microballoon angioplasty because it was a ruptured plaque and it was getting occluded every time. So even after first attempt, if it gets reoccluded, we understood the nature of the underlying occlusion. It is a plaque, ruptured plaque, so it's not going to open up. So then we resorted to this microballoon angioplasty. This is a microballoon. And again, we could open up. Again, it got reoccluded. So finally, we decided to go ahead with intracranial stenting. of that ICAD segment. So again, a microballoon angioplasty is done, and we did applied a stent here. Here are the stent markers you can see, intracranial stent markers. This was done by Professor Shakir sir, and we can see the beautiful result of the whole vessel getting remodeled. This is the final image. And do all acute LVO occlusions qualify for recanalization? That is another question. Every LVO, you need not attempt revascularization. Some case examples. A 40-year-old atrial fibrillation, lady with atrial fibrillation, RHD, MSMR, presented with left ataxic paresis, dysarthria and opercular symptoms. NIHS was around 6 to 7. So this was the occluded artery, M1. You can see some formed infarct already in the operculum. She had those symptoms. So what is the plan? Whether to revascularize? Then you need perfusion. Yeah, we have the perfusion. Again, perfusion is showing the same. You can see CBV showing a small core in the same opercular segment where we saw the established infarct in the CT and small penumbra. The large area of the cortex is still preserved, viable. But penumbra is not there even in that hemisphere corresponding to the arterial occlusion. So what does it mean? The whole area is getting perfused somehow. That means there is no salvageable area, no underperfused area. Even CBF is not reduced much in the whole hemisphere if you see. DSA gave the answer why it is so. It's because of the grade 4 very good collaterals, which was visualized in the DSA. Here you can see the whole hemisphere getting filled from the ACI leptomeningeal collaterals. You can see the collaterals, all the branches are getting perfused. So the final CT after 48 hours remained the same. We didn't go for any revascularization procedure in this case because patient was clinically well preserved. Because the imaging showed very good collaterals and patient is clinically well preserved, and post procedure also patient improved in a week's time. So MT is not warranted in all the cases of acute LVOs. And case 2, 78-year-old lady in hospital stroke admitted in cardiology ICU and presented with right hemiparesis with aphasia. Identified 3 hours after the last known normal. Here you can see a temporal area is showing. This is a large hypoperfused area and large penumbra, and temporal area and posterior parietal area is already showing core in CBV. So in spite of 6 hours, or 3 to 4 hours past the stroke, the patient is still well preserved. That's because of these collaterals. You can see the collaterals, how rapidly the collaterals are getting filled. You can see the occlusion here. There is a dominant M2 trunk occlusion here. And here, in the lateral view, you can see the whole area getting collateralized. That M2, the occlusion also, you can see the collateral supply also, you can see. So because of these rapid collaterals, we didn't attempt revascularization. We attempted intraarterial tirofiban because the patient is already on anticoagulation. We didn't want to go for a distal thrombectomy. Now here comes the question of whether to revascularize a distal occlusion, especially in case of such a rapid collateral. We gave intraarterial tirofiban. It didn't open up, but we stopped the procedure, abandoned the procedure because the collaterals were very good. You can see the PCA collaterals also filling up angular territory. The final CT after 24 hours, the whole area is preserved except the temporal area which already had a core in the CBV. Patient was neurologically doing well at discharge except for aphasia because already there is a formed infarct there. So based on the hemodynamics and the this one, based on the SNF protocol, MT was deferred. Primum non-nocere principle was applied in these distal vessel occlusions because doing a thrombectomy will be more harmful, especially distal thrombectomy will be more harmful. And as the patient was on anticoagulation and considering the risk of hemorrhage, we didn't consider revascularization here. Now, another case, a 68-year-old gentleman with history of smoking presented with posterior circulation symptoms, ataxia, vomiting, bulbar weakness, and gaze evoke nystagmus. You can see infarct in the lateral medulla and the cerebellum. Basilar is not seen here in the MR angio. Here is how the basilar was filling. Basilar was filling through collaterals. Vertebral V4 was occluded. You can see the pica was filling. And superior cerebellar also getting collateralized. So the whole circulation is maintained in the posterior circulation. You can see even the PCOM contributing to the distal basilar. So the circulation was maintained and patient was fine. So no revascularization according to SNF protocol. Now, revascularization of distal vessel occlusion. recently, we have reviewed, our colleague has reviewed, along with Shakir sir, Dr. Prasad had reviewed a detailed review of all the distill vessels and trials, distill trial, escape MEO trial, discount trial, and most of these trial results were neutral, but there were a lot of factors to be taken into consideration while doing a distal vessel occlusion. Not all distal vessel occlusions need to be revascularized. Because the definition of M2 is heterogeneous in most of the trials. Proximal M2 lesions cannot be put in the ambit of a distal vessel occlusion, and especially when there is a clinico-radiological mismatch, and these patients may benefit with revascularization. And distal occlusions frequently involve vascular territories with greater collateral redundancy and lower hemodynamic dependence on antegrade flow. So consequently, a substantial proportion of patients may achieve favorable outcome with best medical therapy, especially in distal vessel occlusion. And IVT is very effective in distal vessel occlusion as compared to proximal vessel, large vessel occlusion. The revascularization rate is around 51%, whereas in proximal occlusions, the IVT rate is only 20%. So why to go ahead with distal occlusion revascularization with when it poses a risk of procedural risk to such a in these cases? So the SNF protocol for MEVO and DVO is very clear. We don't consider occlusion of proximal M2 as DVO, and revascularization is indicated, especially in the case of dominant M2 and proximal M2 as, with major deficits and clinico-radiological mismatch. And we prefer IA drug therapy in distal vessel occlusions like M3, M4, and A2, A3 if it is needed and if the parenchyma is safe, preserved. Thank you. This is our team.
Yeah. So if a patient has means stenosis, MCS stenosis is there. Along with that, we have low aspect, like aspect was 5, but we undergone, like we ask for endovascular intervention. In that scenario also, with if low aspect is there, then also we have to give this tirofiban, or is there any role of low dose tirofiban? And another question is that, like if a patient has low aspect and still stenosis is there, whether we can go ahead with intracranial stenting or not. That these two case scenario, can you explain?
Actually, stenosis, you mean, by stenosis, you mean a plaque. So the nature of the occlusion is to be it's a stroke. So, because already arteries are if it's a thromboembolism, plaque rupture and a thromboembolism, then there is not going to be stenting proximally, and revascularization of proximal segment is not going to help the patient because already there is an established, in fact, plaque embolism.
It is MC occluded with this stenosis with occlusion was there, and in that condition, because aspect was low, means aspect was around 5 to 6. So we tried to intervene, but that stenosis was still there. So whether still we have to, because the chances of reocclusion is there, whether we have to give tirofiban with low aspect, or is there any role with low aspect and intracranial stenting we can do in acute period?
First of all, since protocol is vascularization means the aspects is very low. So
5, it is not
so
very low.
Even established on the segment, because already whatever in fact has happened, it's already there, and still so
So it was based on plain CT only, and but problem is that still we can save those temporal area and all. If basal ganglia infarct and some superior infarct are there, still we can save some temporal lobe. If language function is chances is there that language may be affected.
Yes.
Maybe
I think this, so, you know, when we talk about hypothetically M1 occlusion, there are many variables, many. Now, what are the variables that we have to consider? What are the variables that we must consider actually? So we have to expand our variability in our judgment making. First and the foremost, let's say an occlusion of an artery. It's just a mechanical thing. But we have to think pathophysiologically. What is the pathophysiology behind it? An occlusion of M1 could be a cardioembolic stroke, a fresh clot from the heart going in a M1 area, which is a normal artery. You suck it out, you remove it, fantastic, 10 minutes job, you have complete recanalization of the artery. The extreme other end is a ICAD, atherosclerotic plaque in the M1 region, ruptured and occluded that. You do a 3 hours of the efforts. It opens and closes, because it's a ruptured plaque. And what you are doing mechanically by retrieving the clot or sucking the clot is you are causing more injury to the plaque also, which is causing again a propagative thrombosis into the same area. And that's what the reason for the occlusion. So in these cases, what we do is that we use intra-arterial tirofiban. This is a out of the guideline work. Actually, I think when we started, this was, I think, one of the first work that we started. Nobody was using in the world. And we found some good result in initial cases, so we established a protocol. Now, this protocol that we are now about to publish of about 30 cases that we have is actually speaking over a period of last 3 years. Now, that is the second spectrum that I'm saying. Now, that is one aspect. When we are considering only the pathological aspect of the disease. Now, there's second variable. What is the reason? What is the pattern of stroke? That is another very important thing to understand, especially for my frontline residents and medical people that are working in an ER. You have to classify any stroke which is coming to you into 4 broad categories, because largely what we are seeing is applying to the atherosclerotic disease. Now, the atherosclerotic disease, how it can cause a stroke, the pathophysiology of a stroke. One is occlusion of an artery, which causes a hemodynamic impairment. So hemodynamic stroke. In these cases, you will see that there is a fluctuation in the neurological deficit. You raise the blood pressure, or patient come with the high blood pressure, you reduce the blood pressure, the deficit increases. So they are dependent on hemodynamic perfusion. So if you have a hemodynamic stroke, that is the one component. The second component is a side branch occlusion, which could be a perforator or a side branch. So atherosclerotic disease, let's say M1 segment involving the lenticular strat perforator, or basilar artery involving the pontine perforator. Like Anand showed one example, complete occlusion of the basilar artery, but the pattern of a stroke is a perforator stroke. Complete hemipontine infarct, that's it. And what would be the hemodynamic component to it? If you have a distal territory suffering, that is a PCA territory or superior cerebellar territory suffering from ischemia, which could be easily perceived on or picked up on the diffusion imaging. So if that component is there or not there, you can judge upon from that point of view, whether that hemodynamic component is there. So you have a perforator stroke, you have a hemodynamic stroke, and third one is a embolic stroke. You have a ruptured plaque, not occluding the artery, but recurrent, the clot formation and going into the multiple territories, into the same artery. So basilar artery, for example, there is a clot going into the superior cerebellar in pica and PCA, either on one side or on both the sides. That means this is an embolic stroke. So you will have a multiple embolic in the cortical area in a random way. So these are the 3 basic fundamental. And you may have a fourth is a combination of any these 3. You may have a perforated stroke with a hemodynamic component, or you may have a perforated stroke with embolic phenomena also, which may not be symptomatic. The symptomatic could be a perforated stroke. So you have to define that when you are recanalizing this artery, especially with the mechanical method, you have to take into account another very important factor, which nobody talks about in our routine presentation, is the operator's learning curve. What is my risk of performing that procedure? I decide by myself. Nobody else can decide for my risk. I know my complexity. I know my previous experiences, that whether I do in this situation, what are the chances safely I can recanalize it? That also depends on many factors. What is the age of the patient? What is the tortuosity of the vessels? Is the systemic atherosclerotic diseases there, or a focal disease is there? And what are the tools available with me? what is the time of the day and night which is there, which is usually the night, so it's not a major variable. But you do have to take into account whether the anesthesia available to you or not. This is also a very important factor. In many of the situation or most of the situation in our country, anesthesia is not available, and majority of the places, I would say, it is done under local anesthesia, and you're struggling actually. Patient is struggling with you. You are doing a thrombectomy and patient is moving the head. And all kind of things are happening. So you have to take into account many things actually. So these are few variables I'm talking about. We also know what is the length of the clot is another variable. If it is a short length of clot, high probability that you can remove it. If a long segment of the clot, you struggle for a long time. And suppose you struggle for 3 hours during the procedure and recanalize the patient, right? So your recanalization time is not the time, window period now is extended, not at the time that you did a puncture. The window period extended to the time when you recanalize the M1 segment. That is something very important. So you have to keep a sense of time when you are performing a procedure, right? Which usually we don't have because we are engaged in the procedure. So you have to constantly see that I have done 3 passes, 5 passes. In some of the American one, they do 10 or 15 passes. So 10, 15 passes will take 3 hours, 4 hours time. End of the day, you can show that the vessel is recanalized. But is it corroborating with the clinical recovery? That's the question. So at that time, you have to change your strategy. It's a dynamic disease, dynamic phenomena, dynamic management has to be. So you also have to change your, so my answer to your question is now you will understand that you get an X situation. I think the operator which operates, like in your case, the operator tried the thing, is right in that way to doing the procedure, right? Because that is what he understood the demand at that moment. And the recanalization, reocclusion is happening, there are 2 possibilities as we shown in some of the example. We generally do not consider doing an acute angioplasty, acute stenting, because many of these situations are the patient who has already received thrombolytic therapy. Now, with the thrombolytic therapy, you put a stent, you need a 2 antiplatelet drug, which is a contraindication. Even in the present guideline, there is no guideline says that you use 2 antiplatelet drug, but we do use it. There are situations where we have thrombolyzed patient, I get disease. We know that if we put a stent here, we can have a very good outcome. So we have to take a risk and we use even tirofiban in these cases and then subsequently double antiplatelet drugs. So those kind of deviation from the guideline does happen. So that's why we keep on saying that no M1 occlusion is a duplication of the next, what you call M1 occlusion. That is why the important thing what we emphasize is not this is not a mechanical action of opening a pipeline. Okay, if you go with that approach that is a pipeline and I want to open it up, of course there are many people doing it, and that's where also comes the point of view that who should do it and how the clinical background or clinical perspective or clinical aspect of management constantly putting into doing these procedures makes some change in the outcome actually. It may not be too high in terms of percentage, but even 1% variability in the complication rate is a huge improvement in our work that we usually consider. So that is something which we need to understand, I think. So the fundamental point is here that there are 2 things on either of the sides. Understand the hemodynamics of the brain circulation, that's the brain cerebral blood flow, which is auto-regulated with a chemical mechanism, like by generally when you have a stroke, there is a rise in the blood pressure. That's why we keep on saying that patient of acute stroke or hemorrhagic stroke coming to your emergency room, never ever reduce the blood pressure. Don't bother even if it is 190 or 200, though we have a cutoff line of 180. But understand that situation, because this is a rebound hypertension in both the situation to maintain the perfusion pressure. In hemorrhagic stroke, to compensate the raised ICP. So mean perfusion pressure is a result of mean arterial pressure minus the intracranial pressure. So if the intracranial pressure is high, the mean has to be high, which nature does immediately. So we don't lower the blood pressure. That's one important thing on this side. On the other side, the mechanism of the stroke and the clinical present situation of the stroke and what is specific from the functional vascular anatomy. Very important point I'm mentioning here. People are not talking about functional vascular anatomy. That this particular territory, what result it will bring back to me. For example, you have angular artery occlusion on the left side. You know what it will give rise to? It will give rise to the Hessel-Guidus infarct. So patient will have a communication defect or the aphasia. While the same artery on the right side, adequately perfused, would be grossly asymptomatic. So functional vascular anatomy is also very important to consider, and the which hemisphere is, dexterity of the hemisphere is also very important. The same thing sometimes you do, and also, for example, nature of the function that you would like to revive. For example, if there is a lawyer or a teacher or a journalist or a doctor having a left only the opercular infarct in the motor area, I would like to chase this M2, M3 segment also. While in our protocol, we do not do it M2, M3 segment chasing. But in this situation, it's a very vital, important function, but we will try to do carefully, probably using either the local chemolysis, right? You can also use don't think that intraarterial thrombolysis is out of the game. This is unfortunate part that the PROACT trial, which was published in 1996-95, has been dumbed down. It is one of the best studies conducted. There are very few randomized trials which you can vouch for. Out of 110 maybe. This is one of them. But it has been rubbed out. And I don't want to go into the other side of the You can read this article also we have written in the Indian Academy of Neurology 2-3 years ago. It works. And we have shown that even the patient who have received IV thrombolysis coming to us, and now you see a dense clot on the CT, but when you do an angiogram, you find a very minor perfusion happening across the M1 segment. That means the lysis is initiated. Maybe if I wait for 1 more hour or 2 more hours, it will be complete lysis. But in that situation, because we are there with the angiogram, you just do a microcatheter taking into the clot and inject another 1 milligram of, or depending on what drug we have given. We use tenecteplase locally. We are the first one to start in local tenecteplase, intraarterial. And it works. Immediately it opens up the artery. It dissolves the clot because it is a lysing clot, and you do a high density injection of the IV lytic right into the clot, not IV. It works wonder. So we do not rub it out. This is a very useful technique, very safe technique, and very cost-effective technique. Because in the same leftover RTPA or tenecteplase, which usually we have in the vial, we use it and patient is saved or patient is benefited. So there are different strategies can be planned in this way. So what we will see over time is that learning of these things is continuous process that we are making ourselves, case to case basis, situation to situation basis. And that is what is the most important thing, is a continuum of engagement into the work. It's not that you divide or partition that, okay, this is until here you do the IV lysis and the other team does this thing and we have no idea what is done there. Then you will not have a full understanding of the stroke management spectrum of the whole spectrum of into. You will be then fragmented in your understanding. That means your knowledge will also be fragmented in terms of application. So that is something which we are constantly and continuously talking about. Okay, I hope I made some clarity on the answer with that.
Any other question? What is it? Thanks, Peg.
Thank you, sir, for your valuable insight into thrombectomy. Now we will take a break for lunch and resume shortly.
ஒரு மிஷின் வாங்கணும்னா அதுல என்ன பூச்சி இருக்குது அது இருக்குது அதை எப்படி சொல்லலாம் எம்ஆர்ஐ இது எல்லாமே வாங்குறது ஆமா.
Please join back the session by 1:30 p.m.
see. Hello.
The second one in the.
So, CVT. Solution is Professor of Neurology with areas of interest in advanced brain-computer interface, rare and inherited neurological diagnostics. Welcome to the talk. Good afternoon, everybody. At the outset, I would like to thank Dr. Sri Jitesh and his team and for organizing this CME. The topic that I'll be covering will be on diagnosis of CVT. So CVT, though it is mentioned that it is one of the rare causes of stroke, contributing up to 0.5 to 1%, especially in our region of Karnataka and in Bangalore, probably because of a tertiary care referral bias, or probably because the center has a lot of experience. We get a lot of patients of CVT, and many a times CVT is a mimicker, and it becomes a diagnostic challenge, and the decision making regarding heparin, it becomes very important. So diagnosis of CVT is important because it has heterogeneous clinical and radiological presentations. But the overall outcome is around 60 to 80%. Generally, the outcome is very good. So we need to understand about brief anatomy about the superficial and the deep venous systems, how they drain, the drainage, the brain regions which are supplied by these superficial and the deep systems, thereby helping us to understand the clinical presentation and the radiological correlations. And when it comes to the risk factors, it could be genetic or acquired. And in terms of the acquired causes, there could be gender-specific risk factors. For example, pregnancy, purpurium, occipital intake, hormonal replacement therapy. And overall, across the globe, the common cause of CVT is prothrombotic states and other hematological conditions, infections, systemic disorders, autoimmune disorders, myeloproliferative disorders. These also, and L-asparaginase or any other chemotherapeutic agents. These are also predisposing factors for CVT. And in the initial, what has happened over the past 10 to 15 years is the transition in this risk factor profile. Earlier in the ward, we used to see a lot of women in their postpartum and the puerperal stage and pregnancy. But this has changed drastically over the years with a better maternity care that is available. And the general period where they are predisposed to CVT is the third trimester or the puerperium, which is basically because of the prothrombotic state and the increased fibrinolytic reduction in the fibrinolytic activity. And the third most common cause is the occipital intake, which has been noticed that especially in those with the underlying prothrombotic state, they are predisposed to CVT. And across the occipital profile, what has been noticed is especially the ethinyl estrogen. These have been predisposing to the CVT. Now, more and more of desogestrel and with the various preparations, the fourth generation preparations, the CVT incidents are coming down. This is one of the study that was carried down by Dr. Manisha at NIMHANS, which has given us some insight about how the different generation of OCPs across the several years, this has caused the increased incidence of CVT, and more common with the it is less common with the progestin only pills. In
what as I was mentioning, across the globe, there's a transition in the risk factor profile of CVT. And also from the Indian registry, these have also shown that there is an increase in the male CVT, more so because of the hyperhomocystinemia and the alcohol intake. So these are studies with Dr. Sri Jitesh, one of his students' work, where it was looked in all the nutritional factors, B12 deficiency, folate, polycythemia, anemia, these were looked into. And there have been a lot of work from this institute on hyperhomocystinemia, B12, all these nutritional factors, and also on anemia and polycythemia. So thrombophilia in CVT, so studies have shown that it is factor V laden prothrombin mutations, which are the commonest causes for thrombophilia. And in the acquired thrombophilia, antiphospholipid syndrome, PNH, myeloproliferative disorders, these are the common causes of acquired thrombophilia. In the Indian studies also have emphasized that these are the common mutation, but the studies that have been carried out in NIMHANS have shown that even when women were having these particular mutations, they were not, this was the incidence of these mutations were common in control population also, thereby necessitating the need for more genetic studies from our cohort. And other causes are autoimmune and even COVID, obesity, PCOD, etc. So how these thrombus formation increase the venous pressure and then they cause the collateral circulation activation, how they increase the ICP and cause cerebral edema and hemorrhage, this helps us to understand the clinical symptomatology. So the clinical symptoms can be in terms of the raised ICP, or it could be the focal syndrome, subacute encephalopathy, cavernous sinus syndromes. The most common being headache, and the headache can worsen with Valsalva manners and recumbency. The site of headache, though there is no specific relationship, some of the studies from our center has shown that they could be side locked. There could be underlying vascular congestion contributing to the laterality of CVST. And the patterns could be that it could be acute, subacute, or even thunderclap-like headache, and more common with the superior sagittal sinus and the transverse sinus. And the presentation could be more common with the frontal and the temple regions. The acute symptomatic seizures, 30 to 40%, they are prone for focal or generalized seizures. And the mechanism could be because of the hemorrhage itself, the hemorrhagic transformation, poor GCS, the involvement of frontal lobe, high D-dimer. These are some of the predisposing factors for seizures in CVT. Raised ICP can manifest in these patients as transient visual obscurations, diplopia, cranial nerve palsy. So visual symptoms are often neglected or often not looked into, whereas ICP can manifest as vision loss, and that has to be taken into account. So papilledema, which can be graded by modified Friesen. Then we have also tried to document the venous retinal vein pulsation, which is as a non-invasive way of monitoring the ICP. And visual impairment, as I mentioned, optic nerve dysfunction or venous infarcts or occipital infarcts, these can predispose to visual impairment. And we saw over the period of years, over 12 years, we were able to see that adequate identification, early identification of these cohort where surgical intervention to rescue vision is important because they can have a better visual recovery if identified early. And the other symptoms are motor weakness, hemiparesis. So in terms of the focal pathology, so when it is the superior sagittal sinus, predominant limb weakness, aphasia when it is because of the lateral sinus thrombosis or transverse sinus thrombosis, cranial nerve palsies when it is the sigmoid sinus thrombosis, or cortical veins causing focal neurological dysfunction. So based upon the regions, based upon the veins that are involved, the clinical syndromes can also vary. So as I mentioned, venous aphasia. So one of the students looked into venous aphasia, and what we also noticed was superior sagittal sinus, transverse sinus, vein of Labbé thrombosis. These predispose to the venous aphasia. Generally, they have a better outcome after while comparison with the arterial strokes. But again, we have to look for venous aphasia in the state of altered sensorium and other focal deficits. Language generally is missed, and that also improves with adequate anti-edema measures. So at the end of 6 months, what we noticed was anomia and transcortical motor aphasia. That was a residual deficit in these venous stroke cases. Encephalopathy, this is common with the deep cerebral vein thrombosis. Another thing not to miss is the cognitive deficits that these deep CVT patients are prone for. So early identification of the neurobehavioral symptoms is also important. So not only motor deficits, cognitive deficits, visual deficits, and the language deficits. These are something that has to be identified earlier and addressed. And certain unusual presentations, isolated headache or tinnitus, cranial nerve palsy. We have reported lower motor nerve facial palsy in CVT, multiple cranial nerve palsies, including 11th and 12th palsy in raised ICT due to CVT. Then Charles Bonnet syndrome, where the patient was visually blind, but he started having active visual hallucinations. Then patient presenting with abnormal eye movements, inverse Duane's retraction syndrome, or even with Duane's retraction syndrome. And so all these have been noticed in the acute phase and with adequate anti-edema measures. So we generally, we give very high mannitol and then Diamox therapy, and adequate anti-edema measures can help resolve these, but identifying these heterogeneous presentations as one of the findings in CVT, this is also very important. When it is the investigations, so apart from the complete hemogram, APTT, prothrombin, the identification of anemia, the nutritional factors, homocysteine, polycythemia, these all form the routine protocol in CVT patients. And that apart, autoimmune inflammatory, autoantibodies, APLA, these are all the protocol to rule out the acquired causes. So prothrombin workup and the other genetic testing can be done. The prothrombotic testing can be done after stopping anticoagulation around 8 to 12 weeks after stopping. And D-dimer, the role is more of a negative predictive value. And when it comes to so these are the clinical and the investigatory protocol. Then when it comes to the neuroimaging, the idea is to identify the thrombus and look into the absence of the venous filling, and then look for the other hemorrhagic and the mixed density, the venous infarcts. So CT is commonly the initial imaging test, and MRI is more of help to identify the flow void, the abnormal signal intensity due to the thrombus, and its surrounding enhancement. So when it comes to CT, there are various signs that are described with CVT. The cord sign or the hyperdense sinus, the vasogenic edema, empty delta sign, non-opacification of the sinuses. So basically CT is to rule out all the mimics, and then to confirm CVT, we can have direct and indirect signs. And other important thing is the CT density. So we need to take into account the presence of anemia and polycythemia in our cohort. So HH ratio, that is the Hounsfield and the hematocrit ratio. This is also important before we just predict and say that the plain CVT is having a hyperdense sinus. So in Alekia's thesis, we looked into this, we looked into the pattern, and we were seeing that in majority of the cases after heparin, by 6 months, the hyperdensity had come down. So these are some of the images, contrast enhanced images, CT showing a empty delta sign in the confluence of the sinuses. Then on the rightmost lower down, you can see hemorrhagic mixed density lesion with edema. And one major thing to differentiate between the arterial strokes and this. So many a times it is a confusion to differentiate between the arterial stroke with hemorrhagic transformation versus CVT. So the edema, the significant hemispheric edema when it is present, that favors the CVT. So that is one thing. Then the leftmost top is the cord sign, the dense lateral sinus sign, the dense triangle sign. These are all in the plain scan. And then cashew nut sign, which is of high specificity, juxtacortical C-shaped hyperdensity, then mixed density lesions with hemorrhagic transformation, parenchymal bleed, and the presence of edema. So these are some of the signs that we can pick up by CT. And gyral enhancement, focal enhancement, tentorial enhancement, these can be other indirect signs of CVT. And sometimes arachnoid granulation, these would cause us confusion. And in false positive, these are false positive cases. So when we have a empty delta, so you always look into the contrast scan to confirm that, to look for the thrombus surrounded by the circumferential enhancement of the thrombus. And CT venography, MR venography, they have an excellent diagnostic performance in detecting these dural venous thrombosis. So in MRI, what we see is the various sequences, T1, T2, GRE, gradient echo, susceptibility weighted images, contrast MRI, and MR venography. So these are the various things which help us in the CVT protocol, identifying the thrombus, visualizing the thrombus, and then looking at the pattern of the contrast enhancement around the thrombus, and also looking for the hemorrhagic venous infarcts, the parenchymal edema, the presence of hydrocephalus. So all these can be vasogenic edema. These all can be made out by the MRI. So these are some of the signs which I was mentioning, the imaging findings. So here you could see that in T1, generally they are hypo or iso, especially in the initial phases. You could see on the top, on the superior sagittal sinus, these are irregular and they are a hypo to iso. And you can also see the irregularity of the sinuses. Then cortical vein thrombosis. In the SWI, you could see that these cortical veins are thrombosed. Then this is a case of like hemorrhagic venous infarct. So blooming in the center, you see the blooming in the susceptibility weighted images. Contrast enhancement can also be seen. And generally after 2 weeks, when it becomes the hyperacute, subacute phase, then these thrombus would turn hyperintense due to high methemoglobin concentration. So MRI is sensitivity is higher, 82 to 90% specificity. And as I mentioned, SWI, then MRB showing the flow-related enhancement, absence of flow-related enhancement, DWI, which can show the hyperintense clot signal sign. So these are the various sequences under which the CVT can be detected. And so this is again a thrombus in the superior sagittal sinus. You could also see in the posterior end of the superior sagittal sinus, the thrombus. In the contrast, you can see that the contrast is filling, leaving the thrombus in the middle. And you can also pick up other signs of raised ICT in terms of the optic nerve, optic sheath dilatation, the empty cella sign, and certain other sequences like the MR black blood thrombus imaging. These can also help in the subacute phase. And turbospin echo black blood sequence. These are the other additional advanced sequencing which can help in the CVT protocol. And the spectrum of intracranial hemorrhages, it need not be only venous parenchymal hemorrhage. It could even be intraparenchymal hemorrhage. It could be corpus callosal hemorrhage. It could be subdural, non-traumatic subdural hematoma. It could be subarachnoid hemorrhage. And so these are the, or it can even be intraventricular hemorrhage. So these are the various patterns and heterogeneous radiological findings in CVT. And so these pose a challenge in the diagnosis, and even mastoid fluid signal changes. These are also associated with increased clot burden. And in terms of the deep CVT, where the thrombosis of internal cerebral vein, basal vein, the vein of Gallen, straight sinus, when these are involved, so you can see that the basal ganglia, there is T2 hyperintensity, and there is a blooming in the same region, and the superior sagittal sinus is thrombosed. Sorry, it is the straight sinus which is thrombosed. So you could see this from the CT, the hypodensities. So adequate knowledge of this deep CVT and identification of these, this is very crucial in initiation of the heparin therapy. This again, you can see contrast enhancement and blooming. It is a case of deep CVT. And brush sign, this is hypointensity in the subependymal and deep medullary veins. So these are also significantly associated with ipsilateral parenchymal lesion, and it correlates with the extent of thrombosis. So the imaging predictors of prognosis involves that the poor prognosticators involves deep CVT, presence of posterior fossa lesions, venous infarcts, hemorrhagic lesions, hydrocephalus, multiple sinus involvement, diffusion weighted imaging restriction. There are, so not only imaging, CT venography, MRI, MR venography, there are also other non-invasive modalities which are coming up more in the CVT management, especially OCT. So a study conducted here, we have seen that ONST, OCT, TCD, TCCD, these also have a major role in the diagnostic armamentarium of CVT. You could see the crescent sign on the leftmost corner where this is on the posterior, there's a bulge into the, so that's because of the papillary edema that you can see an anechoic area within the optic nerve sheath. So serially monitoring this optic nerve sheath can also help us to gauge the ICP and reduce the mannitol therapy. And you can see that the perioptic sheath dilatation is there in ONST. Then OCT studies have shown that they are more sensitive, especially the choroid layer and the thickness, and peripapillary RNFL thickness can help us to monitor and gauge the raised ICT. And TCD, TCCD, these also can help us, especially monitoring the middle cerebral vein, then their pulsatility and the resistivity index. These can help us in gauging the raised ICT. And DSA, this is mainly for the endovascular interventions and for thrombectomy in CVT, and also for the embolization of the dural AV fistula, which we would see in cases of chronic CVT. So DSA is limited for that. So CVT is a heterogeneous syndrome, and proper identification of the syndrome, clinical presentations, adequate knowledge about the superficial and the deep venous system, and taking into account the raised ICP, that monitoring using various modalities, including CT, serial monitoring, and using the ONST, OCT as adjunct in the monitoring of these anti-edema measures. These help us in the management of these cases with CVT. Thanks for the patient listening, and any questions or comments are welcome.
Thank you, ma'am, for that lucid presentation and diagnosis of CVT. We again call upon stage Dr. Preetham sir for our next talk, Evidence for Heparin in CVT.
So good afternoon, everybody. So again, I'll be speaking on evidence of heparin in CVT. So basically, it is a very small topic, but I'll try to cover what history we have, how we have started this heparin in CVT, and what are the evidences for that. And in certain special situation, whether we have to how we can use heparin or the low molecular weight heparin. So CVT, as we know, it is less common cause of stroke. Almost 60 to 80% will have good functional outcome. So the first question we have, whether really this anticoagulation improve the outcome in acute CVT. So we need to see what are the evidences. So this was the first study which is done in, I think, 1991 by Infol et al. In that, what they found that after, I don't know whether these pointers are there. Fine. So in this one we can see this is at 0 month, means at the onset, and this is after 3 months. We can see if a patient receive heparin, the severity reduced to almost 0 in most of the patient. But we can see if we have not given anticoagulant, then there is a variable severity in the patients. So this is the first study which suggests that we can use heparin in the acute venous sinus thrombosis. So this is the study from Dr. Nagaraj sir, who is from NEMANS only, and he has done a study on like in the postpartum state whether this heparin will have benefit or not. So overall, what he found, there is significant benefit of complete recovery in patient who receives heparin, and there is a significant improvement in the mortality outcome. So in that study, he tried low dose heparin, but ideally we can give means like whatever we have 5,000 international unit 6 hourly we can give, and or most of the patient will have better outcome. This is the another study after 2 years. That last study was in 1999 and this study was in 2002. In that he tried same like 5,000 international unit of unfractionated heparin 6 hourly, and the dose will be adjusted accordingly. Like we are supposed to maintain the APTT around 1.5 times of the initial value, and it was found that almost all patients who received heparin has improved completely, and only that some 2 patients in the control group who died, and one had residual paralysis after 6 months. So this is the another meta-analysis regarding efficacy and safety of anticoagulation in cerebral venous sinus thrombosis. So it was found that there are like if you compare anticoagulation versus placebo, and the first graph which is showing the outcome is mortality. Okay, you can see in mortality it favors the anticoagulation, and the second is disability. There also it favors the anticoagulation, and if you see the last, which is the new ICH formation, in that also it favors the means use of anticoagulation in acute CVT. So this is the trial which shows that in spite of unfractionated heparin, low molecular weight heparin also shows a better better favorable outcome if we start in the acute phase of the CVT. So now we have to decide whether we should use low molecular weight heparin or unfractionated heparin. Which one is better? We need to see based on the evidences. So there is a like a randomized control trial by UK Misra sir from Lucknow. He did on low molecular heparin and unfractionated heparin, and he found that this unfractionated means low molecular weight heparin has a better functional recovery and outcome. The similar study done by Jonathan et al. And in that study also, they have found that a significant difference was there in patient who has been treated with low molecular weight heparin and fractionated heparin, and low molecular weight heparin has a better outcome, and the primary outcome also, it was the significant difference was there, and the secondary outcome like means in secondary outcome there was not much of statistically significant difference, but overall MRS was better with low molecular weight heparin. Then this is the meta-analysis. This again shows the same means like in all parameter there these are favoring the low molecular weight heparin. So based on this, at least as of now, we can understood that low molecular weight heparin is better than unfractionated heparin, and we can use heparin in the early phase of the CVT. But the next question when it's arise, that if patient has some hemorrhage like ICH or some subarachnoid hemorrhage, whether in that condition also we should give means heparin or low molecular weight heparin? So the answer is yes, because if you see in a patient, this is the Cochrane analysis that of anticoagulation in CVT, they found that almost 43% of the patient will have intracerebral hemorrhage, but still it favors the treatment. So we should not hesitate if a patient has subarachnoid hemorrhage or patient has some ICH and all, or hemorrhagic infarct is there, we should not hesitate to start heparin in such case. This is another study which shows the safety assessment of anticoagulation therapy with hemorrhagic CVT. In that also they found that there means patient will have better outcome even if patient has hemorrhage and if you intervene with anticoagulation. So as of now, we understood that if any concomitant intracerebral hemorrhage is there, that is not a contraindication for heparin therapy. But we should be use judiciously, whether if large hematoma or something is there and we are suspecting that hematoma size increase or big subarachnoid hemorrhage is there, then we can give a lower dose, and but we should continue heparin. We should not stop the heparin, because as the thrombosis worsen, the chances of mortality will be high. Then CVT in special cases like CVT in pregnancy. Anyhow, we know that all oral anticoagulant are not safe in pregnancy. So we will be left with heparin only. And heparin is safe in pregnancy. We can use as a prophylaxis in some like chronic thrombophilic syndrome or Apla syndrome, or in normal cases also, if patient has CVT in pregnancy, then also we can use, as it does not cross the placenta and has a favorable maternity safety profile and does not cause fetal malformation. Similarly, in pediatric patient, in acute CVT, we can use both low molecular weight heparin and unfractionated heparin, and evidence suggests that anticoagulation does not increase the post-treatment intracranial hemorrhage. Failure to anticoagulate may allow the thrombus progression and worsening of symptom. Then in next case, like preterm infant, if a patient in neonate's time or preterm infant, whether in that condition, is it helpful, that anticoagulation? In this study, they almost 70% of the patient received anticoagulation. 11 infant had intracranial hemorrhage before treatment. No infant developed new or worsening of intracranial hemorrhage after anticoagulation. Even in the presence of pre-existing hemorrhage, anticoagulation is safe in this cohort. So even in preterm or neonates patient also it is safe. But overall, we have seen the study, but what do the current guidelines says? The European guideline, which says about like therapeutic dose of subcutaneous low molecular weight heparin or intravenous unfractionated heparin should be initiated as soon as possible following diagnosis of symptomatic CVT. This is a strong recommendation with moderate level of evidence. Then subcutaneous low molecular weight heparin is preferred over intravenous unfractionated infusion for most of the individual with CVT. Due to why? Because it is more reliable, and anyhow that the dose will be 2 times only for low molecular weight heparin, and the lower duration of the anticoagulation effect, and longer duration of the anticoagulation effect, and predictable pharmacokinetics enabling administration of fixed dose without laboratory monitoring, and lower risk of heparin-induced thrombocytopenia. And in case of heparin-induced thrombocytopenia, anyhow, we have to give either newer drugs, but newer drugs are not, most of them are not approved in the acute phase. But in the acute phase, we can start enoxaparin if heparin-induced thrombocytopenia is there. Then the next what it suggests, the intravenous unfractionated heparin is typically reserved for individual with CVT who has severely impaired renal function or require a surgical and invasive procedure, because we know that heparin effect usually lasts for 5 to 6 hours. We can do and we can revert also with revert heparin, and we can do surgery. So if any patient who is in ICU or who require decompression or such chances are there, then better we should in that condition we can keep on heparin at that time. If using intravenous unfractionated heparin, it should be administered as a bolus followed by infusion and adjusted based on the institute protocol. The heparin should be avoided in individual with CVT with history of heparin-induced thrombocytopenia. The presence of intracranial bleed or subarachnoid bleed is not a contraindication. This is strongly recommended, so we can easily use in this such patient. The systemic intravenous thrombolysis is not recommended in acute thrombolysis. I'm not talking about thrombectomy. This is thrombolysis. IV means systemic IV thrombolysis. What we are doing for stroke case is not recommended for acute CVT. The presence of concurrent head and neck infection is not an absolute indication contraindication for anticoagulation. These are the European stroke guideline, and similarly the AHA guideline is that it is recommended in LMWH is recommended over means unfractionated heparin, and the presence of venous hemorrhage does not constitute a contraindication for anticoagulation. Similarly, this is the German guideline. In that some key questions were there, like in patient with acute CVT, does anticoagulation improve clinical outcome compared to no anticoagulation? That is strongly recommended that it has improved. It will improve. So then similarly, like which one is better? So again, same thing will come, like low molecular weight heparin is better than. In pregnant women and postpartum women, does the use of anticoagulant therapy improve the outcome without causing major risk to mother and fetus? It is a moderate recommendation, and it's shown that it is beneficial in those cases also. Next question was like, for pregnant women with previous history of CVT, does prophylaxis with anti-thrombotic drugs during pregnancy reduce the risk of thromboembolic event in the event or affect the pregnancy outcome? In view of low recurrent rate of CVT or venous thromboembolism during means prophylaxis, this should be considered during pregnancy for at least 6 weeks postpartum if patient has more prone for thrombosis. An indication for low molecular weight prophylaxis during pregnancy and the postpartum period exists, in particular if CVT occurs spontaneously or in connection with the previous pregnancy or under like patient is on OCP or something. So in that condition, we can use the prophylaxis. The take-home message is therapeutic heparin should be initiated as early as possible. The ICH and hemorrhagic venous infarct is not a contraindication. LMWH should be preferred, ideally you should prefer until unless some certain situation. And anticoagulation is safe and recommended in all population like pregnancy, including children. And current international guidelines strongly recommend heparin therapy for acute CVT based on consistent evidence. Thank you. Last.
Thank you, sir, for your great presentation. Our final speaker for the session is Dr. Shakir Hussain, sir, who will speak on CVT thrombectomy. Shakir Hussain, sir, is a visiting consultant in BMH Calicut and University Hospital Zurich, which was with a special interest in complex mechanical thrombectomy, and he's pioneered in high impact microcatheter navigation techniques. We welcome you, sir.
Thank you for your kind introduction, lady. And I think this topic has been nicely discussed already as far as its presentation and its so this is a very important topic because relatively this disease is more commonly seen in our developing countries than in the developed world. And there is enormous work being done at NINS, it's national, at NIMHANS. Dr. Nagaraja was particularly interested into this topic, and I think subsequent generation has taken a keen interest, and I can see many theses has been continuously being awarded into this subject. So I have no conflict of interest to declare, but I would like to make an acknowledgement to my two important people of my life journey. Dr. Ghazi Yashargil was was until recently was a living legend of microneurosurgery, and Professor Antonio Alavanis, under whom I did my interventional mentorship and learning. And the work which I am going to show you is largely done at University Hospital Zurich, Baby Memorial Hospital, and this Perintalmanna EMS Hospital. Now, the important part of this school is a very continued approach to deal with every brain disorder, and specifically neurovascular condition is primum non nocere. That is, first do no harm, and that is something which is a very strong part of the philosophy. And to be with the minimal devices within the vascular system. And the third most important, and remain as a minimalistic as possible. So this strategy gives rise to a very low complication rate and bigger reward. And this is our team. I would like to thank each one of them because they constantly keep me academically alive.
And the subject of, I'll go directly to the previous two speakers have nicely covered the topic in very good detail. So this is the University of Zurich area. This is the building where our department is harbored. It's called Nord 1 Center. And this is my current hospital of work, Baby Memorial in Calicut. So the venous system anatomy, let's recapitulate. We have already seen and discussed that they broadly divided into two systems, a superficial venous system and a deep venous system, right? But both the venous system are in a hemodynamic equilibrium, or they are connected to each other at some or other point of their connections. So on a angiogram, how do we see and how do we identify the deep system? So this is a superficial system which comprises of the superficial venous sinuses and the cortical veins. So this is the superior sagittal sinus. This is the torcula. This is the straight sinus, which is a part of the deep system. This is a vein of Galen. This is the internal cerebral vein. This is the caudate vein here, and this is a septal vein. And similarly, here it is a transverse sinus. This is a sigmoid sinus. It is a sigmoid shape. It merges here into the, what you call the bulb of the inferior jugular vein. And this is a 3D rotational angiogram. This is on a normal angiogram that you would see. On a gray scale, you can identify this is a superior sagittal sinus, transverse sinus, sigmoid sinus, jugular bulb, and jugular vein. Okay. And this is a suboccipital system. So they are connected through the diploic vein into the suboccipital venous system. These are the cortical veins, which starts from the frontal region. From either hemisphere, they drain to the superior sagittal sinus. And some of the veins may be enlarged, like the frontal vein, if it is enlarged and capturing the territory or anastomosing with the superficial middle cerebral vein here. This is the superficial middle cerebral vein. This is a vein of Labe, very enlarged and actually capturing the territory of the superficial middle cerebral vein. Normally, it is a small vein. So there is a high variability of the venous system as compared to the arterial system. So in each patient on the two hemispheres, there is no similarity or symmetry. So forget about the individual cases. So there is a high variability. And that must be first understood when you are understanding all the science and all the findings of the imaging that you want to analyze on the imaging. So this is the deep system. This is the internal cerebral vein. This curve is a vein of Galen, straight sinus. The meeting point is a torcula here again. So this is how on the lateral view we see it. And if you look at the anatomical specimen this is a superior. So they are encompassed into the sleeves of the dura. Okay, so this is a dura mater. Here it splits into two parts and it harbors the superior sagittal sinus. This is the inferior sagittal sinus, which is in the edge of the falx cerebrum. Okay, and this runs the junction of the falx cerebrum and the tentorium cerebelli. This is the tentorium cerebelli, this one. This is the cut part, but this is continuity is like this. So junction of this point with the superior cerebellar, what you call the tentorial sinus, it harbors the straight sinus. Okay. And this is the transverse sinus, sigmoid, and this thing. They have a connectivity with the cavernous sinus through the inferior and superior petrosal sinus. This is what you see on the superior view of the skull base. This is the what you call the straight sinus, transverse sinus, sigmoid sinus. This is superficial, the superior petrosal sinus, and this is the inferior petrosal sinus going down here, this one. This is the cavernous sinus. This is the clival sinus. This is the clival place, and this is called the basal sinus or the clival sinuses. This is the superficial the deep middle cerebral vein, or the sphenoparietal sinus also it is called as. And this is the superior ophthalmic vein that you see. Now, some of the salient feature of this system is that these sinuses are enclosed in the fold of the dura, as I said, and it ensures that they do not collapse. So it gives a rigidity to this low pressure vascular system. Cerebral veins do not have such rigid structure, but they remain open due to the transmural pressure gradient. And this is determined by the fact that this what is called the Starling resistor model. By this theorem, it states that so far the flow is maintained into any vessel, it remains patent because of the intravascular pressure and the perivascular pressure gradient, which is almost equal. Now, there are changes happening in when there is a raised intracranial pressure, there is a change in this pressure also. But it is auto-regulated until the point when there is a failure of the auto-regulation, and at that time, at the end of the raised ICP, there is collapse of this auto-regulation and the veins also get collapsed. And that's a time when there is no circulation happening into the brain if you do an angiogram. And that is the state of what we call the brain death. Now, they have a important point is that they, unlike the other veins in the body, they are innervated through the what you call adrenergic nerve fibers through the cervical sympathetic trunk. This is a very unique phenomena, and noradrenaline in such situation causes vasoactive constriction, and vasoactive peptide in the substance P, they causes a dilatation also. And similarly, the hypocapnia, it constricts the small vein and the arteries. Arterioles rather. So the venous infarcts that you see as a result of the venous occlusion is not seen in every cases because of the fact that it appears only if the pressure gradient or the venous pressure rises sufficiently to lower the cerebral perfusion pressure below the auto-regulated, the pressure. Then only the ischemia. It is the same phenomena that we see in a reduced cerebral blood flow. If the cerebral blood flow is significantly reduced, only then you develop a penumbra. Otherwise, it remains in a oligemia, which is asymptomatic completely, where the neuronal function is completely normal. They can be distant. So the similar phenomena can be observed on the venous side also, because it's ultimately a cerebral perfusion. Now, the outcome of the venous occlusion depends on, this is the most important thing, and this is the highlight of the day, that as in the arterial system also we understood this time is not the important determining factor to create infarct. It is the collateral circulation which is important, because every organ of the body, the nature has created with precision and with time. And every organ has been given a collateral circulation to survive. Brain being the most valuable and most precious organ and most intricate, ununderstood organ in many ways, it is very elaboratively collateralized. It has to be, because it is a journey of 50 million years the nature has taken. So it has to have a surviving in every situation. And that is provided by the auto-regulated collateral circulation. So availability of the collateral circulation, if it is there adequately, then patients are sometimes asymptomatic or with the mild symptoms of headache, but still they have a cerebral venous thrombosis. On the contrary, every patient do not bleed. That's also explained that if the collateral circulation has taken over, there is no rise in the venous pressure and they do not burst. The venules do not leak out. So, but if there is a raise in the venous pressure not sufficient to rupture them, then they developed a raised intracranial pressure, what we call the secondary intracranial hypertension, similar phenomena like IIH, but it is secondary here. So the treatment modality has also changed. Today, we understand the venous disease in much better way today. What we, in the last almost 5 decades, we kept the IIH in the Pandora box of idiopathic disease, is no more idiopathic. It's a secondary disease where there is a large number of cases have a venous restrictive disease or venous stenotic disease in the larger sinuses. And we perform today the venous stenting and the complete resolution of the symptoms, including the papilledema, which develops by these patients, and they completely become asymptomatic from the headaches. And that is something very, very, very important, because venous diseases are very poorly understood in neurology or otherwise also. One of the examples is, if you must have heard of it, is CCSVI. When we were talking about multiple sclerosis, there is a new theory with Zamboni from Italy. He proposed a theory. He studies his wife who suffered from the venous disease. He was a vascular surgeon. He studied that her wife's problem very carefully. And he conceptualized that it's a problem in the venous outlet or venous disease, venous drainage of the system. And he proposed this CCSVI theory, and the procedure that he did was that you dilate the veins and enhance the venous drainage, and then there is a corresponding improvement in the neurological function in these so-called multiple sclerosis cases. So that procedure was called liberation treatment, and I'm not sure whether you have heard about it and you are aware about it. We did about more than 100 cases in 2011 and 12, because all this crowd was coming from, not from India, but they were all coming from America, Canada, New Zealand, UK, all these places. My first case in Asia was it was first Asian case that we did in 2010. The patient came from Vancouver, Canada. So what I mean to say is that venous disease has its own wide spectrum. So IH and the dural fistula is also part of the same phenomena that we are talking about, the venous sinus stenotic, what you call occlusive disease. Now, when the resolve, if they are mildly symptomatic or moderately symptomatic, and the resolve in the late chronic phase, they may result into either a so-called IIH or a dural fistulas, which is we are seeing again very commonly, and we are treating them in a chronic phases. So intracranial collateral circulation of the venous side is also of a important significance. And just to briefly highlight you the fact that I do not want to go into the detail. If we talk about it, we can spend whole day on just the neurological basis of the collateral venous circulation. But very briefly, I can tell you is that it is a cavernous system which develops first and drains the whole brain. Okay? The internal jugular vein and the system, the deep system, rest part of the deep system, they'll develop much later in the chronology of embryological development. So it is centripetal, this thing. So if it is so embryologically, in many cases, in many situations, you must have seen, if you study carefully, if a cavernous sinus with a good venous outlet through the superior or inferior petrosal sinus, which also have a variability in terms of hypoplastic or a well-developed nature. Depending on that, they have sometimes excellent collateral circulation without any problem to the patient and completely asymptomatic. And the second group of patient which has what we call the transmedullary collateral circulation, which is what Dr. Subashiri. Dr. Subashiri nicely showed an example of a brush sign on venogram that you see, especially on the SWI images, because you see veins better there. So you see these as a brush phenomena because all these veins are visualized, what we call the transcortical vessels, transcortical veins are prominent, and they also constitute the what you call collateral circulation. Now, in the pathogenesis of the CVT, very briefly, the thrombosis of the vein and the dural sinuses. Now, largely speaking, when we talk about cerebral venous thrombosis, it encompasses two broad categories: cerebral vein thrombosis and cerebral venous sinus thrombosis. Okay? So these are two things. So you may have an isolated cerebral vein thrombosis. Just one vein or two veins may be thrombosed, but the sinuses are perfectly all right. So what happens in this situation? Patient becomes symptomatic for that particular venous territory if it is not drained by the collaterals. For example, if you have a trollard vein occluded and patient has a good collateral circulation through the trollard vein communicating with the vein of Labe, he will not have any problem. He might have a little problem of some area which is compromised, which is causing the medullary venous congestion. May become symptomatic, may throw a seizure, may complain of headache, or may become sometimes symptomatic, or sometimes they just come. I have seen cases which has been, in fact, diagnosed as what you call the Rasmussen encephalitis, because they show only hyperemia. You do a contrast study because they stay. The contrast is still there because of the breach in blood-brain barrier over there. So all these manifestations are dependent on to the which system is involved. If the only cortical veins are involved, it will be completely different presentation. What largely we are talking about, the major presentations are cerebral venous sinus thrombosis, right? So when these sinuses are occluded by the thrombosis, there is a venous regional venous drainage disturbances, which can lead to the cerebral perfusion pressure reduction and neuronal ischemia, or increase in the venous pressure, leading to brain edema, which may result into raised ISPT or IIH-like phenomena, or they may rupture to cause a venous hemorrhage. Okay, so these are the pathways that you see in the similar way. So, cerebral venous thrombosis has a all or none prognosis. If it is treated well, it has a very, very rewarding outcome, excellent outcome, in spite of the fact that sometimes you have a very ugly looking bihemispherical venous hemorrhagic infarcts, patient to very poor neurological grade, even sometimes GCS of 4. I have seen cases with me. GCS 4, both hemisphere filled with venous infarcts. You recanalize the sinuses in time using whatever tactics that you want to use, and they have a dramatic outcome with a remarkable complete functional recovery. I have case examples. Unfortunately, I couldn't put some examples right now for you to show. But those who have worked with me, they have seen those cases, and they agree with this point. But if you don't treat, or if you are not rightly diagnosed or neglected in terms of treatment in some way, or delayed in the treatment, then they have a bad outcome. Now, if treated frequently, adequately in the acute phase itself, they have a very good survival chances, and the long-term prognosis also is generally very satisfactory. It's needless to say that anticoagulation is the line of treatment, is the front line or the major line of treatment. Mechanical revascularization plays a very small role in select indication of cases, okay? Even though if the patient comes to you later, for example, usually these patients come late. They don't come immediately in acute phase. Here, the acute phase is not acute like an arterial acute phase. Here, it is more like a subacute phase. The patient has occlusion of the venous sinus, and they become slowly symptomatic over 1, 2, or 3 days or 5 days. That's why they all come after 5 days, 7 days, 10 days, because they become symptomatic later. So anticoagulation treatment is the front line, and I think it has been, Dr. Raja has very nicely highlighted all the aspects of the questions that are distributed or are questioned for the cerebral venous thrombosis, including the hemorrhage and subarachnoid hemorrhage. Don't fear, use it with vigor. Don't be half-hearted. The fact of the matter is that all this knowledge is there. I do see many presentations happening, like you also emphasize on this point. But in my all multiple places, wherever I've worked in general neurological practice, there is some kind of a fear among the neurologists, and they always use substandard or suboptimal dosage of the drugs. I do not know why. I'm quite sure NIMHANS has a very, very full-fledged protocol of use of heparin, actually, and I know that it is there. So what I use is that heparin. I prefer heparin for unfractured heparin for 3 reasons. Number 1, and in my view, all these randomized trials may show that they are low molecular is a little bit better, but I have a reason to disprove it also. So I will not go into that challenge at the moment. But the vital point is both are anticoagulants. And there is no reason why one should be superior to the other. The only reason why it is superior or possibly superior is that in some environment, not all. In my service, no. Because the most important thing for the management of these cases with heparin is a regular personal monitoring of the APTT level. We have a charted protocol, Dr. Siddhitesh knows about it. We do not leave this job to the critical care people at all, or to the nurses. They have to perform and inform, and we have to monitor it. So if you monitor the APTT level, and we achieve 2 times level, not 1.5 that Dr. Raja mentioned in most of the trials that they achieve 1.5 times. we achieve 2 times APTT level, twice the baseline. And sometimes there is a rise also, but don't panic to reduce it abruptly. If you do use abruptly the stoppage of the heparin, then the level goes drastically down to the baseline level, and then you have to rebuild again. So it becomes like a chasing it's a waveform of the activity. So don't be afraid of, even if you achieve a 3 times of the APTT level, need not to afraid of it. Now, why I'm stating this statement that during our procedures in last 30 years, we use heparin like in a carotid stenting cases and various other situations, plenty and enough, fearlessly. We monitor during the procedure all this through the ACT level, which is very accurate and very immediate, right next door. I mean, right in the lab itself. So don't fear from heparin. And the second reason for this is a very cost effective, this is low cost. The low molecular weight is quite expensive. And as you are also highlighting, in our population is a low socioeconomic zone, and the nutritional deficiency, which is again the low socioeconomic, is more reason. So to take the cost of the low molecular heparin for a long time, lasting sometime 2 weeks or 3 weeks, is a pretty high cost. And the third important factor is same as you also highlighted, Dr. Raja highlighted, where you require renal profile is compromised, or you require surgical intervention, you have to switch over. Because we prepare these cases for either intervention might be required or surgical decompression may be needed, you should be ready for it. So for all these questions to answer effectively, low molecular heparin, the unfractionated heparin is the best drug. But one thing, always care for it. We do see that there are certain, what happens is the effectivity of this heparin is sometimes variable. And this is iatrogenic, because if it does not preserve correctly in the low temperature, the cold chain is not maintained, or a particular lot of the heparin is not effective, it's not effective. So what we do is that we check if it is not rising with the APTT level is not changing, even if your dose escalation or a bolus dose that you again give after some time, then you should doubt the batch and you change the lot of the drug. So that is what I have seen, that the moment you change the lot of the drugs, the effect comes very quickly. So endovascular approach, the mechanical revascularization, I would call it as a mechanical revascular or endovascular revascularization, may not be necessarily, as I said, should be mechanical. It could be chemical also. And we do it in our combined way also. So in 1990s, some surgeons used anticoagulant to deliver into the superior cell sinus, going through the catheter into the jugular vein. So what are the indications? The indications are very strict and very clear to us today. This is what we follow. First and the foremost, where the anticoagulation fails. Patient in an anticoagulation not responding and the symptoms are worsening. If patient is stable clinically, neurologically, then there is no need to jump the gun. You continue. If anticoagulation failure and symptom worsening is noted, or if you document the propagation of the thrombus through the serial imaging in spite of anticoagulation, then we must consider a mechanical or endovascular recanalization. Or if you have a severe brain swelling, that means the outlet is severely compromised and is causing raised ICP, which is often manifesting in the form of the bilateral papilledema. Patient often complain. All kind of nice examples, a variety of examples are again shown by you in the previous presentation from this institute itself. So which you are very much aware of it. So in these cases also, what is called a venous congestive encephalopathy, and there is a chances of impending herniation. So we do not wait for that, and we do endovascular approach of management. And important thing is endovascular approach is very, it's not very, it's tiring later because time consuming as compared to the intra-arterial recanalization. But it is very rewarding, extremely rewarding, and relatively low risk than the arterial recanalization, relatively. If you have involvement of the deep system or unpaired sinuses, like the superior cell sinus is affected, Okay, or the straight sinus is affected. Do not wait too long for the anticoagulation to act. So if the straight sinus is affected and patient has usually patients are unconscious because of the biothalamic involvement of the territory, you should proceed faster because there is no chance of collateral circulation to these things. And if they sustain that situation, they usually have a poor outcome. Or last but not the least, if the patient comes to you in a poor GCS score, you want to give a chance to this patient, you must try it immediately without any delay, because the rewards in such situations are extremely high, extremely high. So there are conventional techniques. So there are two conventional techniques. So strain retriever thrombectomy, or we do a suction thrombectomy. And these words are sounding quite familiar to you now because since morning we are talking about it. These are taken exactly from the arterial system. The devices are also same used so far, what is used in the arterial system. That means the arteries, which is smaller in size of a 3 millimeter, 4 millimeter. Here the venous sinus is a 15 millimeter or 20 millimeter in size or 8 millimeter in size. They are all large sinuses. So the same stent retriever and same suction devices will not be effective in a large channel. So today this is a big compromise that we have. And because these procedures are done so rarely, so as such the disease is rare, as such the people performing, they are not scattered all over equally in the country. And essentially the inclination to intervention is also not available. And also sometimes the learning curve is not there. So people are a little bit skeptical and afraid of approaching to this route of recanalization. So because of that, there are very few cases happening in the country. So no company is interested in making a new devices for this. So that's why we have to compromise with this. And sometimes we use a conventional technique, which is exactly the same as arterial recanalization. And the approach that we take is a transfemoral transjugular approach. We go through the femoral vein, inferior vena cava. It crosses through the right atrium, go to the superior vena cava. And you have to be careful in navigation because you are going through the venous channels, which are very fragile. And if you rupture right now in the proximal part itself, it is fatal even. Why? What the venous rupture will cause? The leakage of the blood. Where it will leak? It leaks into retroperitoneal space. Okay. And retroperitoneal hematoma are very difficult to diagnose. And the only thing patient has is hypotension. You keep infusing, keep giving catecholamines, it doesn't catch us. And patient empties out the heart or the severe shock happens and they die. So they are fatal. Or when you're crossing the cardiac chambers, you may create arrhythmias or sometimes ventricular tachycardia. So one has to be careful here, and you just reach to the what you call the jugular vein. And once you approach to the jugular vein, you take your catheters across any pathway that you want to take it, or to the superficial sinus or to the straight sinus. Navigation is a very simple or fast procedure. It takes hardly less than 1 minute time from femoral to the superficial sinus, less than 60 seconds. But it has to be done in a correct way with the correct training and correct orientation. Now, the conventional technique might be inadequate in extensive subvenous sinus thrombosis because of the large organized thrombus load. Usually it is a very large thrombus load. And second, as I already mentioned, the availability of the venous thrombectomy devices is not there. So we have to struggle. So what are the methods that we have today? There are pharmacological lysis. We use local heparin into the sinuses, okay? So we go into the sinus, use first local heparin, so that the propagation is reduced. It's not clotting faster, number one. Number two, you can use any lytic agent which is available to, if you have a urokinase, which is the cheapest drug, but unfortunate part is that they are not available anymore. It's a very effective drug. I've used it extensively in intraarterial as well as intrasinus thrombolysis in my past experiences. It is a wonderful drug. It's very cost effective because it's practically no cost now. Of course, you can use OTP, it was extremely expensive. We have alternative place, which we have done first case in the world. Dr. Rimpi, that this paper is under publication for multiple reasons. And this is the first intrasinus use of tenecteplase, which we have demonstrated in some of our cases. I'll show you my case, which is recently published in Neurointervention Journal. So it has a safe profile and safety in this regard. Mechanical revascularization, we can use stent retriever suction thrombectomy. We also do balloon venoplasty and different techniques which we have now recently conceptualized. Any combination of these techniques can be done. So there were in the past what we call the rheolytic thrombolytic system. Rheolytic is like an angiojet. So with a high velocity with a small tube, you create a high velocity jet of the saline forward, which will strike to the clot and will decimate the clot. And the second channel, which is there with the higher velocity, takes a negative suction. So the jet strikes onto the clot and the next jet sucks the things inside. So it breaks it, it causes the decimation of the clot and the suction thrombectomy. It worked for pretty time, but one of the major limitation of this device is a very rigid system. So to navigate into all the sinuses is not a very easy thing, and it's a little bit traumatic, and possibility of complications are there. So there are many Fogarty system, Fogarty catheter people have used, snare thrombectomy, and so on and so forth. So I just want to end my talk with this example of a 58-year-old woman, type 2 diabetes, dyslipidemia, and rheumatoid arthritis. These were probably the risk factors in her case. And she was on some form of an Ayurvedic medication, which we were not aware of the composition. She presented with a 10 days history of headache, vomiting, followed by progressive bilateral visual blurring and diplopia over last 4 days. This was her MR scan at the time of admission. All the sequences are there. You can see that apparently there is no evidence of any what you call hemorrhage in this situation. And this patient is basically, if you look at it, is filled with the superior sinus, is filled with the clot here. And if you see the venogram, is completely, there is a complete occlusion of the superior cell sinus, and even the right transverse sigmoid sinus here, the left side of the sigmoid transverse sinus also obstructed. So the major occlusion of the bilateral and the unpaired sinus pathway to drain the brain, but she is maintaining the integrity of the venular wall and not causing any hemorrhage. So what she has is a severe papilledema and visual blurring, and diplopia is a sign of raised ICT. This is a angiogram that with the venogram phase on angiography, that you can see that the whole of the sinus, the anterior part is relatively, you can see that there is a filling of the contrast here, but the posterior half is completely occluded. There is no drainage of no visualization of the contrast here. And here also you can see a complete absence of this right side of the sinuses, and very low intensity of the grayscale over there. So this is the interventional, some slides that what we use in this case is a balloon here. And this is a first time ever we did this technique with a, what we call the non-compliant balloon, and what is called the pipeline pigging technique, which has just recently published in the literature as the first case in the literature. So what we use this catheter is that we went forward into the open, until the open area with the balloon here, and we did a lot of, the cleaning work with the inflated balloon. So we pull out the balloon in an inflated situation itself, bring it all the way to the catheter here, and keeps doing suction over here. So there is decimation of the clot. They were extremely hard, dark, black colored clots. And in between, what we did was we injected tenecteplase into the different part of the sinuses, about 2 or 3 milligram of the tenecteplase, and waited for some time, 15 minutes, and waited for some time. And after that, we did again this pigging technique using the same balloon, because this is a literally for the patient, no cost procedure. We didn't use any material cost in this case. Even the tenecteplase you used in this case was available from one of the previous cases, as I keep saying. We just need 1 or 2 milligram. And we recanalize these sinuses completely. You can see this is the end result, a complete canalization of the sinuses on the both the sides, and drainage appeared. And this patient started what you call improving, and she's now, I think, post 3 months. I recently saw her in my clinic. 2.5 months later, she's doing very well. And so the balloon has been used in the literature by several group of people. The common one is that they use a distal access catheter here, and they do a angioplasty with this balloon and do a suction from there. The other method is that they keep this distal access balloon catheter here and use this balloon back and forth, back and forth, back and forth in this situation to decimate the clot and suck the thing. The other one has a kind of a longer length of this thing used, but keeping the back catheter over here. So what they do is that they take it inside and then remove it and then do the suction. What we did was a different in the using the same. Now all these people which have reported is with a compliant balloon. The compliant balloon is made up of a what you call not a made up of a latex actually, or silicone. So it doesn't exert pressure on the wall. And what we use is a coronary angioplasty or any angioplasty balloon, which is made up of a plastic. So if you dilate them, they are as hard as bone or a rock. They cannot be compressed once you inflate them to 5-10 atmospheric pressure. So that's one fundamental difference in dilating this balloon. We did a long segment, the tracking back until here. So we'll bring it until this point where the guiding catheter, which is the largest bore, and we do suction here and deflate the balloon here. We go back again with the balloon here and do it again. So we go through the different channels because sinuses are septate structure. It's not like an arterial single lumen structure. They have a multiple septation. So you have to go through the different channels by trial and error methods. There's no other way, other means that will guide you to do in a correct way. So we name this technique as a pipeline pigging technique. And this, if you are interested, this is a recent last month. This article is published in one of a prestigious neurointerventional journal. Is from Korea. So to summarize the thing, I would say that the spectrum of endovascular venous sinus recanalization can be broadly classified into two groups. The pharmacological recanalization, where we use either anticoagulation or thrombolytic agent. Sometimes we keep the catheter inside. We have a multiple hole catheters. We can leave the catheter inside the superior sinus and inject RTPA or tenecteplase or heparin, whatever you want to use in that particular case, over let's say 12 hours, and next day again you do an angiogram, check angiogram. If the recanalization happened, then you remove the catheters. So there are multiple variation in the individualized techniques that we have in several many ways. So these are the mechanical ways, and venoplasty and venous sinus stenting is another group of patients which is commonly reserved more for the chronic occlusion than acute occlusion. So in conclusion, I would say the mechanical thrombectomy has a limited role in cerebral venous thrombosis management, but it has a definitive and rewarding role in cerebral venous thrombosis management. Thank you very much for your kind attention. Yeah.
Sir, like in IH case, there will we have seen like stenosis of venous sinuses will be there. So we don't know, means we have read so many articles in that it was written it is cause or effect, we are not sure.
So, yeah, I agree with you, especially Huggies from UK. I think he's one of the person who has done a lot of work on IH, and he is of the opinion. In fact, he has commented on in a later part. If you read the same article of the same gentleman in the later part in 2000, he has agreed that venous stenosis is a reason for the problem. So, how do we objectify it? Very simple. We have parameters to consider it, that when to do the venous sinus stenting. Our protocol, we have done about 7 cases in last 1 year. All of them are women, all of them are young, and all of them are symptomatic with not only headaches, refractory headaches, but with bilateral papilledema. Early, or one patient had a long-standing problem with a complete optic atrophy. We didn't want to do that case, but the family insisted. So including that case, all other cases out of 7 has a fantastic result, 100%. All of them improved completely. Now, how we objectify? One is that the clinical profile, I already mentioned, these are inclusion criteria. Then we do the, what you call the imaging. You know, the imaging has a very definitive sign. We see the optic nerve, the CSF space ratio. We look at the flattening of the the posterior surface of the orbit, or sometimes the big disc bulge is there, and sometimes if you do a very careful diffusion imaging, you can document the venous ischemia on the disc actually, which is a little bit not easy to replicate. And other things are empty sella and all others, many more signs are there. We essentially take into account. And the other last thing is that the venogram or if I have to do it, most of the cases they are referred to us, so they all come with a venogram. If I have to do it, I prefer to do a CT venography, which is more definitive and high collaborative to the DSA. So if you demonstrate that there is a significant stenosis or severe stenosis in these sinuses, then we take up these cases for the DSA. First, we rule out the secondary causes of IH. So we do a 6-vessel angiogram, and then we do a venous manometry. We go across into the superficial sinus. Venous manometry, if the gradient across the stenotic segment, some people in the West says about 5 to 8. I consider 10, upper limit. So because these are early experience, when you build, you have to take a very definitive cases. So very definitive would be that I explain them. If it is 10 or more than 10, then we consider them for the stenting. And all of these cases that we have done, 100% result. So this is a new frontier. I think there's a new way of looking at it, and I think this doubt that cause-effect relationship is dying off slowly.
Because we have seen a few cases in which we give antiedema,
Yes,
and after antiedema, that whatever stenosis was that was resolved.
absolutely. I agree.
So
So I forgot to mention one important point in the clinical selection of cases, refractory to medical management. If they are, all these cases are referred to us by the neurologist, and they are usually for 1 year, 2 year minimum with them, and they are symptomatic, or they were symptomatic without edema before. Now they are frankly showing edema in the papilledema. So that means there is a progression with the medical treatment. So refractory medical treatment is a must.
In Zurich, there's a last course that Philip was discussing.
Well, they have a different protocol, and so his protocol is even different. They are much more inclined to take every case actually.
So he was saying that St. John's, he, I
5
think
mil-
almost practically
many times
he
He doesn't consider the pressure gradient also.
And in fact, in NIMHANS, they were Dr.
Uh,
Tali's unit was
Sridhar, use closer.
Tali's unit, Dr. Tali's unit was doing stenting. I don't know what happened to that. Still doing. Yeah, yeah. But these groups in say John Hopkins, they regularly do it. Yes.
Yeah. Well, I personally feel, just Siddhitesh, as you know, that we also had a discussion on this in the Zurich when he presented. The subsets of cases are different and the pattern of practice is different. I don't think I would agree with all that indication that they have. I'm more conservative in that regard. Our criteria are more robust, more, I would say, more stronger to remove our biases, actually. I do it for removing my bias of doing the procedure. Because when you are doing something, you are inclined to do that way. And you try to take a borderline case into doing the things, actually. If it is, say, for example, cutoff point is 8, and if it is 7 millimeter difference is coming, you'll say, it's a 7.5, it's 8 millimeter. I go other way around. I unbias, and because these are not emergency procedure, if they are delayed by 1 week, 1 month, or 3 months, are not going to be a major catastrophic worsening or this thing. Still, it is experimental procedure. It should be done carefully and under strict ethical protocols. So that's important for us.
Any questions?
Yes.
Like for endovascular therapy in CVT, whether based on length of the thrombus or any specific sinuses involved, because if extensive sinuses are involved, those are usually refractory to treatment. But extensive sinuses are involved, then I don't know whether really this endovascular intervention is possible, because they have to go there and then they have to give some intravenous thrombolysis or something. So,
well, intravenous thrombolysis will not have any effect in this situation, and I think trials have also shown it, because it's occluded sinus. So if you give intravenously, it has to reach the brain through the arterial route, no? Ultimately. So you inject intravenously, it goes to the right ventricle and then the left ventricle and then to the brain. But if it is not flow is not happening to the sinus, it is all going through the collateral route. So it is not reaching to the site where it is needed. So it will not be effective. So what we propose in extensive dural sinus thrombosis is, these kind of results are not seen in all cases that we perform. Okay, in the first angiogram. Usually, this approach that we take, we do, as I said in the beginning, that's a very time-consuming procedure. It takes a couple of hours. And you don't see immediately like arterial changes. So it's not attractive, angiographically rewarding immediately. So you are a little bit demotivated. Also, you are tired. When you are demotivated, you are tired. But what we recommend and what we do is that do your best thrombectomy attempt, and then combine with the thrombolytic agent or the intrasinus thrombolysis, heparinization, and keep the catheter inside, keep the sheath in situ, bring the patient back to most of these patients are on the ventilator. So they are critically well managed. There's no problem in shifting them. You monitor their critical management part, and next morning take them back to the angiographic suite. Perform the angiogram again. You would be surprised that next day the findings are completely different. Sometimes the third day, the findings are so robust and so beautiful that, oh my God, it's completely normal. So it is not that, like, as I said, like in arterial recanalization, it's entirely different game. Here you have to be patient and you have to be careful not to be aggressive to make everything visible in one go. Another very warning point that I want to give you is that if you have a high load of these clots and you are actually doing retriever thrombectomy and some clots are actually migrating to the jugular vein, where they are going to? They are going to the lungs. So you are causing a pulmonary embolism, and the pulmonary embolism is well known, a complication of a thrombectomy actually. So you have to be careful that you solve the problem there and you make a much worsening problem to the cardiovascular system where the patient is difficult to be managed actually. So you have to keep your mind at all these places. So you have to be a little bit like not acute in your approach, but subacute, or follow them over 1 or 2 or 3 days. That's the best way. You are safe and you are effective. Yes. Why residents do not ask questions? Huh? Is there any embargo in speaking? See this page? Why you terrorize them not to ask question? Huh? Please ask question. There are many stupid questions. I like that because that gives me a new pathway. The discovery comes from all stupid questions. Throw them. I will patent them. Yes. Yes. Look. Yes. Very good question. So by and large, I think there are almost consensus on this. At least if there is no secondary reason for hypercoagulable state. So you work out your complete profile of the hematological profile, and if you find a procoagulable state, then you continue longer, certainly, depending on the situation. But in our situation, if most of these cases are postpartum or dehydration related, or if it is a male patient only, then there is a alcoholism is a most common cause, or alcoholism related polycythemia also is a common cause of venous sinus thrombosis that I have seen. So in those cases, we give it for 3 months. And after that, we give antiplatelets for 1 year. But if there is a procoagulable state or any genetic or hereditary marker available, then it is basically lifelong. Yeah. So in that situation, 3 months anticoagulation. 3 months anticoagulation followed by antiplatelet medication. Or if you just, even if the lifestyle parameter was there, you try to, or patient is, let's say, oral contraceptives with a woman category, then you guide them that, or any hormonal treatment is there. So then you take care of that part. Either you withdraw them or you give them antiplatelet drugs and a good hydration. All right. Okay. Yes. Very. Yes, very pertinent question. This is often, you would see that, oh, it's now 3 weeks or 4 weeks. So I give you my one example. This young lady, he was in Bangladesh, and he had a extensive venous sinus thrombosis. She was admitted in a private tertiary care hospital. She was on ventilator with a poor neurological grade for almost 3 weeks. Right. And the family decided to fly and bring it to me. So they came to the chartered flight. They landed in India the middle of the night, almost 10 o'clock. When we examined, she was a grade GCS barely 4 and very obese. And so I said, well, the chance of this situation is very bad. And you see the imaging is both hemispheres filled with the hemorrhagic infarcts. And she was, so I counseled the husband, who was actually a prominent journalist there. I said, but he insisted that, look, we did all our exercise. I know that this is difficult. Whatever is the prognosis, we accept it. But because we have brought her here, let's do it. So I said, okay, we do it. So we start at 10 in the night, 11 in the night, until 5 in the morning. We recanalized it by several techniques. That one of them is which I reported now, but first time we did it in 2010, 2014. And recanalize the sinuses, same way, not perfect way. We kept the catheter inside. Next morning means it was 5 in the morning. So not the same morning, but the next morning. We did again a angiogram, and we found that sinuses are open. So we removed the catheter and everything. And I did the first thing at that stage, I did the tracheostomy in this patient, very obese, short neck. I said, well, now she will need a time. So we did a tracheostomy and we tried to wean off. In 3 days, we could wean her off the ventilator. She became almost GCS of 13, roughly around 13, 14, 13. But she was still dependent. MRS was still 2. And sorry, MRS was still 4. And we did a rehabilitation. She stayed with me for almost 1 month. And then we was a reasonable situation to be transported back by the normal flight and kept in another hospital there where she came from for almost another 1 month or 3 weeks time. She used to work in UNESCO. She's back to the work with the same vigor. That's an example. So the longest duration I have done is about 3 to 4 weeks. So the point, that's why I insist, very good that you asked this question, because any extent of venous sinus thrombosis, any duration of the venous sinus thrombosis, if it is not GCS3, or probably I will still take a chance in GCS3 probably, but largely you would not consider, because GCS3 means a brain death situation. Actually, the brain stem is gone. Otherwise, I will consider it even if it is 1 month or 2 months old. If it is GCS4, must do it, because they are very rewarding. Yes. Yes, so that's another point. Actually, the most important point is, see, that's why we insist on Sijitesh. You will appreciate now this point of our extreme, what you call emphasis, that who should do and why a person should do only one job. If as a neurologist you want to do it, you cannot be a general neurologist at all. You have to leave everything. I left neurology practice completely, even when I had no patients with me, because I wanted to practice intervention. So at that time, people used to call me, my colleagues and my seniors, that you are a fool. You are working in a private sector, you are sitting still. What is the problem that if you see a neurology patient, because you have no intervention cases, 1 case of the DSA in a month? So what are you doing for 29 days? Why don't you earn money? I said, no. I used to report EEG and EMG. EMG was my passion before this, electrophysiology, and I was reasonably good at it. So he said, why don't you come and report them again? I said, no, I don't want that income from electrophysiology. So it's a kind of a submission you have to give to yourself, not by the force of somebody. You have to decide what I want to do it. And when you do like that, then it is possible you can do everything with Siddhitesh. But if you are a casual person, even I say to my radiology colleague, because I do take new radiologists into my fellowship program, but I ask them, you have to leave the diagnostic neuroradiology. You can't do both the things, because it's a white collar job. It's a very easy job. So you will dwell over there. You would not like to come in the night, and you will do some kind of a delay or some kind of inefficiency of work because it's tiring, it's demanding, it's taxing, may not be rewarding after that. So you don't want to do it repetitively again and again and again as your career for 30 years. Are you ready to do that? That's the first question you should ask anybody. Same way the neurosurgeons are coming to us. I said, you leave the scalpel. And neurologists, you should leave your OPD. You leave your neurology. When you prepare yourself like that, you are 24/7 for the care of these patients, because you are transforming them. It's not doing the procedure. Post-procedure is most important for me. Those who work with me, they know how much I fight for my patients, our patients, because system deficiencies or system, I would not say deficiency, but system slowness or little bit, there are gaps in every system. And if you leave to that gaps, you do not generate a result. So following a good endovascular management or endovascular picture creation, sometimes you have to work very hard with the patient to bring out a clinical outcome. And that can be done only by the devoted people or clinician particularly, because they understand all sides of the games. But there are neuroradiologists who have completely transformed into intervention. I know my colleagues are there. They do 100% no diagnostic work. They work exactly like we work. So then you transform yourself into a clinician, not a radiologist then. So that is something which is important actually. And that is the whole debate of things in the country which is going on is who should do it? I only should do it. No, everybody should, anybody can do it. But anybody should not be everybody. It should not be that anybody is everybody. No, anybody means somebody. And the somebody is dedicated, devoted person. Doesn't matter where he comes from. It is immaterial. Because if you're coming from a neuroradiological background, you have an enormous benefit of your imaging anatomical acumen that you have, which correspondingly probably a neurosurgeon, neurologist may not have that much, which they have to build over time. So there are hybrid areas which we have to create, and that's a more primary important point. It's not important that, I mean, it becomes rigid then. It becomes scientism, the new terminology I discovered. It's not remain science. It becomes religion. So we are scientists. We don't make the boundaries. It's a human approach for the humanity. Preserving a life, preserving a functionality of life, which is a very rewarding than the preserving the life. Sometimes as a neurologist, you know that when you preserve a life, you feel so sad that why I saved this life, because patient is vegetative now and a bigger burden to his family. It's painful then. But there is no way that we can get rid of that, because in the whole pathway of the critical care management, some patient will probably stop at the vegetative state. So the point is basically that to transform to practice a specialty or a tool to transform into a high probability quality outcome at a cost-effective way. The third point is specifically for India. This I don't use in Zurich at all. Is our prerogative. And we know in our daily clinical practice, a person who is not in contact with, for example, there are many, I understand that here you have a very good interaction, clinical, the neurology here has a good clinical interaction with the group, with the neurosurgery and neurology, I know that. But there are many places in the country where there are no neuroradiologists are completely isolated. They are very mechanistic in their thinking and doing. So how it can be possible that the clinical view is not incorporated into the approach to the management of these cases? So this is advancement which is happening, and each specialty has its niche, its contribution, and the collaboration to share. And that is where you transform then into what you are questioning is that why everybody is not, or how everybody is not able to do it. Because what the word created in the Western world, and which we are so loosely using in our country, especially in the private sector. The institute which is open yesterday, they have a newly appointed person, not proven of any competence. They have yet to prove because they are fresh. They write the Center of Excellence. So Center of Excellence has become a joke in the country. So Center of Excellence in the West, what we call them or what they are, this is a Center of Excellence existing for the last 45 years or more. So you can say that it has proven track record. But a service which is just developing now, and I insist that no, only I should do it, would not be right for the population which is actually being served by that, the hospital by that region. Will not be a right step, will not be interest of that society. And who knows, it could be your near and dear in that society. So he will also be then. So we have to create an excellence. And excellence lies in the mind of a physician. He never says that I'm an excellent. It is the peer review says that And it's a continuous process. It's not an end of the, it's not a zenith. Don't achieve that zenith ever in life. Because the moment you achieve the zenith in the life, that means you are dead. So the science is a journey. It's a continuous learning process. We remain a student all our life. So that approach is an approach of collaboration. And I think that gives rise to what we call institutional development, because there are collaboration of the multiple excellences of the departments. It transforms the things. It gives a value, and an institute of this kind is there. It gives a value to the whole nation. We all take, whether I belong to this institute or not, I take a pride in it, because it belongs to my country. We are selfish people. We should be. So that is the point actually, and I think the whole exercises I would request, and I would like to see, I would pray, I would dream, I would use all these words, that we transform it. It's our job, collective. And don't consider that any action, only, the change happens from below. I believe that way. If I want to do it, I can, there are many ways we can do it. But if you want that somebody will decide and will do it, it usually does not happen. So use your own resources of your mind, language, communication skill, humbleness, submission, thankfulness, non-arrogance. So use all positive feature of your human character. Each one of us has that. And then you can transform actually. It's a simple job. So that is my last comment. Thank you very much. Any more questions? No. We take tea. Because we have to go. We break for tea? Yeah. If you want, you can continue.
Yes, but continue. Because it is already getting late.
Next, what is Dr. Sujit sir speaking about classification of stroke and recurrent stroke.
On display. So this is the particular talk is on secondary prevention in stroke classification. Now, how many? I just want to know how many of you classify ischemic stroke in routine practice? How routine practice? How many of you classify? You implicitly classify stroke. Okay. So I consider classification of stroke as a most important step that predict and help prevent recurrence of stroke. Now, what is the recurrence rate of stroke, ischemic stroke? Current ischemic recurrence rate is about 5 to 8% per year, or 5-year recurrence is about 15 to 20%. But this was not the case in 1970s. Most of the patients, almost 80%, have recurrence by the end of 10 years. Now, it's drastically reduced in the last 3 decades, and it's primarily because of almost universal control of risk factors. But I would also say that we can do better if you classify the strokes and do it in a continuous basis and act accordingly. So in our studies, we had about 7-year follow-up studies and 2 cohorts. Our recurrence rate is about 1 year, less than 1 year, 1% per year. That means implied 1 year risk. So reduction in recurrence of rate is because of the better classification and targeted investigation or intervention based on the classification. So theme of this presentation is to discuss the etiological classification and see how it helps to prevent recurrence of stroke. So we have different systems of classification. The most influential is, of course, TOAST. And we use something called as SSS, which is called it came from a study called SSSS study. Is a modification of TOAST classification. TOAST classification, as you know, came from a study in 1993, published in 1993, called Trial of ORG 10172 in acute stroke treatment. It is basically kind of heparin-like treatment. That study failed, but the classification system stayed. And ever since that, all the classification system is based on TOAST. Now, the SSS TOAST give an evidence-based dimension to this. So it follows a TOAST classification, but give different evidence grades. Like each of the classification is divided into evident, probable, and possible. So you have small artery occlusion, 3 categories: evident, probable, possible; large vessel atherosclerosis, 3 categories; cardioembolic, again 3 categories; and other determined cause and undetermined. Now, a small artery. So what is small artery occlusion? So if you look at this thing, when you have a penetrating artery occlusion, so this lenticular striate penetrating artery, and you have a stroke because of that, that is small artery occlusion, it will be usually less than 2 centimeters. The infarct size will be less than 2 centimeters, and typically in the lenticular striate territory, or maybe in the pons. So this, if you see in the CT scan an infarct less than 2 centimeter in penetrating artery territory, you call it evident small artery occlusion. And if you don't see also, you can call it probable, but you need to have a typical clinical Lachenau syndrome, like pure motor stroke, pure sensory stroke, ataxia, clumsy hand syndrome, dysarthria hemiparesis, or mixed sensory motor stroke without any signs of cortical involvement. And possible small artery strokes are when you have a typical presentation, but you're not done the full investigation. So it's an evidence grade by one. So these are the small artery occlusion. And then cardioembolic stroke is classified as evident when you have a stroke and associated high-risk cardiac causes like atrial fibrillation, LA thrombus, atrial flutter, and so on and so forth. And probable are when you have multiple territory, same age strokes. When other condition like vasculitis or maybe a paraneoplastic condition or cancers are all ruled out. And possibly is when the full investigation is not done. So you have something like this, shower of embolies, multiple territory, same age. And large artery atherosclerosis is stenosis 50% or more in a clinically relevant. In the same territory, you have strokes and you have occlusion more than 50%. And in probably is that same territory TIOs, but the stenosis is less than 50%. And possible is that when the investigation is not fully done. So this is a typical pattern of strokes. You have a wedge-shaped stroke or a watershed strokes or a MCA territory or different, or a penetrating artery. So you can have atherosclerosis and then the penetrating artery is affected because of large artery. And then you have undetermined when you have 2 different categories, unclassified or unknown. Unclassified are when you have multiple evident, 2 different causations are there, or unknown after despite all investigations is all the diagnosis is not clear. And in the TOAST classification, this is the standard diagnostic investigation. You do a CT scan, you do a vascular imaging, and in here, what important thing is that they don't specify what kind of investigation: CTA, carotid Doppler, and MRI. And this has an important implication in the classification as well as predictions. Echocardiography and the basic biochemistry and HbA1c. Now, what is the probability of the proportion of etiologically unclassified stroke as per strokes classification in each resident? What is the proportion of patients who are unclassified? It is more than that. Anyone else? About 30% are unclassified per TOAST. And this is very important. Now, we have beyond this, we do few investigation. We do CT angio in all patients, and there's a reason for that. CT angio actually covers the whole anatomy from aorta to the what do you call to the MCA in a very beautiful manner. And especially if you do maximum intensity projection, you can clearly delineate the arteries, the anatomy of the artery, while MRI cannot substitute that. MRI only show a flow related things, and kind of a secondary imaging of vessels. There are specific rules for MRI. For vessel wall imaging, MRI has a specific rules. But to delineate the anatomy, CT angio cannot be substituted. That's one. Then in suspected young strokes, when there are no other strong conventional risk factors, we do MR vessel wall imaging. And what is specific for Karnataka, we do homocysteine B12 and all. This is very important because in Karnataka, one of the more important cause for strokes is hyperhomocystinemia, and that is related to nutritional deficiency of B12 or folate, especially in the context of alcoholism. And 7-day Holter in elderly patient without strong conventional risk factors. And repeated APLA or ANA profile when you have a young stroke without strong conventional risk factors. You repeat at least 3 times in 3 months, still you chase it. Because what happened in the APLA syndrome, in autoimmune strokes, the antibody profile can come up later. And there are cases in which we have diagnosed recurrent strokes, young strokes as autoimmune, when all other things, and we have because patient was getting at least 4 events in 2 years, and then we thought there are many circumstances in which we made a diagnosis of young stroke. After that, patient is followed for 4 years. At least 3-4 consultants are seen across India. Now, so that's a kind of autoimmune stroke is a very uncharacterized group of disorders. So these are the 4-5 things which we take care. And with that, and okay, what is strong risk factor? Now, in the usual medical parlance, smoking, uncontrolled diabetes, and homocysteine are considered risk factors. But I consider this as a strong vascular risk factors. Now, even etiological. So here you to differentiate what is etiological factors versus risk factor. A risk factor is considered to be something contributing to causation, while an etiological factor is as a clause of sufficiency. And an etiological factor is sufficient to cause a condition, while risk factor is itself not sufficient to be causative. So risk factors contribute to a disease, but per se is not thought to cause a disease. So usually this in epidemiological studies, the odds ratio of this thing will be about 1.52 range. Now, by standard literature interpretation, they consider diabetes, smoking, all as vascular risk factors. But I think this is an underestimate of the early epidemiological studies, and it's almost like an artifact. The original large community-based studies like Framingham and Whitehall studies didn't differentiate controlled diabetes versus uncontrolled diabetes mellitus. Like Framingham heart study, Whitehall study, they didn't have a metrics to differentiate diabetes from controlled to uncontrolled. But later studies, when they included, they found very high risk odds ratio associating diabetes with stroke. So there is one study, which recent published study involving about 30,000 patients. They found as the HbA1c increased, the odds ratio, hazards ratio increased to as much as 8. And this is very high. It's almost causative. And if you put this in the Bradford-Hill's criteria of causation, everything fits. Strength of association, dose response, consistency, biological possibility. You know, diabetes is known to cause endothelial dysfunction, oxidative stress, and pro-thrombotic states. Because of these, we consider uncontrolled diabetes almost etiological, sufficient to cause stroke. And we see patients who have almost like a prothrombotic state. And in our settings, we don't investigate extensively when you have a patient comes with stroke with highly uncontrolled diabetes and a pattern of stroke which is concordant. We don't investigate them beyond the standard post investigation. Smoking. Now, smoking is considered a risk factor, but there are studies which show that as the intensity of smoking increases, the odds is as much as 21. So it is a wide odds range. So that the smoking increase has a clear dose response gradient. And again, he fits all the checklist of the Hill's criteria. Homocysteine. Now, homocysteine is found to be highly thrombogenic. If beyond 50 microgram, it can cause real floating thrombosis. And that's one thing which we see. Many other people don't see actually, because most people don't report it because they don't do imaging. They don't do proper vascular imaging. So they miss it. So, and the treatment of floating thrombus is entirely different. It's not antiplatelet. Antiplatelet won't work. Floating thrombus behave like cardiac clot. It just the artery, the pressure gradient pump, and then it embolizes. And if you don't properly treat it, they will have a recurrent strokes. So hyperhomocysteemia is highly prevalent in vegetarian or quasi-vegetarian population. Now, in Karnataka, we see that in Agam's thesis, although people claim they are non-vegetarian, their take of a non-vegetarian diet is very limited. So that actually, I call it quasi-vegetarian population. And especially when it's tied with alcoholism, it tilts the whole balance. So I'll just give a case illustration. This patient, young, I think 30s, came with a stroke in same territory. What do you see here? Anyone, our residents make it? You're noticing something? So when you look at our residents know this, we have to look at the angiography from the source imaging from aorta to up. This is the way you have to look at the arteries. This delineate the whole artery tree. You are looking at the aorta. Okay. You track the aorta up the artery tree. This is the way how you do. And the artery, you see the roundness of the vasculature. And here you see what? This is donut sign. And this is a floating thrombus. So now this it floats and then it's embolized. It behaves like a cardiac clot. So this is the initial scan, maximum intensity projection, the clot hanging around. And after MR angio is not able to visualize this. Okay, then after treatment, 2 weeks, it disappeared. What treatment we gave? We didn't give antiplatelets. We gave heparin. And now this is almost a standard practice. We give heparin for 2 weeks, and after that it disappears. And then patient is almost back. If homocysteine is corrected, it won't come. It won't recur. It's basically because there's one causation of the alcoholism causing hyperhomocystinemia. So essentially, our rate of unclassified stroke is as low as 5%, and our recurrence rate for the last 7 years is 1% per year. So that so we are able to delineate clinical entities like floating thrombus, focal cerebral angiography, another misclassified condition. Young patients coming with MCA narrowing and vessel wall imaging showing circumferential enhancement. Aplar syndrome. Aplar syndrome, unless you suspect and chase it, you won't pick it up. Aplar syndrome specifically affect the posterior circulation and anterior territory. This is what is the reason for that? We don't know. Some kind of a propensity is there, and uncharacterized autoimmune strokes. So you have to look into it. And you are able to do that only when you characterize the typical syndromes. And stroke classification is not an academic exercise. It provides clarity of clinical thinking, guides focused investigation, and directs appropriate secondary prevention. It significantly reduces recurrent stroke. It actually gives an understanding of what is a prototypal picture of a particular causative condition. And this understanding helps to characterize atypical causative mechanism, including novel causation. So 2 weeks back, my father-in-law was having CA prostate, and he was on, after surgery, he was put on a particular androgen blocker agent. So this is almost 2-3 years back. He was having I saw him after 3 months, recurrent strokes, and recurrent he was not able, almost stooping. And then I found it's unusual. He had stroke about 20 years back, and then he's absolutely healthy. But I was looking at that particular literature, and they reported that this particular drug causes endothelial dysfunction and cost press. But then this is unusual kind of strokes coming up, absolutely stable vascular risk factor. I told the oncologist that we particularly stop this drug, and he didn't have recurrence for almost 2 years. Then when he came this time, the oncologist told the PSA is rising, you have to restart it. I will give another drug which won't cross blood-brain barrier. So he was given drug. Second day he had stroke. Dysarthria, next day posterior circulation stroke. I just again looked at actually the same kind of drug. It's an analog. Stopped, again improved. So this kind of this is the first reporting should be reported actually. Actually what happened is that when you do clinical trials, they consider this as stroke because prostatic carcinoma happens in elderly. They consider it a part of a elderly. So unless you have known the prototypal presentation, whole classification gives clarity of thought. So when you see patient, you have to try to classify it and see whether the risk factors are commensurate to the etiology. So then only you can just pick up atypical presentations. So it's a very important thing. It helps in patients. It reduces risk factor, recurrence of stroke. So it's an important exercise to do. Thank you. Any questions on this? Any questions on me? Yeah, okay. I think, okay. Sorry, sir. Yes, I come.
Thank you, sir. Next speaker for today's is Dr. Nishant sir, who will speak on diagnosis and treatment of SAH.
Good evening, everyone. So throughout the day, you might have heard more about ischemic strokes, classification, treatment, so on and so forth. But I'll take you on a different type of stroke, which is more devastating. And if not treated, it can be life-threatening. And timely intervention is absolutely important in such strokes. And most of these strokes are managed by neurosurgeons. So good evening. I'll start about, I'll be presenting on aneurysmal subarachnoid hemorrhages. As though it feels like it's just any hemorrhage, the condition is life-threatening, and if not treated in time, it can lead to severe mortality and severe morbidity, which can easily be addressed by timely and adequate treatment. So if you generally see the incidence of subarachnoid hemorrhage, it's most commonly caused by a traumatic brain injury. And if you see any other patient who has any head injury can have a subarachnoid hemorrhage. So the treatment of which is not related to what I'm presenting today. Like I'll be presenting mainly on non-traumatic subarachnoid hemorrhages, the most common of which is aneurysmal rupture. So there are other causes of non-traumatic subarachnoid hemorrhages, like the rupture of AVMs, fistulas, venous thrombosis, which is we see quite commonly, vasculitis, coagulopathy, drug abuse is another common cause, and hypertensive crisis. So what is aneurysm? Brain aneurysm is a focal outpoaching of an arterial wall. It can happen in two different ways, which is a saccular type, which is easily treatable by surgery, as well as endovascularly, and a fusiform type, which can be caused by different causes, and the treatment also varies depending on the cause. So epidemiology as such, it's quite prevalent. It's 1 to 6% is quite a lot. Though you may or may not have met people with aneurysmal subarachnoid hemorrhage, like if you see a tertiary or quaternary center, we will have OPD full of patients with subarachnoid hemorrhage. That at least tells that the severity of the problem in the society as such. If you see patients who have incidental aneurysm, about 20 to 30% can rupture. It is around 3 to 4% in India, but it is very high in specific countries like Japan and Finland, very well documented, and the treatment paradigms of such problems like aneurysm, subarachnoid hemorrhage, we gain more from studies in those countries as well. Risk for aneurysmal formation, like more the age, like we commonly see patients who have subarachnoid hemorrhage more than 40 years, female gender, hypertension, smoking, and genetic factors. Though even for patients who have unruptured hemorrhage or even ruptured hemorrhage, we classify patients who have hypertension, smoking, and who are female have high incidence of re-rupture as well. Natural history, it's very devastating when a patient has a subarachnoid hemorrhage. It is known that more than 10% of people don't even reach medical attention. And though it is a quite older data, it is generally told that up to 50% don't make it within a month. But with effective treatment, it's not the same even in the recent past. And only 1/3 of survivors have a good result. I disagree with this, like because in the present day of age and management, I think aneurysm subarachnoid hemorrhage have a better outcome compared to what it was earlier. The more common aneurysm happen in the anterior circulation, about 80 to 85%. More commonly in, sorry? Okay. It's not charging. I have a charger. It takes you. Anybody has a Mac charger? Yeah. Sorry. I think it's charging. It's charging now. Okay. Yeah, it's happening now. So the anterior circulation aneurysms are the most common. They occur more frequently, and it is up to 80% to 85%. The posterior circulation aneurysm are somewhere between 10 to 15% more commonly basilar artery. Even in the anterior circulation aneurysms, the internal carotid artery and ACA complex, more commonly it's happening in anterior communication area. Anterior communicating artery aneurysms are more common, up to 30%. So what happens when a patient develops subarachnoid hemorrhage? So basically, the blood vessel inside a brain opens up. When there is a the blood vessel opens up, the blood rapidly outpours into the intracranial cavity. So what happens is the ICP rapidly raises. As we all know, cerebral perfusion pressure is very important to maintain normal circulation of the regular brain. But when the mean arterial blood pressure equals to ICP, just imagine that there is a massive difference in mean arterial blood pressure and ICP. ICP is 10 to 15 and mean arterial pressure is almost 90 to 95. But when there is a equalization of these two chambers, what happens is ICP rapidly increases, cerebral perfusion pressure almost is knocked off. If it becomes zero, that means your brain doesn't have any brain circulation. That means it can have devastating consequences. What happens as soon as the aneurysm ruptures, there is a clot which is formed on the aneurysm rupture, and the patient is saved. The continuation of extravasation doesn't happen. The blood clot saves the patient from dying. So if that doesn't happen, as we told, like 10% of people who doesn't reach medical attention, those are the patients who the clot doesn't happen and they can die instantaneously. So it's an evolution of medical events which happens. Initially, there is an ictus. The patient present with a headache or loss of consciousness. And as soon as possible, within 24 hours to 48 hours, we have to manage it and block it so that it doesn't rupture again. So we have to either do clipping and coiling or aneurysms. And then there is a neuroinflammation phase where patient may have a lot of complications because of that. There may be patient may be having systemic problems, cardiac, chest. So many problems can happen. And there is a delayed vasospasm as well, which can happen up to 3 weeks. and then there is slow recovery of the patient. This is what happens in a patient who has acute subarachnoid hemorrhage. So it's very important to note that, for example, if a patient of subarachnoid hemorrhage goes to a lower center and they don't know what it is, or it is not diagnosed properly, they can have delayed in treatment. If there is a delay in treatment, as we know, there is a re-rupture has a very high mortality, and if it can be easily prevented by early diagnosis and proper referral pattern. In the present day, any patient who has a severe headache and features of subarachnoid hemorrhage, I think the knowledge of people who see those patients in the peripheral centers are good. We get a lot of patients early on. It was not the same in the past. So patient present with severe headache and nausea, vomiting, patient have neck rigidity, they can be in altered sensorium, they can have focal neurological deficits, and about 10 to 20% patient can have seizures as well. So it's very important to know that there is something called sentinel bleeds. So patients may have intermittent, may not be their severe headache, they may have headaches in the past, which is transient, which can happen again and again. They will tell that I had severe headache for a half a day and then I was okay. It happened like several times in the past 6 months. And after 6 months, patient might have a severe subarachnoid hemorrhage. It's called sentinel bleeds, and which can be, if you ask carefully, those patients who have acute subarachnoid hemorrhage, they come up with this history. So what are the clinical features? So patient may have so many localizing symptoms or signs. For example, third nerve palsy can be present in PCOM aneurysms, sixth nerve palsy if there is a basilar or SC aneurysms. Bilateral weakness of lower limbs can happen with if there is a rupture and especially if they have ischemia of the anterior communicating arteries. Aphasia if it is a MCA aneurysm on the left side, and MC aneurysm most commonly present with seizures as well. So there are several pitfalls which can be easily prevented in clinical diagnosis. These are warning headaches, which patient might have easily forgotten, or like patient might have not hidden much to. Failure to recognize that it can, like, I am repeatedly telling that these warning headaches improve spontaneously. Patient have headache and they will be normal next day, but these are severe and happen again and again. So though these are some red flag signs which the neurologist or the treating physician have to recognize early on. So there are differential diagnoses which can be similar, like viral syndrome, migraine, neck pain. Psychiatric disorders can also have, patient may come and tell that patient have sudden onset severe headache, which we have to carefully look at. So how do we assess these patients? Like most commonly, the clinical grading is by either Hunt and Hess scale, which we are not following much in the recent past, and we more often do a WFNS grading, which often correlates to the outcome. Why do we do grading? Because patient comes with a worst grade, have a worst outcome, whether you treat it or not. Even if you treat it, the patient has a worst WFNS grade or the worst GCS. This has GCS in its component. GCS is one of the very good indicator of long-term outcome. Like we can grade that, okay, if a patient has less than 12 GCS, we can tell that, okay, like you may have morbidity in a long term, even though whether we treat it or not. So how do we evaluate? We evaluate usually by a non-contrast CT if a patient has features of acute subarachnoid hemorrhage. It's very sensitive within 24 hours, up to 80% sensitive. If there is acute subarachnoid hemorrhage, we usually, at least in NIMHANS, we do CT angiogram or a DSA based on the location of the aneurysm. For example, if we have a doubt of anterior circulation aneurysm or a MC aneurysm, we do CT angiogram and go ahead and treat it. If we suspect a proximal IC aneurysm or a posterior circulation aneurysm, we often tend to do a DSA so that we can properly evaluate whether to treat by surgery or by coiling or intervention. So if much time has passed, CT is negative, we can resort to lumbar puncture. We do less often because most of the time we are able to pick up whether patient has a subarachnoid hemorrhage. And if the patient has features of subarachnoid hemorrhage and CT may not show, we are going ahead and doing CT angiogram, whatever it is. So whether we can do CT scan or lumbar puncture based on the timing in which patient comes, Intracranial aneurysm detection can happen either by DSA, CT angiogram. MRI is very less often used, and it has the least sensitivity to pick up the aneurysms. As I told you, the maximum sensitivity is within 24 hours. The sensitivity decreases to 30% after 2 weeks in CT scan. But you may know that especially ACOM aneurysm and MC aneurysms, the blood may disappear early, and if you don't look closely, you may miss a small subarachnoid hemorrhage somewhere, especially if a patient comes after like 5 days, 6 days. If you look closely, you can identify some small subarachnoid hemorrhage which is easily missed. So Fisher grading, we do Fisher grading to assess the grading of subarachnoid hemorrhage on the image, like a CT. Though it may not dictate what treatment we do, it tells about the degree of vasospasm or complication patients may have. So, for example, this has within less than 1 mm also, like we can pick up SAH. If it is the thick SH, more than 1 mm also can pick up, that is grade 3. Or if there is a hematoma or IVH, it is called grade 4 hematoma, grade 4 Fisher grade. So the patient may have hydrocephalus, intracerebral hematoma, brain edema, infarction. All these, like majority of these are not counted in Fisher grade, though it dictates outcome. So we cannot just tell solely on Fisher grade about how much vasospasm may happen. WFNS grade can tell outcome. So many other things dictate the outcome as well. So, for example, this patient has a basilar artery aneurysm and there is a hydrocephalus. Even patient may become CSF diversion dependent. For example, patient may require a shunt, or a patient may require an ETV or something later to make sure that hydrocephalus doesn't affect the outcome. ICH, we may have to resort to immediate surgery for evacuation of this as well. So pitfalls in CT diagnosis, like how we can miss it. Loss of sensitivity with increasing time. We may miss if the CT is done later, we may miss it. False negative results in small volume bleeding. For example, if there is a small volume in MCA, it can be easily missed. Interpretation, like not everybody is good in picking up SAH. Technical factors, like for example, peripheral scan is done in a periphery, the thickness. Now I'm very impressed that most of the periphery have very thin cut CT as well. But it can happen that in a periphery, thick cut CT scan is done and SH can be easily missed. Lumbar puncture, we don't often do lumbar puncture. Very rarely we do lumbar puncture to detect if any SH has happened. But it is very sensitive early on, and about 4 weeks, about 40% is sensitive. This is how we see xanthochromia in LP. Even LP is not foolproof. We may miss it. It all operator dependent. We may have a hemorrhagic tap, and we have to distinguish properly. It's very important to diagnose SAH so that it has a high stake in patients' morbidity and mortality. So DSA is considered a gold standard, though it has a lot of morbidity associated with it. For example, if a patient who has doubtful previous acute subarachnoid hemorrhage, whether you would go ahead and do DSA, I would not agree with that. Like, for example, some patients who have doubt of SAH in the past, we may go ahead and do CT angiogram first, and whether to treat it or not, we will decide it later. See, these are two examples. One is an MC aneurysm, and the next panel shows a ACOM aneurysm directed downwards, which is easily pickable in a DSA. So this is a proximal IC aneurysm, which is close to the what we call as ACP, anterior clinoid process, which is very important in differentiating whether it can be easily clipped or it is slightly difficult to clip. For example, if a patient who has paraclinoid aneurysm, we may take more time to drill the ACP, and we may have to prepare neck control, something like that. So the time duration and the complexity of surgery depends on where exactly in the ICA the aneurysm is located. So this is a 3D rotational angiogram, which very clearly shows a narrow neck and an aneurysm, which helps us to plan our management. CT angiogram is sensitive, more than 95% if they're present day CT angiograms, and you can get very nice pictures. And especially for neurosurgeons, we want, especially in the IC aneurysms, we want the relationship with bones and the how much distance is it from the anterior clinoid process and stuff, and it helps us a lot during surgical management. MRA, like we hardly do MRA for detection of aneurysms or in planning of management. Angio negative SH, what about if you have an SH but angio negative? It can happen. We very often see 1 in 5 cases, we get 1 in at least 5 to 7 cases, we get CT negative and angiogram negative SAHs. More commonly, it is because it happens in cases where there is typically a prepontine and perimesencephalic SAHs. There are a lot of debates about whether if there is a perimesencephalic SAH and DSA is negative, should we repeat the angiogram or not? We don't do it if it is a perimesencephalic SAH. More commonly, it is venous bleeding, which may not be because of aneurysm rupture. If there is an SAH not in a perimesencephalic area, we usually repeat DSA approximately 3 to 6 weeks later, because vasospasm, hypoperfusion, and thrombosis can also deter us from detecting an aneurysm. So as I already told you, perimesencephalic bleed can happen because of venous hemorrhage. So we need not go on repeating angiograms. Like we do an angiogram if it is negative. We often come to an idea telling that, okay, this is perimesencephalic cases, we need not do it. But there is a differential diagnosis of basilar artery aneurysm, which we have to be careful of. Initial management, like our resident may have a standard a checklist: shift to P1, no IM injections, absolute bed rest, 30-degree elevation, analgesic SOS, sedation if required, if patient is not neurologically stable. All these things are standard. Patient has to be managed in a calm, dully lit room. We don't tend to do too many procedures. We don't tend to do too many injections, because it can cause re-rupture, because elevation of blood pressure has been proven to increase the blood pressure and cause the re-ruptures. We do hourly neurochecks, more than hourly neurochecks, strict output-input monitoring, BP, oxygenation, seizure prophylaxis we regularly do, stool softeners, and nimodipine we start as soon as the patient comes. So investigation, like all the regular investigations we do, and specifically what are the problems associated with subarachnoid hemorrhage, specifically in the initial part, as some are in later part, is rebleeding. Like we know that rebleeding can happen, very high rebleeding rates in the initial day, and vasospasm, hydrocephalus, hypotonia. I will go through all these things. What about rebleeding? It is very disastrous. Like, patient is here, we could have treated in front of you, patient has rebleed. It's like it feels very bad, and you could have saved that patient many times. Patient has very severe risk of morbidity and mortality. So as soon as we see and as soon as we get an opportunity to treat that patient, we have to treat this patient. Like we now in the recent past, we equate treatment of extradural hematoma and subarachnoid hemorrhage as the same. How we see an extradural hematoma, we quickly take up to the OT. Like subarachnoid hemorrhage has to be seen, aneurysm subarachnoid hemorrhage, we see it at the same like that. So rebleed happens in the first 24 hours. It's reported as 4 to 6%. And over time, approximately around 6 months, if you don't treat it, about 50% have rebleeding. Vasospasm can happen in the initial part, and the peak of vasospasm is in the first week, for example, 6 to 8 days. What happens? Vasospasm can cause ischemic complications, delayed neurological deficits, confusion, irritability, fever, and we do angiogram to detect vasospasm and treat it. How do we investigate vasospasm? So first we rule out other causes of these features, like obtundation, whether patient has hyponatremia, hypoglycemia, all these things. And then if all these are normal, we usually tend that it may be vasospasm. We start treating. How do we treat? It should be euvolemia. Patient should not have fluid deficit. Patient should have euvolemia and induced hypertension. Earlier, we were treating with hypervolemia. Hypervolemia is more problematic. We don't do hypervolemia now. Euvolemia and hypertension is the dictum of treatment of clinical vasospasm. If there is hydrocephalus, we do EVD. If there is an IVH, there is a more chances of patient developing hydrocephalus later. And if there is a patient has raised ICP features, we put an external ventricular drain. So this is an example of patient who had subarachnoid hemorrhage and came with hydrocephalus, for which we had put an external ventricular drain. Seizures can happen up to 10 to 20% of people. And especially patients who have MCA aneurysms, thick ICH, rebleeding infarction have a higher propensity to have seizures. So these are the complications which can happen over time. So you can name it, you have it. Like there are 15 to 20 complications which can happen due to aneurysm rupture, from stunned myocardium till neurogenic pulmonary edema. Most of this can be devastating and life-threatening. It's not the acute subarachnoid hemorrhage. It's a systemic complication can happen. So many systemic complications can happen. So every now and then, every week, one case will be there who had a systemic complication and had a very bad outcome. So it needs an interdisciplinary cooperation, and especially a physician has to be around to make sure that patient is adequately treated for systemic complications as well. Cardiac complications is very common. Most of them have hypertension as well. ST segment elevation is seen almost in all patients who have severe subarachnoid hemorrhage. T wave changes, prominent U waves can happen. If there is a doubt that patient also may have MI, you may have to do an echo and 12-lead ECG to confirm. But these ECG changes consistently are present in most of patients with acute subarachnoid hemorrhage, especially in a severe degree. Stunned myocardium, this is a very devastating problem. It's a very severe form of cardiac injury. It can cause cardiogenic shock, pulmonary edema, and though if you can detect it and treat it very early, patient can be salvaged, and patient has to be treated soon so that they don't go into failure. If a patient goes to failure and develops other complications, it will be too late for that. Hyponatremia, very common, like 10 to 30% of patients have hyponatremia, especially if they have severe subarachnoid hemorrhage, hyponatremia chances are more. Pulmonary complication, as I told you, neurologic pulmonary edema can happen, especially in severe grade SH. Definitive treatment. What do we do with these patients with subarachnoid hemorrhage due to aneurysm? There are two ways in which you can treat these patients. Patient can undergo microsurgical clipping of the aneurysm. What we do, we do a craniotomy, expose the aneurysm, and clip the aneurysm so that it doesn't rupture again. It gives a surgeon 100% assurance that it may not rupture again. And another treatment modality is endovascular coiling. Endovascular coiling is like how we do DSA. The same angio suit, a coil is introduced inside the aneurysm so that it fills up the aneurysm, and the dead space inside the aneurysm is blocked, and over time we expect that thrombosis happens. So the general dictum, how we choose is a patient who is younger and easily approachable aneurysm, like anterior circulation aneurysm, we tend to clip because it can be permanent treatment and need of retreatment is very less. A patient who is old or patient is in a bad clinical status, and especially if the aneurysm is in the posterior circulation, we tend to go for coiling because the cardiac morbidity and morbidity because of the old age is less in coiling, as well as if the surgical morbidity is also less in case of surgical morbidity is more if we do open surgery for posterior circulation aneurysm. So this is how coiling happens. Like you can introduce a coil inside the aneurysm cavity, and you block it so that blood doesn't go inside that aneurysm sac. But what happens is there is something called as coil compaction. Over time, there is constant hitting of the pulsation to the coil, and the coil goes to one side and the aneurysm recurs. So long-term studies have shown that even posterior circulation, 20 to 30% aneurysms recur. So surgeons often choose clipping in a younger patient, especially in a anterior circulation aneurysm. This is a dark aneurysm, which is coiled. You can see that this aneurysm has been coiled and the coils are seen. Clipping, so this is how you expose the aneurysm and go to the neck of the aneurysm and clip it. So the surgeon will know that no residue is there, and we are very sure that it may not recur. So even for patient in younger or older, if aneurysm is clipped, we need not do repetitive investigations. For example, if a patient is coiled, we may have to do angiogram very often to detect whether recurrence has happened. If it is clipped, the chances of recurrence is so low that repeat investigations are not required. For patient with ruptured aneurysm, so technically amenable for coiling and clipping, endovascular coiling should be considered because most of the patients who are slightly older and patients who have severe subarachnoid hemorrhage usually undergo calling in the present era. Clipping is preferred if there is a wide neck, blebs, geometrically complex, and I can tell you that all aneurysm cannot be coiled. At least at least in our practice, at least 20 to 30% of the aneurysms, the interventional radiologist will tell that like there is high complication rate of coiling. So those patients come for clipping as well. Coiling is preferred, as I told you, in elderly, poor grade or aneurysms of the posterior circulation. So coiling and clipping, there are so many studies, especially the ISAT study, which have shown that early on, the surgical morbidity is higher than coiling morbidity. But over time, the recurrence rate of aneurysms are more in coiling than clipping. So it's a balance. So if you see an younger patient, easy to clip, you permanently treat, they are done for their life and they are treated. Older patient and the patient has a posterior circulation aneurysm, we tend to send them for coiling to avoid surgical morbidity. That's it. Like you say, especially if a patient who is younger than 50 to 60 and anterior circulation, clipping is the choice of treatment. So concluding, SAH is a neurosurgical emergency. It has to be treated as soon as possible to avoid mortality and morbidity. And you should have a high index of suspicion, and immediate investigation has to be done. Securing aneurysms early results in better outcome. So outcome depends on age, grade, CT grading, size of aneurysm, and severity of vasospasm. So all these things have to be taken care when you prognosticate. Thank you. So incidence of cardiac complications as such, they tell that it's around 5%. Most of them are may not require treatment. So for example, ST segment elevation, if you talk to a younger cardiologist, they tell that, okay, this has to be treated, we have to do something about it. So a seasoned cardiologist who has seen a lot of SH patients, he tell that, okay, this settles over time. So intervention required is very less. It's only in cases of stunned myocardium or there is a actual MI. But all these things happen. It's a problem, like because the heart has got a shock. Heart is affected definitely, but it may not require treatment. But if you suspect an MI, you do TOP T and all. So if there is a positivity, then only you will treat it. That is around 4 to 5%. Long-term myopathies happens only in if you have a stunned myocardium and then there is a long-term. All these trivial changes usually doesn't cause long-term cardiac complications. Thank you.
Thank you, sir, for that insightful presentation. Now we call Pritham sir to deliver the vote of thanks.
Good evening. It is my privilege to propose the vote of thanks at the conclusion of the CME. On behalf of Department of Neurology and the organizing committee, I extend my heartfelt gratitude to the director of the NIMANS, Dr. Prabha S. Chandra, for her continuous support to start this program and in her visionary leadership and support in promoting the academic program. We equally thank our Dean, Dr. Professor A. Nalini, for her guidance and support toward organizing this CME. Our sincere gratitude to Head of Department of Neurology and Neurosurgery for to start this CME and interdepartment collaboration of the interdepartment collaboration so that we can do the we have done the proper CME, which is including the neurology department and the neurosurgery department. I would like to thanks the SNF team for their enthusiastic support and the collaboration. I sincere thanks to Asian Trust for to provide the support to conduct this program. And special notes of appreciation to the neurology resident and the student medical MD resident who has come here to participate in the this conference and making this conference a successful one. And along with this, I would like to thank the speaker and the faculty who has come for the program and for their interesting discussions of the stroke-related cases. And finally, I would like to thank all those support staff from camera person to the technical team who with their support we conducted this program. And finally, I'd like to conclude based on this CME. Means at least we learned something basic about stroke. This is mainly for MD resident and the neurology resident who are like first, second year, who has to learn what and all to be done in a patient with stroke or CVT. We would like to, we wish you a safe journey home and look forward to meeting you again if any next academic program occurs. Thank you.
Tea has been served. Everyone can please move. This is a feedback form. You can scan the QR code and let us know what you thought about our CME.